Английский канал 1, 2, 3, 4, 5.
слушайте. Раз. Раз, два, три. 1, 2, 3, 4, 5. Раз. Это же флешка. А что, какая просто подключись? Алло. Дарьян, срочно подойди, у нас тут проблема со звуком. Как помнишь, когда? Задержка.
Скажите, вот сейчас 5 докладов все есть?
Микрофон выключи, пожалуйста. Красный, чтобы не горит. Раз. Раз. Раз, два.
Сохрани и заново открой подкаст. И все. Он сам не будет перезагружать. Задержка на...
Сейчас остановлю стрим.
Стрим. А, нет, подожди.
Остановил уже. Все.
Мы в эфире же.
И что, ничего страшного. Пока мы в Ютубе не завершим, ничего не будет. А, блин, еще NDI же у нас.
Угу.
Собака.
Делай, стоп.
Хорошо. А.
Говори. А я в ту не попаду, да?
Нет, это отдельная секция.
Отдельно, да? По-нашему доброе утро. Доброе утро. Сейчас уже через 7 минут наша встреча. Это Ласко.
Да, здравствуйте. Подождите, пожалуйста, сейчас мы настроим последние настройки.
Мне пока
Спасибо.
выключится. Пока
Да,
выключится.
пока можете выключить микрофон. Ага. Спасибо. Раз. Раз, два, три. Все. Раз, два, три. Федор Леонидович, вы слышите?
Да, слышу и могу отвечать, да.
Отлично, спасибо большое. Вы можете уже включить камеру.
Включаю. Угу.
Отлично. Ага. Так, смотрите, у нас эфир через 5 минут. Мы выведем вас. Вы видите, вот баннер висит среди видео,
Да?
баннер висит. Ага, вот там это прямой эфир. Это картинка прямого эфира. То есть, когда вы увидите, что вы там в прямом эфире, вы можете начинать тоже говорить. То есть, ну, у нас модератор будет Ярик Анатович говорить, и вы вместе с ним можете.
Да, мы сейчас с ним что-то еще для вопросов сделаем там. Сейчас подумаем.
Все. В принципе, он вас сейчас слышит, вы можете ему что-нибудь сказать. У нас Ерик Анатович на связи.
Ерик Анатович.
Микрофон включайте.
Здравствуйте, Федор Ленич.
Да, приветствую.
Приветствую.
Давайте мы сейчас предложим докладчикам, ну, если там 15 минут 13 бы доложить, вопросы зададим, чтобы было поживее. А то у нас такой сухой всегда вот этот онлайн идет. Никто же не задаст вопрос из зала, только мы с вами можем.
Давайте.
Потому что дискуссия 5 минут, потом все забывается по ходу дела. Ну, постараемся не выбиться из регламента.
Договорились.
У нас, значит, первые два докладчика, третий идет доклад, сын мой Максим будет докладывать.
Максим Федорович, да?
Ага, Максим Федорович, его тогда представите, ладно?
Хорошо. Максим Федорович, он тоже с Рудена будем представлять его?
Да, он ассистент нашей кафедры, вот он за мной, да.
Все хорошо. Здравствуйте.
У вас доклада не будет, да?
Нет, у меня второй доклад.
Второй, все.
Второй, да.
Тем более, ага. Тогда я вас представляю здесь.
Первый доклад это с Ташкента, Мураджон Нургашевич.
Вы тогда первого представьте, а я вас тогда представлю.
Все, договорились. Ну, наверное, вы начнете как поприветствуете.
Да.
Потом я, может быть, кое-что скажу. И потом вы уже предоставите слово. Я, наверное, предоставлю слово Мураджану Нургашевичу. Хорошо?
Хорошо.
Все, договорились.
А вы сейчас где находитесь сами?
Мы в Астане, в Институте травматологии.
В Астане, да? Ага.
Да.
География просто необыкновенная вообще.
Да.
Как так можно вот соединиться и так прям... вчера мне приходили сообщения, что где-то связь нарушалась, да? Трансляция нарушалась.
Это, знаете, как здесь вина может быть не только наша, где-то, знаете, не сети, вот эта сеть, вот это как его, сотовая сеть, где-то у нас тоже бывают проблемы, но это не только от организаторов зависит, но и от местных сетей, там, как люди подключаются.
Еще. У вас какая погода? У вас какая сейчас погода?
У нас вот сегодня снежок пошел первый день.
Да вы что?
Ну.
Южные страны и снег, с ума сойти.
Дождь, переходящий в снег. Ну, уже вот такая, как обычно в ноябре, что-то у нас в этом году рано.
Ну, кстати, и это может быть как раз. Ага. Да. Так, мне сейчас Макс вышел. Вот у меня зеленая есть, зеленая общая картинка. Ее зажечь или нет? Вот.
Это надо к ребятам.
Игорь, вы меня слышите? Игорь?
Ребят.
Да, я слышу.
Игорь, скажите, пожалуйста, у меня вот маленькая картинка.
Зеленая.
Рекламная, зеленая, да, зеленая.
Да.
Мне ее зажечь?
Зачем?
Нет, не надо, да?
Не надо.
Не
вы
надо.
сейчас там в этой картинке появится Ерик Ирисметович, получается. И потом вы будете вместе разговаривать. Потом, когда вы запустите свою трансляцию, вы вообще ничего видеть не будете. Да,
это уже второй вопрос. А сейчас трансляция пойдет вот именно этой зеленой картинки, да?
Да.
В ней будет, ага.
Чтобы здесь видели, да.
Чтобы... Она у меня просто маленькая, как...
Ну, нажмите на нее 2 раза, она встанет большой.
Понял, вот я поэтому...
Да. Ага, вот, и смотрите, эта картинка мы просто в Zoom отдаем, чтобы вы понимали, что примерно идет в прямой эфир. А прямой эфир идет на платформе. Не здесь, а на платформе. То есть люди подключаются на платформу и смотрят там.
Но у меня вот эта картинка зеленая, большой сейчас не стала. Я 2 раза кликнул.
Ага, у вас какой вид в Zoom стоит? Галерея или докладчик? Сделайте вид докладчика и 2 раза на нее кликните.
Ага, понял. Докладчика, да? Сейчас Макс у меня придет.
Ага, вот, да, ему скажете, вид докладчика сделайте, в правом верхнем углу у вас там кнопочка есть.
Ага, Максик, мне сделай, пожалуйста, вид докладчика.
Да, и 2 раза на эту зеленую кликните, когда у вас будет
хорошо. Сейчас, вид докладчика. Я тебе сказал, но уже забыл, что это такое.
Нет, смотри.
Вид докладчика. Сказали, надо переделать. У нас вид не конференция, а вид докладчика надо. Вот вид.
Вид докладчика.
Сейчас, Игорь, еще раз. Вид кого надо сделать? Я тебе только сейчас говорю.
Делайте вид докладчика и 2 раза на вот эту зеленую.
Вот сюда на зеленую.
На юзер 2 раза, да?
Нет, где Игорь техподдержка. Вот зеленая, где у вас идет, видите?
Она у нас улетела.
А у нас идет зеленая, где юзер.
Да, была зеленая, потом перестала. стала юзер.
Ага, нет. Вот смотрите. У вас, когда тогда сделайте вид галереи и 2 раза кликните на нее. Вид галереи сделайте и 2 раза на зеленую кликните.
Не получается, вот 2 раза на зеленую.
Так, сейчас
Ну,
выбрать.
просто тогда там 3 точки
Пошло.
есть.
Попробуйте.
Все?
Да?
Ага, отлично. Смотрите, у нас 10 секунд до эфира, поэтому будьте наготове. Да, и свет вообще нет, что ли? Так, а что делать? Может быть, тогда вы первый выступите?
Ну, мы сейчас начнем этот, как его? Начнем, да. Если что, мы перестроимся.
Все, хорошо, пока что микрофон выключите, пожалуйста.
Угу.
Hello, dear colleagues. Good day. Let me start today's program. It is the morning session. I cannot say good morning because the geography is so wide that it may be early morning somewhere, it may be afternoon somewhere. This is our second day. Yesterday I talked to the moderators. Very interesting reports were presented to you. 100% of reporters, almost 100%, provided their presentation. Notwithstanding any technical problems, I hope that today we will be able to work as fruitful as yesterday. Our co-moderator of today's morning session is Fedor Leonidovich, Doctor of Sciences. I think Fedor Leonidovich does not need to be introduced. Please, the floor is yours. Thank you very much for your invitation. Although our life has changed significantly, but this an ordinary meeting with such a distance, it is amazing. I would like to make a proposal from the very beginning to have a live conversation. Let us try to make a report in 13 minutes and we will ask a question because no one can ask a question from the audience. What kind of flags do you have on your table? This is our geography, it is so wide. You can see only half of the flags. We have another half of the flags of our reporters of our geography in the conference, all the countries. This is the first time in our history, in our modern history, we have in parallel a conference of the young scientists who, in analog to Elizarov readings, are called Batpenovsky readings. They have been arranged by the foundation named after Batpenov. This conference on the second channel, if something is interesting for you, you can switch different channels to see both conferences. This will be a bright event in our calendar. In the next year, if you have some ideas and if you wish to speak, this conference is held within the conference of the young scientists. You are welcome. We'll be happy to welcome you at the conference. This is our first experience this year, and we hope that we will continue this experience in the future. So if our first speaker is ready, probably we can proceed and follow the agenda. Yes, we have international conference. We should stick to the agenda. Yes, surgical treatment of partial ruptures of ACL. We have a force majeure. Our first speaker is delaying a little bit. Maybe I will be the first to speak. Okay, we can start with your report, no problem. Can I start? Good day, dear colleagues. Let me congratulate you to our 20th anniversary of the Institute of Traumatology. Before the last year, it was a Scientific and Research Institute of Traumatology, but last year the Institute was assigned the status of the National Scientific Center by Batpenova. Today's report we devote to the arthroscopic restoration of the knee meniscus. We have 3 reports on this topic today. We want to see from different sides on this topic. We would like to talk specifically about damages of such quite rare earlier, but not rare now, quite common damage of the posterior meniscus. We have 50 beds for about 1,800 patients. So damage of the meniscus root, this is a pathological condition which results in an extrusion of the meniscus and significant violation of the load and osteoarthrosis. This is how arthroscopy looks like. I think this is not a new picture for you. You meet it every day in your practice. We can omit this slide. We know the importance of the meniscus distribution. Damage of the meniscus root is equal to the total resection of the meniscus. The biomechanics is broken in such a way. This slide demonstrates dynamic of changes during the year without surgery. Earlier, it was a rare pathology, but now our experience shows that about 15% of operations on the meniscus, in 15% we meet this kind of damage, lesion. This is an anatomical classification. Also, we stick to the clinical classification of this posteromedial damage of the posterior meniscal, menial meniscal after 50 years, and posterolateral, this is traumatic damage of the meniscus in young people who have damage of ACL. This is a classical slide which shows MRI images. You can see the symptoms of the gap. In such case, it is already late to restore the meniscus. We need to see the initial compartment of the bone meniscus only in the narrow swelling. What methods of treatment do we know? Conservative partial meniscectomy and restoration of the meniscus. We will talk about all of them in detail. Conservative treatment is considered to be unsatisfactory because 90%, 1/3 of in 5 years, they have to replace the joint. There are no indications for meniscectomy. You can see our clinical case. We have made resection of the meniscus in this picture, in this clinical case. We will discuss it later again. We compared results after the partial meniscectomy and root restoration, because there is no doubt that restoration of the root demonstrated the best results. This is the material, staff, resources, what we need. This is a classical set, Scorpio, titanium guide, etc. We have set the arthroscopy set for the shoulder joint. This is a little bit about the technique. We are working on the cartilage in the part of the adhesion of the meniscus in the posterior part of the meniscus is sutured using special tool, meniscal Scorpio. Then we make this seam. We use the mattress seams, which are more reliable. And we need the tools from the shoulder set to make different manipulations with the needles and sutures, not to have confusion with the sutures. It makes the operation a little bit more complicated, but makes higher quality of the suture. Then we form the canal using the reverse drill. Diameter is 6 millimeters. The sutures are brought into the tunnel and then fixed with the titanium pin or button. We use the button with the anchor with the button, but we think the button is a little bit more reliable. We can dose the degree of the tension of the suture, and these are the results we are going to get after the surgery. I would like to introduce to you several cases. Here is the damage of the ACL with the broken posterior root of the meniscus. We have managed to make surgery not in the chronic stage, but in the acute stage. This is a positive moment. We have sutured the meniscus, we formed the tunnel, we fixed the exterior meniscus. Now we can see how we have managed to do that like this. Then we made plastic of the anterior seal. Then we have sutured using the same titanium bottom, made additional fixation. I would like to show you another clinical case for you. This is our female patient, 3 MRIs of one patient immediately after the beginning of the complaints. Initial MRI, then in 3 months, and then in 1.5 years. Let's see the dynamics and assess what is the negative effect of this condition on the cartilage. You see the initial picture on the first, the initial swelling, and then we see classical cliff symptom. Of the case, we see how arthrosis is developing 1.5 years. This is too fast, in fact. And now correlation between MRI and arthroscopy of the knee joint, 1 month between them. We took that patient due to her young age. This is her MRI on the left-hand side. Please look at the MRI. You will see a sort of bridge between the meniscus and the place on fixation, but it does not work functionally. You have to make restoration. In this patient, we made revision. In patients, we make MCL lengthening. We extend the medial collateral ligament. This is quite an easy manipulation with low intervention, which reduces manipulation, especially in the posterior sections or compartments. Using a needle, we copy the medial collateral ligament. We penetrate the medial collateral ligament as a pie, and it increases the space in the posterior compartments. We use this method not only in the suture of the back horn, but also it allows to preserve the cartilage without damaging. It allows us not only to improve the visualization, but also the prerequisites for mobilization. We make mesenchymal stimulation suture. Here again, you see that we use the tool from the shoulder set. This is approximately how we restore the lip in case of damage of the bankas. Now we have stopped on the node version because it allows us controlling the tension, and using the normal standard technology technique, we have used the suture with mattress seams. It was interesting what happened, and we made MRI after the OR. We saw that we have made some centralization. We can see very promising results, very good results. Now you will see the axial image demonstrating the centralization of the meniscus. The next clinical example, I showed it before. This is a patient, female patient after resection of the meniscus. You can see we are making mesenchymal stimulation and mobilization of the meniscus. Please pay attention to the meniscus extrusion. This is a young patient. We tried to save the meniscus. We made centralization of the meniscus using the node anchor. You see it's here, and now you can see how it works. This anchor is working. It allows centralizing the meniscus, and then we sutured the back posterior horn. The next patient, quite frequently we see such a picture, damage, lesion of the posterior root of the exterior meniscus, and lesion of the ACL of the posterior part, we use meniscal scarpio to make the suture, made transtibial channel, and use the suture. This is how we did that of the exterior meniscus and made a single cord plastic. In the post-operation period, we use the stimulation methods, which allow us affecting the zone of surgery and the cartilage itself, because usually we have some chondromalacia as a foundation. Therefore, posterior medial or degenerative are met mostly in the medial meniscus and postlateral in the adolescent and the young patients. Restoration of posterior medial allows to centralize the meniscus to improve the condition of the cartilage. MCL lengthening we use not only to improve visualization, but we think it allows to facilitate visualization and centralization. Restoration of posterior allows to stabilize the cartilage with the joint. Thank you very much. We have lost some time because of the welcome address, but still I have some questions. So the drilling was with the reverse drill diameter 6 millimeters. Isn't it too much? Too much, you think? So we follow the recommendation of providers of this technology, and others recommend 6 millimeters and the depth. But what do you feel? Do you want to make it wider? Maybe, possibly, if we had this accessible. This is about accessibility. Now we have lip cut 6 millimeters. This is the minimum. But keeping in mind your remark, we will study this issue and we will decide. If we meet, I will make a present to you. Did you use the tape with the suture? Okay, it is very sound suture, but it makes the operation a little bit longer. No, we didn't use the tape, but I think that currently, if you have no tape, we can present it to you as well when we meet. Okay, thank you. And what I liked, the age, maximum age is 72 years. Do you really make suture for such patients, fixed it for such patients? Our approach is not to look at the passport of the patient. The patient comes and demonstrates a very good condition of the cartilage, and in this condition, we try to convince the patient to have the surgery because the condition of the cartilage decides. Wow. Cool. We have never had a patient like this before. We will keep this in mind. We had a lot of patients like this, and some time ago, it was a special term introduced, like calm epidemic or quiet epidemic. We are evidencing this kind of thing in the young specialists when we started work. It's like paranoia. Any lesion, we had to check if there is a root every time, but in recent times we have so many patients. If you pay attention to that, you can see the roots. Well, thank you so much. Maybe now the first reporter is online. Okay, he is ready. So the next report will be represented by Mr. Irismetov from Uzbekistan. The floor is yours.
Hello. Dear Chairman, dear members, dear participants, I couldn't connect on time. I'm sorry. My presentation is about the partial tears of the ACL. The ACL consists of the anteromedial and they have different functions. So the cruciate ligament have different location, different position, and with 90 degrees folding, it has maximum strain, and at the posterior lateral, it relaxes. Both bundles with the ACL tears, the traumatologists and orthopedists are paying attention to this, treating this as the intact bundle of the ACL. And in many cases, conservative treatment is used from both bundles. Both bundles provide the sagittal stability of the knee, and posterior lateral bundle is responsible for the knee stability. As we know, the AM bundle has high energy trauma tears. There is the moving sliding box symptom, and the PL bundle has rotational mechanism of the knee. The clinics is poor. It's sometimes not reaching the 3rd degree. We mentioned partial tears. As to the stability, the instability is not more than 5 millimeters, such as the malalignment. It's perceived as rotational instability, and when the PL bundle is teared, it's the rotational instability of the knee. Look at the right part of our diagram. When we suspect partial tear, we recommend to our patients to do sagittal cut. For this program, we have patented this program. From this MRI, you can see that not all MRIs have to be interpreted. If we see the intact ACL, we should not always treat this as intact ACL, but we need to look all MRIs. At the subsequent MRIs, we see partial tear, and this can be interpreted as intact bundle. In these cases, we do post-sagittal cuts, which provides information on partial tears of ACL. And we can find here partial tears with a scanning step of 0.7 millimeters, and we can see that well. At this section, we see that intact bundle has to be interpreted as intact bundle, and the damaged part is the tear of ACL. Peeling the femoral tunnel, we augment ACL, thoroughly preserving intact ACL and restoring damaged bundle of ACL. And this here you can see the PCL removed, the PL removed, preserving intact bundle. Mostly the soccer players and the athletes that do not have instability of their knee to function in their sports. Mostly these patients address us. So this channel is being drilled in the femur. And mostly we do transplantation of the lower muscles tendons. Next stage of the operation, we do transplantation of the PL, posterior lateral bundle, and inserting autotransplantant. In this case, one tendon is enough, and we are using the tendon of this muscle. So we should be careful about the intact bundle during the ACL augmentation. And inserting autotransplantant, the PL is at the bottom, AL is on top. So drilling this tunnel, the AL and then PL, preserving the intact bundle, as I said. This is post-operative results. The AL is intact, and here PL is intact. So what is the advantage of ACL augmentation during partial ACL tear? There is vessel factor, preserving the bundle. Also, there is a biomechanical factor. When the intact bundle is a carcass, and it limits its load on autotransplantant during post-operative period. The MRI results, preoperative partial tear of ACL, damaged bundle, an intact bundle on the next image, which is confirmed in the lateral section. The white arrow shows intact bundle. Post-operative results, autotransplantant inserted, and there is intact bundle shown. 28 surgeries we had. Average results were not too little, 76 score, and post-operative, after 2 years, it has increased to 92 score. So we can make a conclusion that knee instability, especially for athletes, should be noted by traumatologists. MRI special projections and decreasing the step of MRI sections improves diagnostics. Preserving the intact bundle improves knee functionality. Thank you for your attention. Thank you. Let us, Ignatovich, do you have questions? I have a question, if I may. I also have 2 questions. Please go ahead. Eric Ignatovich, can you hear us? Yes, I can hear you. Tell us, please, what is your attitude towards ACL, towards anterior lateral ligament? What is your attitude? It's a good question because rotational stability is a big problem for athletes, and if necessary, the anterior lateral ligament has to be restored. But in our case, for partial tear, it was enough, but I'm positive about your question. So for partial tear, you never tried AL? ALL in our cases was not required. That's clear. Now there is a new trend of the sub-knee muscle tendon. Have you approached this? What's your attitude towards this attitude? There is a doctor from Yaroslavl who says that popliteal muscle we miss. Yes, you are right. The posterior lateral complex is important for the knee stability, and it's mostly damaged during the PCL. Yes, that's for heavy traumas when there is posterior lateral angle. But what about isolated? And let me even aggregate this question. The ACL and some instability of the popliteal tendon. Yes, we faced that problem. We had one patient who had a popliteal tendon damaged, the hamstring, and with his hamstring, we did nothing. I believe it's a new approach, and we need to restore it as well to provide for maximum stability of the knee. Yuri Kanatovich, what do you think about popliteal or hamstring? Yes, we haven't paid enough attention to this damaged. And when we see additional rotational stability, we still have some unclear issues here. So may I ask a couple of questions? Was it difficult to train radiologists to do special projections? Does it make the examination lengthier? Because we need to meet with radiologists. Was it difficult to train them how to do such special sections? And were not they reluctant? Some of the idea, when we face this problem, the most part of the idea came from them, because they offered to us to reduce the step of scanning, and they offered to us to reduce their sampling interval. So they were actually training us. So they're real friends of yours. If we talk about double bundle technology, the Freddy Four, the double bundle founder, has died last week. Have you done any double bundle restoration? Yes, we've done two-pitch plasty, and you gave the. We've done the arthroplasty for two-pitched approach. But as for the body tissues, we haven't done that. Our experience for the artificial tapes, but the stability, rotational stability was better than with the anterior bundle method. Freddy, for how old he was? What happened to him? Is it COVID? I didn't find the information. I saw this in post Ibrahimovic because he he saved his knee, so I didn't find information what was the cause of his death. Thank you for informing us. Then the next presenter, it's by Russian University for the Friendship of Peoples, Maxim Fedorovich.
Good morning, Yuri Kanatovich. Good morning, dear colleagues. It's 8:30 here. I know it's later with you, but we're all ready to work. And let me just launch my presentation. Can you see my presentation? Yes, we can. Please go ahead. Just one moment. I will just have a full screen view. There you go. Dear colleagues, please let me continue the discussion of the damages to the meniscus of the knee joint, and I would like to continue with my discussion and speaking about not only just the root, not only just about the anterior horn, but also about their combination. So speaking about the statistics, in 63 to 80% of cases, it is the lateral meniscus that is being damaged, and the most common combination, it is the posterior horn plus the body. 15 to 30% of cases, we have the damage to the lateral meniscus. In the interior horn of the lateral meniscus is damaged in 5 to 10% of cases. And the damage can be observed in 20% of cases in the population. It is mainly linked to the high density sport. Now, speaking about the reconstruction of the meniscus, we should look back at its anatomy. First of all, medial meniscus can be 40 to 45 millimeters. Its width is 27 millimeters. It is less mobile than the lateral one, and the posterior horn, together with the meniscus root, is added to the plateau of the tibia, and the body is joined with the coronal and collateral ligaments that are intertwined in the collateral ligament of the joint. Now, speaking about the anterior root, Berlet and Fowler developed a certain classification that includes 4 different types. We're not going to dwell too much into that, but we would like to mention that in 3% of cases, we have the intermeniscus ligament, and they can just connect to each other without the tibia. And now if we can look at this ligament, we will see that it can lead to some instability. Now, let us speak about a lateral meniscus. It is more round, it has more mobility, it can also move frontwards and backwards. It covers 60 to 70% of the lateral plateau of the tibia, which also distributes the weight bearing. And throughout the whole body, as you know, it is not connected to anything but behind. So posteriorly, it is connected with the posterior collateral ligament. It is also important to mention the ligaments, the epithelial ligaments that we mentioned earlier today already. Now let us talk about other types of damages. I'm not going to talk about these damages or injuries. I just want to say that any reconstruction of the meniscus depends on the type of the injury, and specifically it depends on the type. Now we need to look at the zone of the meniscus, and we might be working in the red zone or pink zone. Pink zone is number 2. You can see this anatomical presentation of meniscus, and the third zone, which is the white zone. And here we understand that even if technically it is possible to have a suture, it will not be sustainable because it will not survive here. Now let us talk about different injuries of meniscus, and we will move from the back to the front. The first type of injury is a root injury, just like Eric Kanatovich has mentioned and reported quite nicely. Root is the foundation. It is how the posterior horn of the meniscus is connected to the shin bone. And for the first time, it was Pagnani who described this anatomy. Now, if we talk more about the meniscus root, it is the structure that is least dislocated when we are bending our bones. It also leads to the osteoarthritis as well as the development of the osteochondral deficiency of the hip bone. As Erik Kanatovich has mentioned earlier, we have certain symptoms of the tear that can be observed at the MRI. I will skip through that. And also we have the Pagnelli classification. It has already been mentioned earlier today. It is more an anatomical one rather than a clinical one, but it tells us that any injury to the meniscus, specifically to its root, requires a surgical intervention because it leads to quite severe complications. Currently, how it is done, we have an arthroscopical suture that can rebuild the anatomy. And now more about our technique, about our method of the surgery. It is a bit different. We don't have the meniscus scorpion, the automatic one, like they were mentioned earlier. You can see here the extrusion of the meniscus. The meniscus is unstable, it is hypermobile, and using our grasper, we can dislocate it a little bit to the front, and we can see the zone that we need to fix. And we use the curette, the arthrotropic curette, and we need to see the cartilage in order to create the best conditions for the survival of the meniscus. Next, we need to understand how we need to drill the channel. After that, we use the drill, a 4mm drill, and we're always trying to use the thinner drills in our practice. And then we do not use the automatic surgery machines. We use the anatomical needle that has a thread. So it is quite a thick one, and then we pull the suture through in order to grab the root of the meniscus. In our practice, we're also using different ropes or tapes because they allow us to fix the meniscus for a longer period of time and also connected to the plateau of the shin bone. After that, once we have pulled this thread from behind, we also make an additional node, and then we pull this thread through the channel. Sometimes it can be damaged a little bit, so we need to make sure that it's working fine. And then you see that this fixation is a rather stable one and a sustainable one. For the fixation, we're using different buttons, and we do not use bandages. We have a mechanical stabilization. Erik Kanatovich has already mentioned that all these surgical interventions need a certain tool set. I'm going to skip that. Now, moving forward, I would like to talk more about the posterior horn as well as the body, meniscus body injury. At the MRI, we typically see oblique or lateral tears of the meniscus, and the major classification is the Stoller classification that we're using in our practice. You can see the first 2 degrees that require conservative treatment, but the degree 3rd A and 3rd B require surgical intervention. I would like to show you a clinical example. Again, you can see the posterior horn as well as the body tear. And following the classification of this Stoller, we see that it is located in a pink zone, and we use meniscus suture following the all-on-site technique. And in this case, we have used fast fix 360. We have applied 3 sutures, and before that, we have also used the brush pill in order to make sure that the surgical field is clear. Also, would like to mention that quite often we see the ramp injuries. This injury is usually located in the posterior horn, but actually it mainly covers this transition between the horn to the body. For the first time, it was Strobel who described it in 1988 as the peripheral pericapsular tear of the posterior horn, and it can be observed in 9 to 17% of cases of the ACL tear. It is not visualized among the standard reports, and it is hard to observe it during MRI. Now, MRI signs, we can see the translateral tear, and we can also see the fact that the shin bone can be swollen. Another classification has been developed. Again, I'm going to skip through it. It is an anatomical rather than a clinical one. And we're just saying that any meniscus injury, especially the proximal, is important because we need to keep the anatomy. One of the injuries is the meniscus injury along the whole of meniscus, along the whole joint. And if we look at the MRI, we will see that it has a certain symptom of the double posterior ligament. And this is the body of the meniscus that is located at the point of its location to the posterior ligament. Now I'm going to show you the arthroscopic picture. You can see that meniscus is unstable and it has quite a significant injury, which you can see right now. It is suture of the bucket handle type. We're using just a regular needle and micro perforation in order to avoid blood clots, and then we apply sutures following the type of outside-inside. And we try to apply the sutures as frequently as often. Again, if we're following the type of the bucket handle suture, and we used to apply the 3 sutures, now we're actually applying more sutures. Meniscus is now stable, and in order to fix the posterior horn, we follow the methods of the alongside, and we use fast fix 360. And this is what we see at the end. Quite often, we see the injuries of the anterior horn of the meniscus. It is usually lateral meniscus. And if we look at the MRI, we will see the diagnostics that the contour is not exact. You can see that we see the extrusion of the meniscus that happened due to the injury. Now let us look at the surgery. You see non-atomic reinsertion after amputation of the anterior horn of lateral meniscus. And now we are working on the field where the meniscus is joining the bone, and in the third picture you see that we use the grasper to grasp the horn. After that, we are including the anchor fixator. Usually we use the same ones as we have of other type of injuries. After that, we suture meniscus and we refix it in the fixation area. And this is what we get at the end. This is our functional result. Thank you very much for your attention. Thank you, Maxim Fedorovich. Tell us, please, Maxim. We all know that the ramp injuries don't belong to the height. They belong to hidden injuries. How often do you use posterior lateral approach? Well, in our practice, we do it in 30% of cases. But if we understand that we have certain signs of instability in this area, we always try to use this approach in order to avoid any additional injuries. Also, the role of the anterior ligament. We quite often see unstable ligaments among the anterior horns. It sometimes be in the way. In our case, it can lead to some complications, especially in the older age. Could you tell us about the role of this ligament? Well, it is one of the stabilizer intrameniscus, but it has lost its function somewhat, because if we look at the normal anatomy, then we're going to see that the root of the anterior horn usually attached to the shin bone, and it is a lesser stabilizer. But there are some cases, anatomical cases, when it becomes the major stabilizer. And we need to take that into account because, as I've mentioned in my presentation, if we can damage it retrospectively, then of course meniscus will be unstable, and we need to keep that in mind and avoid refixation. So we are looking at the joint, we see a stable anterior horn, but the ligament is unstable. It's very stringent. What do? We don't touch it at all. We only do it if we see instability of the anterior horn of meniscus, and we should differentiate it between that and the intermeniscus ligament damage. Thank you very much. Thank you. Fedor Leonidovich, please, the floor is yours. Give us the floor to the next speaker. So we're going to talk about the meniscal tear, and the speaker from Turkey.
Нет, лайв. Планируется лайв.
Здорово.
Сейчас ждем подключения. Но он на связи, да?
Интересно, который сейчас час в Турции?
Мне кажется, примерно как у вас должно быть, нет? Примерно как у вас.
Может, там глубокая ночь.
Следующий доклад из Питера тоже нет. Но у нас два последних докладчика, пока они не на связи. Если у вас есть что сказать, Федор Леонидович, организатор.
We have two speakers. They have not connected yet. Maybe you have some questions to discuss something probably. Please tell me, where is the main meeting held? In the institute, or yes, we have equipped the large conference hall for the everyday meetings. We have equipped this as a studio. We have improvised scene here. The reporters sit here. In front of me, we have IT specialists. On the right-hand side, I have simultaneous translators. And we don't have reporters here. Here we have only those who work here at the institute. They make reports from here. All other reporters, speakers, they connect from where it is convenient for them, at home, in the office, or wherever, on the way. Right, on the way. Yes, you have a big staff there with the technical support. Yes, we have 4 simultaneous translators, IT team. In parallel, we have another conference of young scientists. This is our second channel, our doctorants. I think only from Kazakhstan and from Russia. Yes, from Russia we also. Is Sergey Yuryevich with us? No, not yet. We are waiting for him. In 5 minutes, they say. I can suggest to make a break for 3 minutes. What do you think? Let us use this possibility to ask questions. To tell us about your institute, please. We have the institute. We celebrate our 20th anniversary. It was established by Nurlan Batpenova. This is the building of the former regional hospital that was a multidisciplinary hospital in 2001. According to the enactment of the government, the institute was arranged here. That was departments inherited from the regional hospital, and then in the course of reorganization, we opened new departments. Now we have 7 orthopedic departments. 3 departments are involved in arthroplasty of major joints. 2 departments are dealing with the spine surgery. There are departments heading the arthroscopy, orthopedic, pathology and deformation, false joints, and foot pathology departments. We have 5 traumatological departments, 1 multiple trauma department for concomitant trauma, hand department, acute pathology of spine. We have departments for traumatology 4, but it is dealing with complications mostly. And we have 1 more department without number. This is arthroscopy and sports trauma. Approximately like this. Do they sit in a different building? Yes, they sit in a different building, and the number was not assigned. Nurlan Batpenova, you know, he was working at the Central Institute of Traumatology for a long time, and many departments were copied, yes, copied by analogy. That was department trauma, orthoscopy, and other departments of surgery of foot and hand, polytrauma departments. That was the vision of Nurlan Mugulovich. You said that you have also Parliament department. Yes, we have. We have no common meetings due to the pandemic. We do not meet. We have only online meetings for the doctors on duty. They have a lot of patients, as far as I know, with the remote consequences of arthroplasty of major joints with osteomyelitis. Of course, today this is the only department which is accumulated patients from all over the Republic. Quite frequently, they use sanitary aviation to work on site. This is a very difficult work, a big department, overloaded all the time, mostly prevalent complications. I think the institute must have no problem to find place for your patients if there is any separative complication. Of course, not a problem if it is within the procedure of treatment. Can it handle all the patients? They take patients from all over the country. You say they are overloaded. So how they handle this? So they have sort of queue sort of turn. Usually these are planned assistance aids through the portal, consultative assistance, examination, approval of the date for hospitalization. These are for the planned cases. Since we have time, sorry for asking so many questions, but since we have time, you have the planned department for orthoscopy, for planned procedures, knee, shoulder, etc. Yes, we make blockages without waiting for the portal. If there is a block in the joint or there is a acute damage of the rotating cuff, we hospitalize the patients, so they come not with the ambulance machine, they come by themselves. Yes, we have a consulting clinic, and majority of the patients come from the polyclinic. Our city polyclinics see some indications for hospitalization. They refer the patients to our hospital, and all our specialists of the department have time for consulting. We have a call center for the patients to call us. Now everything is a little bit confused because our hospital is based on the institute. 100 beds were used for COVID hospital. Only 2 or 3 weeks now they are open. They are repaired now and under the sanitary cleaning. Now we have the department of the hand surgery, which was involved. Another one department was involved as well because we had too many patients. And now there is a fall down in the indications for COVID. And what is the situation with COVID in your country? We have news every week. Yes, I see another wave in Moscow, again, limitations and restrictions. Yes, that is why I have a question. We have the planned patients who come for examination for the paid consultation, advice, who are taken for hospitalization, and we have the vaccination as a must. In our case, vaccination is not a must, but we need to have the PCR test 3 days maximum. Do you check immunoglobulins? No, we look only at the PCR test. We periodically have some changes, but as of today, vaccination is free for access within 6 months. If the person was sick, then he can enter without restrictions for 6 months. But we check immunoglobulin should be more than 25. Now, as a recommendation, we do not recommend to hospitalize people above 65 for the plant. In 2006, we visited Moscow with our deputy director. As far as I remember, you were working in Zil's hospital. Always. Yeah, that was Zil hospital. It was transferred to the city in 2006. It was called City Hospital number 12. Zil was dying and was selling its assets, and this hospital was transferred to the city. It is named after academician Boyanov, and you are working on this basis. Yes, I am a patriot. I will die here. How many beds do you have in your department? How intensively you work? I think it will be interesting for our doctors because arthroscopy, yesterday we discussed. I think the next curve in development will be by the arthroscopy because we do it again and again. We have expansion of arthroscopy in the regions. They used to make some simple manipulations. Now they make reconstructions. And how is it going like at your place? Do you have any programs for teaching the newcomers? I think it would be interesting for our audience. Now we have traumatology department. We have about 55 beds. In one department, we can live in peace. We have emergency patients with different kinds of fractures, and we have planned arthroscopy. 1 OR is used for trauma, 1 OR for orthopedic. It's not enough, but we have very good conditions, very good blocks, units, modular blocks from Germany, very good equipment. I cannot tell you that we are doing so many arthroscopies quite frequently, much less than before, because trauma is replacing this. We have a part of quotas for arthroscopy, and for these quotas we can do whatever we want. Even if it sounds strange, the administration and Moscow government help us a lot, and they allow us to buy the balloons for the shoulders. Israel in space balloons. Every year we buy. Okay, we have a speaker, right? Okay, we buy them even with the expiration of the shelf life. We presented to our friends these balloons. So you have some implants, some innovations. How are they introduced? Because the treated cases do not cover any expensive implants, especially for the shoulder joints. It's a secret, but we have communism. They give us money against our responsibility to make the order for 150 quotas, but money is granted and no one calculates how much money we spend for each patient. For one patient, we might spend 15,000, for another one, 150,000. The main thing is that everything comes up properly to have better results. So you are satisfied. Yes, we can do whatever we want because we need so many fixators for the shoulders. And if we talk about Sergei Yurievich with supracapsular reconstruction, he has so many fixators that this would not be, we would not be able to handle that without presence. So what do we have with the presentation? Okay, then we will not wait for the report from Turkey, and Sergei Yurievich is coming. Please tell us, maybe have announcement of some of your events online or offline planned in the year's future. 2 weeks ago, we had resuscitation congress. It was live in a hotel with good, but all foreign presentations were online recorded actually. Only one report on our session was from Israel on osteotomy, and the rest was recorded, but it was so interesting. because why I asked about the knee joints, quite recently the emphasis is placed on that. Last year I was in Kazan and Ruslan Zaitsev showed how endoscopically to check the place of fixation to the pelvis, the exterior condyle. Yes, so many things have been done in arthroscopy and we have to learn all the time. He has extended the knee and using the arthroscope checked from upper side the exterior canal to see the meniscus. He saw the meniscus and the place of fixing the tender to the femoral part. We can identify this wide area with the leg position. I was so much excited and Dr. Hume Yaroslav showed instability. So this is the new curve in our development. This is a positive part of our work. Arthroscopy is developing all the time and not stationary. Every day we learn something new. We can see something new. This is the best thing in our specialty. What do we have with the next speaker, with Sergey Yurievich? They want to make some announcement. Let us make a break for 2-3 minutes. The IT guys insist on a technical pause break. Okay.
Федор Леонидович, мы сейчас ждем до Колин, когда подключится. У него проблемы, он в офис не может попасть. Сейчас он сказал буквально 2-3 минуты, он подключится.
So Dr. Dekolin is ready. Sergey Dekolin, please try to summarize your presentation in 10 minutes, because according to international rules, we have to stick to the schedule. So please show your presentation. Sergey Dekolin is a candidate of medical science, PhD, leading specialist of Scientific Research Institute of Traumatology and Orthopedics from St. Petersburg. Good morning, colleagues. I'm loading my presentation and ready to start. But Dr. Dekolin, you will be fined for being late. Well, it's just the start of the co-working, because it's a early morning in St. Petersburg. What is co-working? It's good internet and good connection. My presentation is about surgical treatment of patients with shoulder arthropathy. It's the unique arthrosis and arthritis for patients with massive rupture of rotator cuffs when two and more tendons are suffered, when the head of the shoulder bone goes upwards, and when the ligament is teared. It's very difficult to treat this. So we'd like to share our clinical experience of this type of patients. You can see here the structures, the rotator cuff structures that through the capsule centrate the head of the bone and to the cup, and provide for shoulder blades. Otherwise, the external muscles, they provide strain, and this was described in 1919 by Hamada, Dr. Hamada, when there is a cranial shoulder interval reduces less than 6 millimeters, HD, when there is the glenoid erosion, and facial changes occurs from the fourth to the third stage, where the vertical profile changes, and when head of the shoulder cannot be supported by soft tissues. Here you see fourth stage of arthropathy. So what do the patients suffer from? The shoulder is in pain, and the person do not have enough muscle strength to raise his arm, but he can do that with his healthy arm by helping his affected arm. So that's the pseudo palsy. At stages 1 and 3, when there are no joint changes, there are 4 stages of anchor reconstruction. There is the upper capsule restoring surgeries, which is quite active for the patients, as well as for the back muscles. It's very important. It's can be done by post-sagittal sections. You can ask the sagittal sections to be scanned for this section including latissimus dorsi. Here you can see the chronology of generative process of rotator cuffs when these muscles are affected. We face these tears with subscapular muscle, and most often we cannot replace this muscle. The anchor fixation has been described thoroughly and has reached its maximum development. It's single row, double row sutures, and edge-to-edge sutures. So here you see the technologies that we are using in our anchor fixation. It's a speed fix technology, double pulley, speed bridge technology, and rib stop. They have all been created by Dr. Buchard and are used in clinical practice due to their simplicity. And in the final variant, they have good clinical effectiveness. Most often, we use speed fix for the subscapular muscle and tendon. This is anchor fixation, where we prefer anchors with small number of material to perforate the head of the shoulder, and the bone tissue is restored, is saved, including humeral head. And so we're using the techniques which allows us to restore the cuff rotators on the footprint restoration. There is clinically no advantage of double row fixation. However, structural changes in the reconstructed rotator cuff are always better when you use double row suture bright technique. And that always is better when they are connected not to one point, but have 4 points of fixation and good footprint area. However, there are some higher re-tear rate due to the age of patients older than 60 years old and large tear size and fat filtration of cuff rotator. The anchor suture and surgical technology, you cannot suture tendon with a high strain, with the arm strained. That would lead to poor rehabilitation, and the tendon would tear off. So the patient would spend their money in vain and not getting the functional outcome. Here we are doing recision, and all the tendon edges, we resect the tissue between the joint part and the tendon at the posterior part, and that allows us to restore this place. So one tendon takes 2 anchor sutures. We are mostly using 4 anchor design to effectively manage such cases. You cannot connect the tendon to 1 or 2 anchors, and when there is a long continuity of gaps, we are using rib stop technology to. Sorry, you have 3 minutes left. With the damaged edge of the tendon, this is immobilization period takes 6 weeks with autoplasma injections, MRI control after 4 months, and returning back to work in 7 or 8 months after surgery. So using two-row anchor structures is most prospective, although those structures are quite stable. We cannot force the rehabilitation time for our patients. In our experience, we also use the arthroplasty, and we are removing the dorsalis muscles of the back, latissimus dorsi, and so we can offer to the colleagues this algorithm of selecting patients for such surgeries. We first select prospective patients for surgery, and if there are patients who have massive rupture of rotator cuffs, do not have symptomatics, do not have their functions impaired, those patients have to be dynamically absorbed by the orthopedic doctors. And we are looking their delta muscle, deltoids, and then we can do physical rehabilitation using neurosurgeon or neurologist, and sometimes we do arthrodesis of the shoulder joint. So we can use the implant. We are choosing this by X-ray and MRI imaging, and at the first and third stages of Hamada, we are looking at the muscle subscapular, and if it's 40% retained, then we can do the anchor suture. If it's less than 40% is restored at the upper part, we're using upper capsule. And for the patients with the deltoids and latissimus dorsi, we are transferring the latissimus dorsi tendon from the back, because we can use inversive endoprosthesis, which can help us in such situations. Using this treatment algorithm, in our experience, we have reduced the number of arthroplasty at Hamada 1 to 3, and that allowed us to reduce the number of bad outcomes and increase the number of good outcomes. Thank you so much for your attention. If there are any questions, I'm happy to take them. Thank you so much. We just have seconds left. We congratulate you with the Doctor of Science and getting your diploma. A short question from me. It's the simple introduction, but it's simple for masters. So if you're taking a year of your work, how many repetitive surgeries you have from your own patients, or you don't have them? Of course I have them, and the patients do come back to us. And just roughly, because you are an honest person, I believe that 20% are returning patients who come back for repetitive surgeries. So I'm talking about the massive ruptures of rotator cuffs. They have problems with biological tissues, and in many cases that end up with injections, physical rehabilitation, talking to patients, and situation can be improved. But sometimes there are repetitive ruptures of tissues with symptoms, and we have to do repetitive surgeries. And those patients, are they friendly, or are they, yes, of course they are not friendly. They have fatigue from this treatment. They think about infection, so they're stressed, and they are also worried by internet data. What about balloon plasty? What do you think about this? Balloon plasty is used as an option, and it's quite fair, and it's quite right. But I'm suspicious about this treatment method, so I would request Fedor Leonidovich to make written readings on the 28th of October. Perhaps I hope that he would share whether the balloonplasty does the work. I can talk about that unofficially. Thank you so much, and thank you, colleagues. Yuri Kanatovich, we have to end our section. In 3 minutes, the next section starts. So, as a guest, Fedor Leonidovich, from your experience, you can make a conclusion. Well, I'm thankful that in our most difficult time, we have heard something new and interesting. And there is always thought for discussion. I'm very happy that we have seen each other. We cannot touch each other, we cannot hug each other, but it's very well to see each other. So I'm thankful that you have talked about your institute in the polls, and I hope that sometime soon we will see each other there, because in the beginning of the year, one of the mayors have invited me for the shoulder joint surgery, but I invited him to Moscow, and then he asked how to do this abroad, and probably he went abroad for the surgery. Otherwise, we would meet in the surgery in the operation theater. So we have exhausted the agenda of our section. And Fedor Leonidovich, thank you so much. Dr. Lasko, we were very pleased to see you online and see you at the next conference, and goodbye.
Нет, красный горит. Красный это включен, да? Здравствуйте. Разрешите продолжить.
Good morning, dear colleagues. Let us continue our conference. We're starting a new session. Moderators are Mafak Hari Bari, but unfortunately he cannot join at the moment. He will join us a little bit later. I will continue by myself. My name is Mr. Mursalov. I'm a scientific expert with the National Center of Traumatology in Astana. Today's session will start with the general information about trauma surgery and why we need it, and then we will move on to more specific issues such as pelvic injuries, chest injuries, and others. Now I give the floor to the first speaker, Professor Vilmos Vesche. Why do we need trauma surgery? Please, the floor is yours. You need to unmute yourself, Professor. We cannot hear you.
Sorry, can you hear me now? Can you hear me now?
Yes, we can. Everything's great.
It's good. And you have my slides or not?
No slide.
Sorry.
No slide.
Здравствуйте, профессор Мафакарул Бари.
Good morning, Mr. Mafakaru Bari.
Hello.
My co-moderator. Yes, thank you.
Stefan, ich fange nicht zu meinem Vortrag. So. Ja. So I hope you can see my slides.
Oh no.
Can you answer, please? Can you see my slide?
I don't see you.
Вас хорошо слышно, но слайдов нет.
We cannot see your slide, but we can hear your voice.
You can't hear me.
Yes, I can hear your voice, but I don't see your slide.
Ah, sorry, but I have started with the projection. Is something coming or not?
No.
No. So I'm extremely sorry, but I can't do anything about because my possibilities are very limited to do from here something. I can see you, but
You share your screen.
Dear professor,
hello?
you should tap share your screen. Share screen. Yes, and then
Hello?
choose desktop.
Choose desktop.
Ja, also bist du über das Zoom-Meeting eingestiegen?
Nein. Ja, hallo?
Hello. Oh.
The green arrow.
Share screen. You shared your screen.
Ja, das ist nirgendwo.
We don't have it. Yes. Yeah, but it is not here anymore. And I am very sorry, but I think I can't have it anymore.
So Mr. Mursalov, we can start second one. He will talk later on. We're going to start the second presentation.
So shall I start?
So our next presenter is going to present the emergency room requirements, the Vienna experience. Stephen Frangel, you're ready?
I hope so. Can you hear me?
Yes, I can hear you, I can see you, but I don't see your slide.
We'll try to change that.
Okay.
Can you now see the slides? Is it
Yes,
working?
now it is visible.
That's good to know. So a warm welcome, good morning from Vienna. I'll report on the emergency room requirements, the Vienna experience. If you have any questions, please go ahead and ask after the presentation. If I'm too fast for the translator, please let me know also. So, it's not working to flip the slides. Now it's working. So if anybody who's polytraumatized or severely injured in the Vienna region or the region around it is found by emergency doctors, either by ambulance or by helicopter, they are brought to our emergency room at the Medical University in Vienna. That's the way it looks. I'll give you a quick tour around. You see with the linings, the alarm position where the severely traumatized patient is brought to, and you can see that there's a multi-slice CT scan and also the option of dealing with two patients at the same time if it's necessary, or more or less at the same time, with only a few minutes of delay. You also see right next to it with the window, the control room where we can observe all the developments and gather all the information that is found by the clinicians. We also have the possibility of administering all the standard drugs that you need, and we can perform intubation and ventilation if needed, conventional X-ray, as well as ultrasound examinations. So to sum all this up, the basic diagnostics consisting of anamnesis. If the patient is still able to talk to us, we talk to the patient, him or herself. We talk to the emergency doctor that brings the patient to us. So that's all the anamnestic background that we have to gather, the clinical findings, the fast scan if the ultrasound is performed, as well as X-ray, and vital parameters and laboratory findings that we also can gather right away in the emergency room. And as you can see here, and as will pop up on the right-hand side of the slide as well, multi-slice CT scan is of vital importance in modern polytraumatized and severely injured patients' care. So what are our indications for polytrauma complete body scans? We perform these polytrauma complete body CT scans if the anamnesis fits. So if we're faced with a fall from great heights, if we're faced with traffic accidents as pedestrians, accidents with high speed or ejection traumas, or explosions, or patients that got stamped or jammed. Injury pattern, injuries to the thorax, where we suspect lung injuries, we perform polytrauma CT scans. We're faced with an unstable pelvis if more than one long bone is affected, or if we have quite proximal amputations. Looking at the vital parameters that will guide us towards polytrauma CT scan, Glasgow Coma scale below 10, if the patient is brought to us already intubated, if the systolic blood pressure is below 80 millimeters of mercury, or if the breathing frequency is below 10 or above 29 per minute. Also, we look at the O2 saturation. If it's below 90%, we think about performing a polytrauma CT scan. So the workup of all those patients can be compared to a well-organized pit stop in the Formula One. So we have different professional backgrounds that have to work in an organized and proper way. So communication is extremely important to support and assist each other as the members of a different team, and gathering all the information together, swift and firm decision-making. So defined workflow essential, subordination under a common dynamic target. It can change according to the clinical development of the patient. In Vienna, we're very happy to have one chief executive who is actually making the decisions and is guiding the team, but of vital importance, that's why it's indicated here twice, communication of all the team members so that everybody knows what we're dealing with, why we're doing what we're doing. Communication, extremely important. So those are the basic members of our workup team. The senior trauma surgeon who is in charge in our shock room, working very closely together with the trauma surgeon who's taking care of diverse accesses and, most importantly, dealing with the clinical investigation and examination of the patients. Usually two anesthesiologists, one head anesthesiologist and one who's doing the drug therapy and the monitoring. If needed, there can be more anesthesiologists present. usually 2 nurses at least, who are doing documentation, samples of blood and other samples, assistancy, and documenting all the development of the patients. 1 radiologist who's present in the control room, as you've seen before, and at least 2 radiologic technical assistants and 2 surgical assistants. Now you see them in real life. We have the 2 anesthesiologists dealing with the head and performing, or very close to performing, an intubation, 2 trauma surgeons present, 2 surgical assistants, 1 nurse in the background, and 1 radiologic technical assistant. And as you can see here, if you don't have a sufficient caseload dealing with polytraumatized or severely injured patients on a very regular basis, please perform trainings, simulate these trainings, and use dummies as indicated here instead of real patient if your caseload is not sufficient, so that you have a very proper workflow. Talking about the dynamics in polytrauma, and we're focusing in this presentation and in the shock room on the period of resuscitation, so the first 1 to 3 hours where you have to deal with shock, organ damage, or brain damage, followed by the period of stabilization within the first 3 to 72 hours, followed by systemic inflammation and the weeks and months of rehabilitation. So we'll focus on this red zone, the period of resuscitation, where the blood loss higher than the administered volume for replacement, or a life-threatening increase of intracompartmental pressure that inhibits organ function and or survival, leads us to life-saving surgery. And this can, as seen here, consist of a laparotomy or of other operations that can be performed in the emergency room in Vienna. So those life-saving surgeries, as for example, craniotomies, thoracotomies, or implantation of a chest tube, laparotomies, or the implantation of a fixator or a pelvic clamp. We are privileged enough in Vienna to be able to perform those operations directly in the emergency room if needed. A quick word about damage control versus early total care. If the patient is not stable enough to perform early total care, temporary external fixation in severely polytraumatized patients is an option, but also other damage control operations. So a few pictures of those operations, like here, an example of a craniotomy, laparotomy here as well in a clamp check technique that might be closed up with a vacuum system or the administering of casts. So all those options, as you can see here, are present in the emergency room if needed. We bring all the nurses and all the instruments into the emergency room. A quick word about the injury pattern in our polytraumatized patients. Injuries to the extremities are very, very common, as well as injuries to the thorax. Also very common, traumatic brain injury. So please look in your polytraumatized patients for this kind of injuries. The outcome in our patient, the mortality rate in severely traumatized, in polytraumatized patients is quite high. Still, also if you look at the international literature about the New Berlin definition, for example, so the 30% that we report in our patients is in very good accordance with the international literature. Why do those patients die? Due to hemorrhagic shock, traumatic brain injury, or ventilator failure in the first 24 hours. Later on, you more have to deal with multi-organ failure, with acute respiratory distress syndrome, or also the killer, the traumatic brain injury. So to conclude all this, what you need, according to our experience, is a sufficient infrastructure, sufficient diagnostic and therapeutic tools that you can use, sufficient caseload. And if you don't have the sufficient caseload, please do train. You have to constantly re-evaluate your findings and let your proceedings be guided by your new findings. Communications, as indicated twice in the one slide, and teamwork with all the involved specialties is of enormous importance. And after you've done all this, our emergency room sometimes does not look as neat and tidy as you've seen it in the first slides, but sometimes it can be quite a mess. But you've done a great job for your patients. And if your team worked well, they're all happy. So with this last slide, thank you very much for your attention, ladies and gentlemen, and greetings from Vienna.
Thank you very much, Stefan Fenzel. Very illustrative clinical guidance on polytrauma during the golden hour when we cannot lose even 1 minute. Diagnosis and support is provided at the same time. Thank you so much. We can proceed to the next report. Professor Mihul Achiara is ready. We are waiting for you.
Stefan, can you help Vilmos?
Sorry, who's the next presenter?
Доктор Стефан, можете помочь Вите Вильмшу, профессору, подключиться и показать нам, продемонстрировать свои доклады?
Dr. Stefana, can you help to show the screen? Barry, could you have your microphone on? Professor Barry.
I'm talking about the next presenter, Mr. Mehul Acharya. Unmute, please.
Hi there.
Yes.
Нет, Вильмс Вичи готов. Сейчас чуть-чуть немножко время подождем, он подключится.
Vilmos is ready. Shall we wait just a second for him to connect, and then we'll have Ms. Acharya.
Would you like me to present my talk?
Because he was to present first, but there was something wrong. That's why he could not present. Now, we'll invite him to talk on why we do need trauma surgery.
Okay.
So I hope we managed to put the presentation of Professor Vichai on my laptop, so don't be confused. He'll try to give his presentation from my laptop, okay?
Okay, no problem, no problem.
So we'll try
Это даже хорошо будет, лучше будет, да.
Share the screen.
Okay.
Is it working?
Yes, now you can go on.
Okay.
Please make it full screen.
Можете докладывать.
Please make it full screen, and you can start your presentation.
Now we can see your slide.
All right, that's good. Is it working?
Yes, I hope so.
So, Mr. Chairman, dear colleagues, for your patience, I am very sorry with the bad start. If I am speaking about trauma surgery and we would need it, first of all, I want to show the definition of trauma surgery. It's a little bit different from orthopedic trauma. The contents of trauma surgery are the diagnostics, conservative and operative treatment of injuries and their sequelae, their prevention and after treatment, including to the rehabilitation in each age. The center is the singular patient's welfare in the center of all actions. Why has developed this subspecialty? First of all, wars, violence and accidents, the industrialization, the industrial revolution, new neo-imperialism, and on the other hand, improvement of the conservative therapy in trauma, development in surgery, hygiene, and operative fracture treatment, improvement of the rescue systems, anesthesiology, and of course, on the end, the socio-economic and political responsibility. The center was pathogenically and organizationally defined, established in Central Europe for 50 years as an independent discipline, and it is a holistic approach, no restriction on orthopedic trauma. Why is trauma surgery a little bit different from orthopedic trauma? Because the acute intervention to deal with the external signs of the sequelae of injury connects the acuity connects much more to surgery than to orthopedics, and only as a functional repair the elective part belongs to orthopedics in our countries. Now, Watts had defined exactly which kind of persons would be the specialists, and he meant to train a specialist in the treatment of trauma is to train a specialist in all the specialties. It is in a sense an attempt to reverse the evolution which itself has led to specialization. The entire process has started by Sir Robert Jones, 1888, as he, as a general surgeon, has situated along the Manchester Ship Canal reconstruction work, hospital wards along the canal, which have been employed by experienced nurses and at least one experienced surgeon 24 hours a day. Later on in Germany, the different hospitals founded by the workmanship compensation assurance followed. At least in Vienna, we got 1925 the so-called famous Webergasse as a special hospital led by Professor Lorenz Böhler. Böhler has had enormous influence worldwide, and you can see that nearly all over the world he developed the influence, and different hospitals have been erected with his advice. In the 50s, the war has shifted from the battlefields to the streets, and a lot of injured, especially multiple injured, has been to be treated. How is able to treat these kind of injured? Because it took about 12 years to reach the goal of a well-founded education based on a high number of yearly surgeries. The entire system has had 7 important steps: the pre-hospital care, emergency room, acute diagnostics, holistic treatment approach, acute care, after treatment, and rehabilitation. And that has led to the trauma surgeon as the trauma leader and organizer of the trauma treatment. How good this has worked can be shown by a report of Franke, who has shown that only the shortening of the transport time helps to save lives in an absolute convincing manner. Another important challenge was to follow the best local possible organization and to create structures which are able to shorten all the processes outside and inside of the hospital. And that is a paper which shows the changes in Orange County after a new reorganization of total trauma care system. That was a horizontally organized system where the patient has had advantages and has profit of the better treatment possibilities. Look here, I show you what have done the Austrian surgeons in the Austrian departments for trauma surgery. That was a inquiry 2001, and that is a high number where the injuries in a high number has been treated exclusively by trauma surgeons. Now, from 2002 on, the general trauma surgeon came into jeopardy because decreasing operative exposure tend to more subspecialization, and it was difficult to recruit and retain the doctors at the trauma hospitals. What did trauma surgery suffer from at this time? It was a poor recognition of this broad kind of specialization. The ever-widening specialization within general surgery led to the search for appropriate fields of work for the new created specialties with exclusive claim. Intimidation by more and more specialized lawyers and poor earning potential. The new generation with the desire for a different work-life balance and the reduction of training instead of 12 to 8 years in high-income countries combined with limited working hours. The result was in the high-income countries, at least, that the claim about consuming work day and night, poorly paid, little reputation, politically unimportant, looks for general order, demotivating, led to the fact that the trauma surgeons have escaped into the elective orthopedics because these had made potentially regular working hours, better chance of better earnings, better reputation, balanced family and social life, and you have represented something as an orthopedic surgeon. A special kind of betrayal of the injured has started. So what were the consequences now of this development? The slightly injured go to the primary care centers. The severely injured, polytraumatized, depending on the local organizational structure, will be taken to the next or for them best suited hospital. They are expected by a few over-challenged or a medical consortium. The trauma leader will be the one in whose specialty the heaviest injury is added. Now, that had led to the first step of disintegration. We have given up very quickly the pre-hospital care, the resuscitation, the acute diagnostic, ECU treatment, after treatment and rehabilitation to different other specialties. The route remains the same, but we have changed our view to the world. Instead, to treat a patient as a whole, we have looked only for the whole in the patient. It does mean our subject became nearly fundamentally the skeleton. Now, that has led to the second disintegration because special orthopedics and special traumatology fell apart in different subspecialties, and only femur and tibia remain as an acute surgical part for the so-called trauma duty. So I'm coming to my first theorem because the financial sources are more and more reduced. The public and the private sector wants to lower the medical costs, and that means that we are employing shift physicians and in-house surgeons 24 hours capable of a wide variety of surgical interventions. but that means a systematic contradiction. The number of injured will worldwide increase, the number of competent centers will decrease, the number of capable surgeons will decrease, the trauma supply chain is or will be broken, treatment quality decreases, and the financial resources for the supply are kept as low as possible. Look, it is absolutely clear that worldwide the number of injuries will increase, and even with special respect to the traffic injury victims, we are getting a huge number, especially in the low and middle income countries, victims who either die or have heavy injuries to the entire body. So if you are looking to the cause of death by age between 15 and 29, so it is clear that the low and middle income countries are suffering with 90% of death, but only 45% of the traffic volume. And where are coming the traffic deaths from? 62% worldwide from Egypt, India, China, US, Russia, Brasilia, Iran, Mexico, Indonesia, and South Africa. We are dealing with other coming problems, that is aging. Up to 2060, we will have a high number of persons older than 65 of age compared to our times. And that means that this high number, a lot of fractures around the hip will show, and by an increase by 200 to 250% within the next 10 years. Does it mean that we need a specialty, a new specialty, geriatric trauma? The other point is, what I want to show you is that the accident deaths and the injured in general are not caused today by the traffic so much, than much more by sports and leisure. So the next challenge is how to solve this incoming problem. It was the proposal to combine generalists and specialists together in trauma treatment. That means immediate reception and resuscitation, critical surgical intervention, economy of manpower, reality outside university centers, and continuity of management, direction, and coordination. So my second theorem is Humpty Dumpty does not exist, and if it would exist and we would divide up the different parts of the body, we can never unite it again to a person. So the next challenge for the future is the fear that we cannot cooperate in this model, and if it is not possible, where can we get the rounded surgeons for the future? In Germany, the solution was the so-called trauma network, where the different sizes of hospitals are cooperating and they are in contact. They are transferring the patient from the lowest level up to the highest possible level to the main trauma centers. A similar system exists in England, but we don't know for longer if it will really work. So the last point what I want to mention is that we have more and more increasing number of armed conflicts. We have increasing number of terrorist attacks. We have a decline in trauma surgery research, and we have not the system to pay for the trauma surgeons training and for the services as well. So what is still applies 20 years ago and today in the same way. We need the pathophysiological understanding, which cannot be brought by every orthopedic surgeon, complete resuscitation, correct triage, negotiated titration of care, organization of trauma care, and the experience and evidence-based knowledge are irreplaceable. So thank you very much for your kind attention. And I want to answer my question. I think perhaps we don't need really trauma surgeons anymore all over Europe, everywhere. If the specialty would survive as specialty, so for sure not in a uniform worldwide manner, but it will follow local needs. And I am personally convinced that the pendulum will go back, and we need everywhere in social sense for the public optimal trauma accident care. Thank you very much.
Thank you very much, Professor. Thank you for such an interesting report. And we quite liked your theories and the challenges that you have mentioned. The challenges are everywhere and they're the same. The lack of resources, of course, and that the surgeons are underpaid. I believe this challenge exists worldwide. Thank you very much. Let us move on to the next speaker, Professor Mehul Acharya from Bristol.
So it's the management of severe pelvic injuries in the first 48 hours.
Thank you very much for the organizing committee for the invitation to present at this scientific and practical conference. I'm going to spend the next 15 minutes or so speaking about the management of severe pelvic ring injuries in the first 24 to 48 hours. So I work in Bristol, which is in the southwest of England. We're a major trauma centre, one of the busiest trauma centres in the UK. So I'm going to start with a case which will illustrate some of the important coordination and multidisciplinary approach in the management of these patients. So this is a 48-year-old male who was on his motorbike and was hit by a drunk driver who was thrown 50 meters from the scene. And what we're going to do is look at his blood pressure and his lactate over time. So at 4 o'clock in the morning, the paramedics got to him. He had a systolic blood pressure then of 80 millimeters of mercury and a lactate of 12.6, which is extremely high. They gave him some fluid, they gave him some tranexamic acid, and they put a binder on. About 35, 39 minutes later, he got to our emergency department. He then, within 10 minutes, had a massive transfusion started. 9 minutes later, he had a chest drain inserted because he had a large hemopneumothorax. And then he arrested. So his systolic blood pressure now is 75, his lactate is still extremely high, and is arrested. So he has some, he's resuscitated, so he's brought back, and he has an initial AP pelvic X-ray. And if we look at this, we can see that he's had a severe pelvic ring injury. If we look at the left side, there's massive diastasis at the back of the pelvis. There's massive diastasis at the front of the pelvis. There's also diastasis on the right side at the back as well. So he then goes to theatre for an emergency procedure, an emergency external fixator and pelvic packing because he's not responding to the resuscitation. This is his CT scan after he's been packed. So you can see he's got a couple of pins, and in the emergency setting, one of the pins has come out, but you can see that he's got these big packs, which are essentially opening up the SI joint, which is already open, but also tamponading that bleeding from the back of the pelvis. Some other cuts, and you see that his systolic blood pressure is still only 90, his lactate is still 10. So he's still not adequately resuscitated. He's not responding. So what do I do next? Well, so I get called as the pelvic surgeon on call. So I come in and I understand that we've got to stabilize the posterior pelvic ring. We saw how open it was on that CT scan. So I come in, we put some emergency iliosacral screws in the back of the pelvis. And you can see that here. And for the first time, once we've put these screws in, his blood pressure, his systolic blood pressure comes up to 100. Lactate is still high. Over the next 6 to 8 hours, he goes to the ICU where he's further resuscitated, and his lactate over the next 8 hours or so drops down and his blood pressure starts to come up. This is him 3 years post-op. So what I'm going to do is spend the next 10 minutes or so just talking about the priorities in resuscitation of these patients. And I call it the ABC algorithm. I think it's easy to remember if you have an algorithm like this. And so we all see this patient, this particular patient, and we're all concerned about this patient. We're all worried about how we're going to manage this patient. But what I'll try and do is over the next few minutes is give you the algorithm to try and make sure that you do everything for this patient in a systematic manner without missing anything. And so if we look at pelvic fractures and the mortality in the UK, this is a historical paper now, 13, 14 years ago, but there is a mortality of about 15, 20%. And there's this bimodal distribution. So the initial peak, we really can't do anything about. And these are the guys who have severe injuries and who die on the scene. Those that have severe head injuries, and those that have unsurvivable injuries. The second peak here is a little bit later, and this is something we can do about. So this is the patient who develops the SIRS response, multi-organ failure, etc. So this is the group of patients that we can do something about if we treat them adequately initially. And so, as has already been explained in that previous talk, I think having a structure and having a system and getting the right patient to the right place so that they're managed by the correct team is key. And we've shown, certainly since we've had major trauma centres in the UK, which is 2013 and 2014, that we have had an increase in patients surviving. We've had 20 to 30% of patients surviving major trauma. And this is more, 30% more patients. And what have been the reasons for this? Well, mainly rapid provisional stabilization and damage control resuscitation. What is damage control resuscitation? Well, it's permissive hypertension, so allowing the blood pressure to stay slightly lower than normal to prevent the clot from blowing. Hemostatic resuscitation, so these patients have lost blood, so you need to give them blood back ASAP. And then damage control surgery. Is there something we can do surgically to try and resuscitate them? And why are we doing all of this? Well, we're doing this because we want to prevent the lethal triad of acidosis, coagulopathy, and hypothermia. Once you start getting into this circle, it's very, very difficult to come out. And you usually end up losing the patient. So we want to try and avoid this. So what's the ABC of pelvic trauma? Well, certainly for me, A is assessment. And it's really important to assess the patient quickly, but effectively. And we'll talk about that. And then B, what does B stand for? Well, B is the next step. So applying a binder, bony stabilization, blood and blood product resuscitation. And then what do you do if the patient continues to keep bleeding? You move on to C. And where do you go from here? And we'll talk about this in further detail just now. So A for assessment. So we all assess the patient, we'll look at the history, the mechanism of injury, we'll resuscitate the patient, we'll look for clinical signs, and then we'll get an initial X-ray, an AP pelvic X-ray. And the two things I really want to know from the X-ray is the patient stable and is the pelvis stable? And if the answer to any of these two questions is no, then you've got to do something else. You've got to move on to the next step. And the next step is B. So binder, bony stabilization, blood and blood products. And certainly in the UK, anyone who has blunt, high energy blunt trauma and who has a systolic blood pressure of less than 110 millimeters of mercury will get a binder. There are concerns about binders, and there are concerns about disturbing the clot. So once the binder's on, you don't really want to check for stability. You don't want to log roll the patient in that first resuscitative period. You may need to do that later. And you can use various things. You can use a binder, you can use a sheet, you can use fixators, etc. Potentially, there are some problems with binders if you leave them on for a long period of time. But in the emergency setting, binders save lives, so they should be used. This is an interesting case. So about 4 or 5 years ago, this is a young guy in his 30s. He's come off his motorbike. He's got a splenic laceration. He's got an open forearm, and he's got some pain around his pelvis. So this is his initial X-ray with the binder on, and it doesn't look that bad. It looks pretty good. The only thing of note there is the bladder doesn't look its normal shape. So then he has a binder off X-ray, and look at that. The bladder changes shape to some degree, and look at the front of the pelvis. So something has changed between those two images. Look at that. And that's with the binder off, okay? And then he gets taken to theatre to have a splenectomy because they can't control his bleeding. And so I screen his pelvis in theatre, and this is his pelvis without applying any force at all. So he's had a laparotomy, he's had a significant injury, he's under anesthesia, he's lost that muscle control, and his pelvis just opens up completely. And this is really interesting, and it made us think that actually the binders may well be obscuring severe pelvic ring injuries. So we looked at this, and we looked at our results, and we found that in 7% of patients, a binder will obscure a severe pelvic ring injury. So it's really important to be aware of that. There are other ways of stabilizing the pelvis. You can stabilize it with an external fixator, but the binder is quick, it's easy, everyone can use it. You can use a C-clamp if you need to stabilize the posterior pelvic ring, or in the case I presented, I used emergency iliosacral screws. So blood, well, these patients lose a lot of blood, and this is something typical of what they may lose. Certainly in the UK, the National Patient Safety Authority had a policy that anyone dealing with severely injured patients should have a massive transfusion protocol. And this is our massive transfusion protocol here. So it's pre-arranged packs from the blood bank. It's one phone call. There's a consultant on call. There's a dedicated porter. And this comes as 2 packs. So there's a pack A and there's a pack B. Pack A is available immediately. And it includes 4 units of red blood cells, O negative. So it's ready to go. 4 units of FFP, and then 2 units of platelets. And if the patient still doesn't respond, then you give them pack 2. So now you've had some time, 15, 20 minutes, and you can get type-specific blood. So 4 units of type-specific blood, 4 units of FFP, and some platelets again. And lots of studies out in the military and in polytraumatized patients that what you want to do is give the highest ratio of FFP and red blood cells. Tranexamic acid, well, the CRASH-2 trial looked at over 20,000 patients, giving them tranexamic acid as a bolus dose and then an infusion. And what they showed is that there was a 15% survival advantage of giving tranexamic acid to these patients. The following year, they then reanalyzed these mortality rates, and they found that actually what you need to do is give the tranexamic acid as early as possible. So it needs to be given in the first 3 hours. So what do you do if the patient doesn't respond? So you've done A, you've done B. What do you do then? Well, you move on to C. You say, okay, so continued hemorrhage. And what do you do? Well, there are 2 main arms. You can either take the patient to the angio suite for embolization, or you can take them to theatre to pack them, pelvic packing, or you could do both. It's important to understand that angiography tries to pick out those arterial bleeders, which account for about 15 to 20% So not the majority of bleeding pelvises. The majority of the bleeding pelvises are from the pre-sacral plexus. And so packing may be a more fruitful thing to do early. So which is best? There are a couple of studies, one from Wade Smith and his unit in the States. They used embolization and then they went on to pack patients, and they found that packing was rapid, effective, and reduced transfusion requirements. They then, a couple of years later, looked at both cohorts, so the ones that they'd embolized and the ones that they'd packed, and they concluded that packing was as effective as angiography. It reduces the transfusion requirements, and it may even reduce mortality. There was this study, 2016, looking at angio versus packing, and the main things to take home from here is that it takes longer to get the patient to the angio suite than it does to theatre to pack them. So in summary, there's a high mortality from these pelvic fractures. There is an improved mortality and survival with establishing major trauma centres, and this requires a systematic multidisciplinary team approach. The algorithm is really important to remember, and it prevents you from missing anything. So A for assessment, B for binder, bony stabilization, blood and blood product resuscitation, and then what you do with the patient who fails to response, continued hemorrhage. Where do you take them? Do you take them to the angio suite, or do you take them to theatre to pelvic pack, or do you do both? Thank you.
Спасибо вам, профессор Михаил Ачарья. Рад вас видеть был сегодня на нашей конференции.
I'm very happy to see you at our conference. Thank you so much for taking part in our conference. And I have one question. You show the slide in resuscitation. A patient had a surgery. You had different screws, and in a different surgery, you have different screws. Are these screws different? First, you stabilized his pelvis, and then you made a final surgery. Have you heard the question?
Dear professor, you should choose English language in the interpretation mode, and you will hear the interpretation.
Профессор Барри, у вас не слышим.
Professor Barry, we cannot hear you. Can you switch your microphone on?
Can you listen to me? The question was that primarily you are going for the binding, and then you go for the definitive treatment for operative surgery or not?
Yes, absolutely right. So they will have the binder first, and they will be resuscitated, and only if they fail to respond to the binder and the resuscitation, then you have to do something else. So then you may need to take them to theatre to pack their pelvis, and maybe more definitive stabilization of the pelvis, because we can keep the binder on for 24 to 48 hours, but we try and remove it as soon as it's safe to do so because of pressure areas, etc.
Thank you so much. Thank you.
Хорошо, спасибо. Тогда перейдем к следующему докладу.
Thank you so much. Then the next presenter, please.
Роль анатомической репозиции крестцово-подвздошного сочленения при нестабильных повреждениях тазового кольца.
Hello, so my topic is the role of the anatomic reduction of the sacroiliac joint in unstable injury to the pelvic floor. Allow me to present you my speech. As you know, the fractures of the pelvic bone and the structure of the injuries of the musculoskeletal system account for 5 to 25% of all fractures. We cannot see your slides. One second.
Dear professor, it's only on platform, not to the Zoom, okay?
We don't see your slides.
Yes, I know. It will not be in Zoom. It will be on the platform. Thank you.
Okay.
Продолжим, да?
So I will continue. The pelvis has a complex multi-component spatial structure in the form of a sphere, which is built on the basis of the general laws of the architecture and anatomy. This sphere goes through the spine, and there's a junction with the sacrum in the centers of the hip joints. We do not see the slides in Zoom. We can see them on the platform. Professor Barry, you're not going to be able to see the slides. Just click the tech support and then you will see the slides. Please do not interrupt our professor. We will continue. The sacrum is the key of the sphere, and it is connected to the nameless bones. This bone should be supported by the ligaments, specifically the spinossacral and sacrotubercular ligaments. These ligaments are located obliquely at an angle of 9 degrees in relation to each other. And the joints of the pelvis are infraarthrosis. That is, there are flat and sedentary formations, which provide a shock absorbent function. As I have mentioned earlier, pelvic stability is largely dependent on the integrity of the peripheral posterior ligamentous complex, which includes the anterior and posterior sacroiliac ligaments. And the anterior or ventral ligament is located almost horizontally, and the two posterior or dorsal ligaments are sacrospinous and sacrotubercular. Stabilization of the pelvis in the case of unstable hemodynamics should be done as soon as possible. It must be performed within the first golden hour from the moment of admission to the clinic. And first inpatient aid has certain advantages, such as direct inspection of the SIJ, and indications include dislocation and fracture dislocation in the SIJ. So this is the first inpatient aid. So now I would like to talk about the front approach to the sacroiliac joint. I'm going to start with it. And one of the advantages of this axis is that it is performed in the supine position. And axis is the first window of the ilioinguinal axis. We expose the inner surface of the ilium. You can see that on the slide, and the view of the anterior surface of the sacroiliac joint is sufficient for our manipulation on it. We expose the inner surface of ilium by moving the megas iliacus. Elimination of the displacement in the sacroiliac joint is facilitated by stretching along the length of the limb and due to the lever movement of the bone holder for the wing of the ilium. After the reposition, we carry out the fixation with two plates. The plates need to be located at an angle of 60 to 90 degrees in relation to each other. They should follow the terminal line that has quite a dense bone structure. We need to decide on the direction of the drill in the tunnel. And usually the blood loss is about 500 milliliters. The main danger of this axis is the possibility of damage in the fifth lumbar nerve root. It emerges from the intervertebral foramen between the fifth lumbar and the first sacral vertebra. It connects the root of the first sacral vertebra emerging from the opening S1 and goes for about 15 to 20 millimeters medial to the articular surface of the sacroiliac joint. This way, we don't have much room for manipulations, and we put one screw on the bow. The second danger is the trauma to the external cutaneous nerve of the hip. When the iliac crest is exposed in the anterior superior spine, which cannot always be avoided with this approach, but we should try not to damage it, because in the future, this can lead to a decrease in sensitivity along the posterior outer surface of the hip. Now we will move to the frontal, to the rear axis, and the position of the patient on the operating table is on the stomach. The gluteus maximus muscle is separated from the crest and retracted downward and outward. This muscle layer must necessarily include the entire muscle mass. This position on the stomach is not the best one, unfortunately. And whether this approach is the best for the surgeon, that is a question, because again, there are certain limitations to manipulation. It means that we don't have a lot of fat under the skin, and that can lead to certain infections, up to 20–25% of potential infections. As I've mentioned, the patient is placed on the stomach. There is a direct access. A direct incision is made medial to the posterior superior iliac spine, and the incision is directed to the posterior inferior spine, curved along the iliac crest. So the skin and the fascia covering the gluteus medium and maximus are dissected. The gluteus maximum muscle is separated from the crest and retracted. The muscle layer must necessarily include the entire muscle mass, since the branches of the lower gluteal artery and the nerve pass through the thickness of the muscle. But they need to be protected from the damage, which limits the immobilization of the muscle flap somewhat. But we need to make use of that. Now, about the quality control of reduction. It's not possible in a complete way. That is why we need to use palpation, and we need to make sure that we retrace the piriformis muscle a little bit, and then we just control with our fingers. So we use palpation. The next step is a fixation of the sacroiliac joint. Again, here we see certain difficulties, such as the screws direction. The screws should to be held perpendicular at 90 degrees, but the drilling of the channels for the screws must be carried out at an angle of about 15 to 20 degrees. The length of the screws depends on the character of the injury. In this axis, the main danger is the damage to the upper gluteal neurovascular bundle. It goes through the main gluteus maximus muscle. And the difficulty here is connected to the anatomical reduction of the SIJ. Osteosynthesis with screws, which has been widely used recently. It is minimally invasive method. It is used by the well-experienced surgeons, those who have the opportunity of carrying out this operation, and a good approach and the good view of the surgical field are very important. We can say in the end that the success of the operation depends on the individual selection of access, depending on the nature of the injury, and it is necessary to take into account the general condition of the patient, as well as accompanying extrapelvic injuries and diseases. Accurate preoperative planning, a good knowledge of anatomical structures, as well as careful surgical technique are additional prerequisites for the successful treatment of the pelvic ring injuries. Anterior approach is more convenient because visualization is good. Posterior approach, direct visualization is difficult. Therefore, reduction is controlled by a guided finger into the fascia. Thank you for your attention.
Thank you very much. Thank you very much for your beautiful presentation regarding the pelvic injury reduction, sacroiliac joint. Okay. So next presenter is from Austria. Again, is Stefan Frenge.
So, hello. Can you hear me?
Yeah.
Perfect. Welcome back to Austria. I'll try.
Еще раз добро пожаловать в Австрию. Я постараюсь показать вам мои слайды. Все работает. Мы поговорим с вами сегодня о сложных повреждениях таза с повреждением мягких тканей. С чего начать?
Of the complex soft tissue injuries that you might face in dealing with those patients. Just a few pictures of the problems that we have to go through in this very, very quick recap. Problems of complex organ structures that you don't face that often in simple pelvic fractures, where concomitant injuries are quite seldom. They're more often those simple pelvic fractures, but the mortality is low and the concomitant injuries are quite seldom compared to the more complex pelvic fractures that are more often associated with relevant soft tissue damages with a quite high risk of infection and where the mortality definitely increases. And it's even worse in those patients that are hemodynamically unstable, as the presenter before me already pointed out. So here you face a very high mortality, and it's very, very important that you get all the relevant injuries and deal with them very, very fast. Especially in these patients, it's important to treat first what kills first. So talking about the diagnostic, the examination level that we have to go through, stable to pelvic compression, I won't go into detail here. It was discussed already, and the enormous importance of stabilization of the bony structures was emphasized already. Also look at the pulses. Are they palpable? Just a quick word about the main sources of bleeding in the pelvic region. Bone and ligaments, you have the venous plexus, you have, of course, the arteries and the hollow viscous organs. Bone and ligaments quite regularly are a source of bleeding, and also is the venous plexus. The hollow viscous organs in up to 5%, but very important, the arteries that might lead to a very relevant bleeding and sometimes to persistent shock. So dealing with those problems, compression is very efficient in the venous plexus as well as the bone and ligaments. Reconstruction and compression as dealing with acute problems of the hollow viscous organs. But with the arteries, it might be a bit more complex. You can talk about angiography, reconstruction, embolization, compression, and please also keep in mind that there is the possibility of using REBOA. If you have that option, it might be very, very useful, and we try to implicate that in Vienna on a very regular basis. So it was already mentioned before, bleeding of major vessels, CT, angio for diagnosis. You think about angiography if it's possible, thinking about embolization or using a stent, and always keep in mind that maybe revision might be needed in these patients. This is a CT scan with one arterial bleeding that you can see especially good on the right-hand side, but actually on all the slides. A quick word about retroperitoneal hematoma, and we'll go through all the relevant effects within the next minutes. It might be a bit stressful, but we'll work it out. Talking about the therapy of retroperitoneal hematoma, whenever feasible, aim for conservative treatment. Autotamponade and external compression might stop the bleeding, and keep in mind, if you go for operative treatment, you have a quite high risk of infection. Going through the major steps in these cases, if you have to perform emergency operation due to retroperitoneal bleeding, if it's localized, aim for ligature, suture, or reconstruction, and afterwards go for reduction and osteosynthesis. If it's diffuse bleeding, consider packing, or if it's diffuse bleeding coming from the fracture, aim for reduction and osteosynthesis right away. If it's an intraperitoneal bleeding, aim for surgery of the organ damage reconstruction and afterwards reduction and osteosynthesis of bony and ligamental structures. Peritoneal packing was mentioned beforehand as a measurement of damage control if adequate diagnostic steps are not possible. Transperitoneal or intraperitoneal abdominal packing, which is less effective if the abdominal wall is not closed. And please keep in mind that there is the possibility of development of an intra-abdominal compartment syndrome. So stepping down this diagnostic and examination level that was mentioned beforehand, blood at the external meatus as a sign for damage to the urethra with a concomitant pathologic finding in the diagnostic checkup. And you also see the acute treatment, the suprapubic catheter that was put in place in this patient. Stepping up towards the urinary bladder, hematuria is found in these ruptures in 70 to 80%. The localization most often is an extraperitoneal rupture, but it can be also combined, an intraperitoneal as well as an extraperitoneal rupture. And please look for concomitant injuries, which are very, very common in these cases. So just a quick mention of the diagnostic checkup. Either you do a fast scan, a CT, or a cystography, depending on your options and your possibilities. And in red, you see the pathological findings in these patients in these cases. Extraperitoneal rupture of the urinary bladder. The aim is the reconstruction of the bladder. In emergency cases, sonography-controlled suprapubic percutaneous catheterism of the urinary bladder should be performed. Be aware that transurethral catheterism can be problematic in these cases. Management of the concomitant injuries as soon as you found them and deal with them accordingly. Osteosynthesis of the pelvis should be put in place as soon as possible, and maybe delayed reconstruction of the urethra. This is a case treated at our department in Vienna just 2 weeks ago with a complex pelvic fracture. You can see that via CT, we performed an observation of the bladder that was perfectly fine, but just to give you an example of a very common concomitant injury, there was a dissection of the thoracic aorta that was afterwards stented. So that's just one recent case treated at our department. Just a quick word about injuries of the rectum or the vagina. Inspection of the torso and the perineum is obligatory. You have to check the function of the sphincter ani if it's possible. Perform rectal investigation. Do you find blood on the finger during or after this examination? And consider proctoscopy or rectoscopy in doubt. Also look for bleeding from the vagina in female patients and perform a thorough diagnostic evaluation if you have any doubt about this. The aim of injuries to the rectum in these complex pelvic fractures may be in the therapeutic acute state, consider left-sided diversion, colostomy, or a Hartmann stump, but most important, thorough washout and getting rid of sources for local infection. In the vagina, go for revision, if possible suture, and also very important, put in a drainage. And please consider revision in these cases if you have any doubt that you were successful in the first place, and maybe it's part of your treatment goal to do several revisions until you perform the final suture. And antibiotics, enormously important, as we'll point out within the next slides. So talking about perineal wounds and rectal wounds, revision might be a very, very important tool of your therapy. Colostomy might be advisable or obligatory. Lavage is important, and treat anorectal wounds in fractures of the pelvis as open fractures. So the role of antibiotics and thorough lavage is enormously important. And it can't be overestimated because you have a very, very high mortality in those cases. And a lot of those mortalities are due to infections or septic complications. Another case treated at our department where we performed a suture of the urinary bladder and osteosynthesis combined with a reinsertion of the anus, washout, and putting in of a drainage. And on the picture on the lowest part of this slide, you see a double catheterism of the urinary bladder, drainage, and colostomy in place. Quick word about decollement injuries and debridement. Debridement should be performed very, very thoroughly. All the affected tissue has to be removed, even though that might be quite a lot of it, but don't let any of those affected tissues in place because it will be harmful for the patient and delay your proper treatment. In this patient, an external fixator for the complex pelvic fracture was put in place, repetitive revisions with thorough debridement was performed, and in the end it was this skin defect was covered by keratinocytes and the external fixator was removed after 12 weeks. Just a very quick word about injuries of the nervous system. Think about the plexus lumbosacralis. If you're able to precisely examine the patient, look for sensitivity disorders, keep in mind that it might be the reason for anal and urinary incontinence and also for sexual dysfunction. So the precise neurological examination in patients with complex pelvic fractures is very important. A quick closing word about concomitant injuries, as mentioned beforehand with the thoracic or aortal dissection, nerval structures, look for urethra, look for all those structures that were mentioned beforehand, and also look for injuries in the thoracic abdominal cavity. So as the pancreas, as the diaphragm, as the duodenum, those are very, very frequently found concomitant injuries in complex pelvic fractures and shouldn't be overlooked because otherwise you're facing quite severe complications. That's the data of 28 consecutive cases treated at our department in Vienna, but due to the fact that we're now just in time, I won't go into detail here. And thank you very much for your attention and would like to conclude with the importance of a well-rehearsed and interdisciplinary team in treating those very complex cases. Look for hemodynamic stabilization as soon as possible, as was mentioned by the speakers before me. Thorough diagnostic evaluation and maybe external fixation are not separable, so you have to go those pathways together in parallel, and an experienced trauma leader, as mentioned in the presentation about the emergency room, is needed in those cases not to overlook any of the relevant injuries. Thank you very much again from Vienna, and please go ahead and ask any questions if there are.
Профессор Барри, вас не слышим, микрофон включите.
Да, я вот, well described. Very nice lecture. Thank you so much. Now we can proceed for the next speaker. Next speaker. Pneumothorax on the X-ray in prone position. Mahambetic. Please go on.
Добрый день, уважаемые коллеги.
Да.
Мой доклад будет посвящен.
I will talk about the diagnostics of the pneumothorax. The poliotrauma became pressing for the last 20 years. So in the literature on traumatology and surgery, the old stereotypes dominate that were formed by the decades, and they do not describe fully the pneumothorax diagnostics. The stereotypes cannot be used during the pneumothorax during X-ray in prone position. So CT can resolve this problem, but not all hospitals have round-the-clock CT, and not always the condition of the patients allow us to do CT, and it's impossible to do CT more than once in a day. So the X-ray remains the most accessible and widespread method for the diagnostics of the chest and its dynamic control. This presentation is to show the stereotypes that prevent timely diagnostics for the pneumothorax. And there are 10 most traumas. It's very difficult to differentiate, but the treatment is different. So let's talk about the timely diagnostics. The first to read the X-ray in prone position using pneumothorax signs in vertical position, it's very difficult. On the top image, it's the pneumothorax, which usually happens at vertical position, but it's also typical in horizontal position. But sometimes in the prone position, there is just a lightning on the screen, or we can see that there is a deep ribs diaphragm angle and depression of the diaphragm cupola. So here we see that the right lung is expanded. So here we see that there is a deep angle. So that's why we are looking for the pneumothorax. And we can see here the edge of the lung, and we see here a small stressed pneumothorax. At the top image, there is a hemopneumothorax, a classical one, done in the vertical position with any type of, any amount of water, liquid or air. It will have horizontal level, and this is the edge of the lung. If we put the patient on the back, we'll see the blood on the posterior, and it will be very difficult to diagnose pneumothorax. There is just a slight lightening, but at the lower image we can see that the mediastinum has moved to the right, and the diaphragm cupola is depressed. So we see here small stressed pneumothorax. For this, in one day, CT and X-ray has been done to that patient with tension pneumothorax, and this is hemothorax signs, a little lightening on the right edge of the heart tells us that there is pneumothorax. So we see hemothorax at posterior and pneumothorax anterior. The second stereotype is to ignore auscultation and to hope for X-ray only. But tension pneumothorax or heart tamponade are the clinical diagnosis, because you don't have time to make the X-ray, so the doctor who can auscultate is much more efficient in diagnosis and treatment. Here we see false pneumothorax. We see the lung edge, but during auscultation, the breathing from both sides is symmetrical. It's the skin flap which created this false picture of pneumothorax. Calibrated upper part. During breathing, the breathing was symmetrical. This is typical for older people who have decreased nutrition. Here, both lines are extended, but the right is moved to the heart. The heart is moved to the right. Is a small tension pneumothorax suspected, but this patient has dextrocardia, so that helps us to escape thoracocentesis. There are a lot of images where pneumothorax cannot be seen even by X-ray specialists. Only auscultation allows us to insist that on the right there is a pathology which there is a almost invisible line of pneumothorax which appears and then disappears again. A similar picture, there is a pneumothorax on the right, the lung is fully folded. So seeking pneumothorax, we can find its line. We have to look for this intentively. Going back to the previous image, there is auscultation during severe polytrauma. In the prone position, we cannot do without auscultation. The diagnostics will be untimely. The fourth stereotype is pay attention only to the lightening and darkening, regardless of the patient position. The quality is not good, but looks like both lines are straightened out, stretched. But we see here the asymmetric laying. The left part is closer to the bony parts. So there is a left to right turn where we see clavicle closer to the bone parts, and here we see movement to the right. Something on the left is pulling. It could be atelectasis. We don't see here what moves mediastinum, and we see additional sign of pneumothorax in prone position. It's the diaphragm cupola, deep diaphragmal sinus, and here we can see the edge of the lung. We see here a small tension pneumothorax. Same patient where after processing the image we can see pneumothorax better. On this image, it's same asymmetrical layer where the left clavicle is closer to bony parts than the right one, and the heart is moved to the right, so we can see small pneumothorax and small hemothorax. They are not tensed. So here we see asymmetrical laying. Left clavicle is closer to the bony part. There is a turn from left to right, and the there is a movement due to the asymmetrical laying, movement of mediastinum. So something from the right is pulling or something from the right is pushing. And only while looking for the pneumothorax on the left, we can see two lines from the shoulder blade line and the lung edge line. So again, we have small tensed pneumothorax, which is not described anywhere in literature. Images which demonstrate the role of assessing the mediastinum location. There is a total darkening of the right half of the chest. We can think about big pneumothorax, but big pneumothorax should move mediastinum in the reverse side. But here mediastinum is moved to the pathological part, and only a task can pull to that side. But the surgeon have not interpreted the mediastinum location and made and thus received heterogenic pneumothorax. The bottom image, the location of mediastinum, is the key for timely diagnostics. And the tense pneumothorax should have the full lung collapse with a closed trauma. It doesn't work, the stereotype. In this case, tense pneumothorax with the chest wound, penetrating chest wound, with a closed chest trauma, tense pneumothorax in most cases has partial lung collapse. But the mediastinum misalignment, and from this tense pneumothorax, small pneumothorax, which we do not find in the guidelines or textbook, the patient has died. Small tense pneumothorax from which the patient has died. This is total pneumothorax with a full lung collapse. This there was the broken clavicle and breathing insufficiency, so the total collapse doesn't always show the tense pneumothorax. It's the mediastinum which is dislocated, and that talks us about the tense pneumothorax. Here we see atelectasis, which requires urgent bronchoscopy. Here we see small tense pneumothorax, which requires urgent evacuation. Here we see in the prone position, both lungs straightened out, but on the cupola of the diaphragm we see this light, and after 2 days the compression pneumothorax has led to total compression atelectasis. Your time is up. So what happened next? The patient was drained, bronchoscopy was done, and the lung started to expand. The patient had on the right hemothorax. Hemothorax on the prone position not always takes the part of the, is not always shadowing the entire bone. It could be on the edge of the lung. The punction was done on the 4th day, so the shadow part became less. So what do we have here? Pneumothorax, hemothorax, or hemopneumothorax? before it was pure pneumothorax, we see that the hemothorax shadow merges with the lung edges. And here we see clear line. And this clear line tells us that there is a double contrast, both with blood and air. So it's a hemopneumothorax. So pneumothorax appeared during the puncture and needling. So when hemothorax has subsided, there is pneumothorax only, and there is the light and there is edge of the lung. So auscultation and knowing these peculiarities in X-ray help us to control better those lesions. Thank you so much for your attention. Thank you for your presentation. There is one question. Do you have experience of using ultrasound sonography during lungs lesions? We always use sonography for polytrauma, but mostly we look at the peritoneum. So for the cavum pleurae, pleural cavity, we can see sometimes echolectasis, but to see the contusion or lung rupture, we can also find this on the ultrasound or sonography. So let's move to the next presenter, Dr. Gehrig will present.
Hello, everybody, distinguished chairman, dear colleagues. I'm great to have this opportunity to speak instead of Mr. Shota. I will announce the speech. He prepared it, but he's on leave, and in Morocco the connection is not great, so he actually sends his apologies and sends his regards from Morocco, and I'm going to present this speech. And if I have any problems, I'm sorry, because the speech is actually in German and I will need to translate it and present it at the same time. So we will talk about the 10 golden rule, about the techniques of the surgery, about different complications that can arise from the surgery, and we'll discuss this. The important is that it is the people above 60 years old who are affected by the protrochanteric fractures. Could you launch the presentation, actually, because we don't see anything. We can hear you well, we just don't see your presentation.
Так, теперь нужно было появиться. Есть или нет?
Да, есть.
Да, вот еще раз привет от нашего доктора.
So once again, our doctor sends his regards from Morocco. And the speech is divided into several parts. First, we talk about epidemiology, then 10 golden rules, operative technique, etc. So we will start with the fact that it is the patients over 65-year-old who are subject to such fractures. Over 50,000 people are operated in Germany. And of course, there are many different options for the surgery. And usually we choose the DHS or the nail blade. You will see the pictures later on. And the patients need to have the surgery if they have the necessary indications for the surgery. Then the surgery needs to be done within the 24 hours. There should not be any delays, otherwise the patient won't have the right indications and the condition will change, etc., etc. But of course, the longer the patient wait, the worse the result is. And then complications happen in 5 to 38% of cases. What is the cause for these complications? Usually it is the operative technique that was not chosen right, or maybe these are the fractures of the implants themselves. Now, how can all that be reduced? I'm going to talk about that next. So, as you know, the trochanteric fractures can be divided into femur, proximal, and segmental. We have the intramedullary fractures, extramedullary fractures. So we use a gamma nail and some other next extramedullary include DHS plate or blade plate. Also, quite often for patients with older age, we use cement augmentation. You can see that around the screw, you see some cement. Some other complications that occur, these are cut out, cut through, infection, pseudoarthrosis, offset. All of that you can see on the slide. Now, the goal of the treatment. Now we talk about reposition and CCD angle. We have mechanical stabilization in order to return the stabilization to the initial stabilization. What are the problems that occur? These are complex fractures or osteoporosis, or it can also be a patient with multimorbidities or a non-compliance patient. What can we do about that? What are the solutions? We have open reposition, cement augmentation, as I said, in the case of osteoporosis, and also soft tissues. Now, we have 10 golden rules. We need to study the history, of course, the quality of the imaging. Then we need to look at the right position of the patient. We do X-ray studying in 2 different axes. We need to look at the anatomical structure, anatomic reposition, and the right choice of the implant, especially when we talk about the nail. Osteosynthesis should be done after reposition. Apex index, it is one of the rules that we follow strictly. It is the center to center position. It is between the neck and the nail. I will show you a bit later. Another rule is cement augmentation. And we also now look at the classification, but I'm sure you know all that quite well. You know all that. So in A1, we do DHL or nails. In A2, we have both nail and DHS, as well as the plate, an additional plate. In case of A3, the same. AO classification was revised in 2018. One of the symptoms of instability of the fracture is that it is 3 centimeters lower than trochanter. The length of the remaining bone should be at least 20.5 millimeters, so at least 2 centimeters, as you can see on the X-ray. Algorithm of the peritrochanteric fractures includes a PFN or DHS plate, but if the patients are older than 70 years old, then we also carry out cement augmentation. What's important is during operation to have all the right anatomical structures identified, apex index, which should be 10 to 25 millimeters as a sum. We need to place it centrally. We need to make sure that the nail is introduced the right way. All these factors are important that I'm showing you, and intraoperatively we need to take care of all this. And now the introduction point, gamma nail is 1/3 anterior and 2/3 posterior. Here you see the formula for the tip apex distance, how it should be identified. We pay a lot of attention to this apex distance because one of the reasons for cutout is the screw that has not been introduced properly, or it is the position on the table. Maybe it also a problem during the introduction of the nail. We need to make sure that all of that is done in the right way, that the direction for the nail is right, positioning on the table using the transparent foil. And before we carry out reposition, we need to make sure that all anatomical structures in the right place. We also identified the points of introduction of the nail using the guidance devices. Then osteostensis happens. We need to make sure that the compression takes place. We should not forget about the compression function because osteosynthesis takes place. There might still be some more areas for improvement. For example, for our gamma knife has this type of screw. DHS has a different type of screw, and we have also decompression screws. All of that can be compensated when compression takes place later, but it might go the wrong way during the operation. Now, classification of the fractures. We need to look at what type of fracture it is, and then we need to carry out the right type of osteostensis. We need to look at different items that are located, maybe not quite right in front of our eyes. We need to look at a trochanter. Next, we see 1 week post-op. Then after osteostensis, you see that 4 weeks later, we see a certain movement, and more so after 3.5 months and 6 months. So we carried out a resection and actually introduced a different implant. It works better for the elderly people. We do it quite often, actually. We have to do revision surgeries, and we just introduced this type of implant. It has a shorter length. They actually come in different sizes, and they help us in many different ways, and our patients start walking again. It's also important that first reposition takes place. Here you see that the nail was introduced without the reposition. So we see quite a big diastasis, and the nail was not chosen properly. The entry point was not chosen properly. Another fracture, a 78-year-old patient. You see this location here. You also see trochanter's location. It is, the screw was not introduced in the right way. Another fracture in a patient of 71-year-old. We had the osteostensis, we had the gamma nail, and we also have diastasis. Next patient is 92 years old. Here you see osteosynthesis. It was a complex structure, and you can see right away trochanter, and you also see this part of the bone. So when we enter the nail, we need to make sure that we have position in control. Another fracture, 88 years old. Patient osteostensis has been carried out. And as you can see, there are different situations here. The nail here, and then the trochanter part is missing. Rotation is marked in red. Rotation is not done properly of the femur neck, and the index was not observed properly. we need to use different devices for repositioning. We should not damage soft tissues. Now we have all the necessary devices, and we have this special type of file that we can use, or this repositioning scissors. So I believe you can see it quite well by yourself how the compression is happening, and then reposition will be done in the proper way. We can also use different devices that allow us to position everything properly. Some more examples of the repositioning technique. Circulation devices are used. We can carry out our technique with lesser damage to the soft tissues. Next, major fracture of trochanter. That's another important part. Of course, if we introduce the nail without properly positioning it, it will have some major complications. Another patient, 58 years old, you would think it is not a complex fracture, but nevertheless, you see what happened here, you see dislocation, you see a revision surgery, additional anti-rotation screws were introduced, which led to infection, and again, revision took place, and we put a different type of implant. Cut out is another complication that takes place, and it's hard to say whether it happens because of the screw that was introduced in the wrong way, or maybe it's because of the weight bearing. But regardless, of course, if we stick to our golden rules, then the number of complications will reduce. Some patients lay on their side, and that means a lot of weight on the side and on the screw, and the screws can even break. So here we had the fixation of the trochanter. Next, you see osteosynthesis in a patient of 68 years old. And a month and a half later, an implant was placed. Next, we talk about the compression and stop screws. I already talked about the compression screws, but a stop screw is necessary in order to block the compression, especially when it comes to the femur neck fracture. But stop screws need to be placed in the tunnel, otherwise it is not going to actually implement all its functions. 94 years old. These are post-op results, osteosynthesis and reposition. You see that it all resulted in an implant placement. This patient came back to us. You see that reposition was not done the right way. Patient 82 years old. Reposition DHS blade. Then cutting out an implant. And here is a joke, sort of. Maybe it doesn't happen to all of us, but it happens sometimes, especially if surgeons just start in the career. I'm sure you've all realize what the problem was, why this guiding screw does not end up in the center, even though the surgeon tries to place the screw in the center. Well, the surgeon forgot to take off the guidance device that is in the tunnel, and that is why it was in a way. Now, infections. Quite often, the infection results just from the wrong sutures. You see that here we see a double skin flap, and then that might lead to infection. So, going back to 10 golden rules, we can say that, first of all, we need to study the anamnesis, we need to do reposition, study X-ray images, choose the right entry point for the implant. And one of the most important parts for us is the tip apex index or distance, which should be 10 to 25 millimeters. And keeping in mind the X rate, we can maybe give plus minus 2 millimeters. The other rules have been discussed already. Thank you very much for your attention. If you have any questions, feel free to ask. Thank you. You have actually told us a lot in just 15 minutes. We thank you for that. Thank you. We are receiving questions now about my speech. How long after the surgery the verticalization is possible? We do that on a second day post-op. The person can actually stand and put the weight on that foot. Okay. Professor Barry, would you like to say something? Just to sum up, maybe. Dear friends, I would like to thank all the speakers.
And I have one or two observations and questions to Mr. Murat Maksutovich. Можно спрашивать вам один вопрос?
Can I ask you a question, if you allow me? He has left. He has left. We can pass your question on to him. Okay, never mind that. Okay, all speakers did well. All the presentations were very interesting. We learned a lot. We've heard of many problems and challenges. Thank you very much for your speeches. And we thank Mr. Mursalov. That's it from my side. See you soon. Thank you and goodbye. Our session is over.
শেষ হয়েছে ভালো। আমি আবার কনক্লুসিভ ইয়ে দিছি বক্তৃতা 7টা
Hello, can you hear me? Hello?
Yes, dear professor, we will start in 4 minutes, okay?
All right, fine, okay.
Thank you.
Thank you very
Please
much.
do not turn off your camera. Thank you
No,
very much.
microphone is all right?
Yes, microphone is great. Thank you.
Okay, thank you.
Dear Christos, it's Dennis. I will translate you into Russian. Nice to see you. You're looking just great.
Hi, Dennis. I cannot see you.
I'm
but
here in Astana.
I can recognize your voice. I still can recognize your voice after so many years.
But you know, it's a big pleasure for us to see your these presentations that I loved since Kaunas, this event in Lithuania. Then we've seen them in Karaganda, and we'll enjoy them for sure.
Thank you so much. Thank you so much. It's nice, very nice to hear from you, really.
Okay.
Look forward to see you again sometime in the future.
I also hope that you will visit us here in Kazakhstan.
So please, dear professor, could you please choose interpretation mode? So you should choose English language. It's in the below of your screen. That's the globe sign. If you see it, the globe sign.
Yeah, it's English.
Yes, and English. Yes, tap English. So you in this case you listen on and hear only English interpretation. Okay.
Actually, I'm speaking in English. So do you want me to put it?
Yes. But if you will not choose English language, you'll hear Russian language. So
no.
that's why you should choose English. Thank you.
Okay. All right. Where's my co-chairman?
Pardon?
Where is my co-chairman, Dr. Ospanov?
He is here in our studio. So you will see him when we will start the live. Okay. It will begin in 2 minutes.
Okay, I will be happy if he starts because he's with you and probably more familiar with the system. So I think it will be better for him to start. Okay.
Okay.
Probably he will present. He's speaking. He's giving the first talk. No. No. Okay. So he should start. Good.
Good afternoon, dear colleagues. We continue the session devoted to traumatology. Moderator is Professor, Doctor of Medical Sciences, Head of the Orthopedic Department of the General Profile Hospital, Christos Karvanos. Doctor of Medical Sciences, Professor, Head of the Orthopedic Department of the Central Scientific and Research Institute named after Priorov, Lazarev, Anatoly Fedorovich, and myself, Ospanov Konur Shtolievich, Head of the Scientific Research Center of our Scientific Center. The first presentation is dedicated to the new fixator for osteosynthesis of trochanteric femur fractures. The presentation is provided by the head of the traumatology department number 2 of National Center for Traumatology and Ортопедии, named after Batpenov, Mr. Stepanov Alexander Alexandrovich. The floor is yours. Hello, good afternoon, dear colleagues. Let me introduce to you my report on the new fixator for synthesis of trochanteric femur fractures. The relevance of this problem is known to everyone, and it is based on several reasons. First of all, this is the high frequency, which is from 30 to 50% of the total number of femur fractures according to the results of the different authors. Secondly, this high percent of unsatisfactory results, 23.9 to 43%. All the above stated indicates the relevance of the selected topic of the scientific research, which was the basis to make the study we have done. The purpose of our study was to improve the results of treating the patients with trochanteric femur fractures by development of a new device for osteosynthesis. The objectives of the study was to develop the new device for osteosynthesis of trochanteric femur fractures and to study results of application of the new device for osteosynthesis of trochanteric femur fractures. The novelty, scientific novelty based on the intramedullary universal pin and proximal femur nail PF, and the new device was created and designed for trochanteric femur fractures, and patent of the Republic of Kazakhstan was received for it for the innovation number 33450, dated 11th of February 2019. Stable fixation of the bone fractions and stabilization of the neck screws is achieved by the fact that the holes on the neck screws on the proximal end of the new device are made with the angle of 3 degrees towards frontal part and 3 degrees backwards from the vertical axis. Operation, the surgery is done with epidural anesthesia. The patient is laid down on the orthopedic table, close reposition with the control of the electron-optical image intensifier is done. Then the surgical access to the upper part of the great hunter is done with the length of 5 centimeters with the hand manipulation of the marrow canal. Then after the assembly of the system, the intrabone core is manipulated with a special arm, and the intrabone nail is introduced into the marrow canal, and at the end we make block of the distal end of the device with the screws. The feasibility study was, a mathematical study was made for our device to substantiate the nature of the stress. For prototype and suggested device have similar dependence, and the maximum summer accumulative transition of the suggested device was 5.1 millimeter and 7.3 prototype stress. And maximum values for the suggested device was below, it was 92 megapascals and prototype 127 megapascals. The received results prove that the suggested device ensured more stable fixation of the bone fractions due to prevention of migration of the neck screws in the distal direction. This study was based on analysis of the results of the surgery of 72 patients with the trochanteric femur fractures, which were treated in the traumatological department number 2 of the Scientific and Research Center named after Batpenova in the period from 2017 to 2019. The patients were divided into the control and main group. 42, which is 58% of patients, were in the control group. In the reference group, the surgical treatment was made using PFN. The main group consisted of 30 patients, 41.7%, who had osteosynthesis of the femoral bone using the new device. All these distributions in this table, you can see distribution of the patients by age and sex. You can see most of the patients were the people above 6 years old, which corresponds to the data of the other studies. In the total number of the patients, the majority were female, 47, 65.3%, 25 male, 24.7%, almost 2 times more women than men. This is explained by the hormonal changes in the organism of the ladies in the postmenopausal period. Distribution in this table is shown with the trochanteric femur fractures depending on the type of traumas. In this table, you can see the patients who received the injuries at home. In the street, 32%, at home, 52%. The household traumas are low energy fractures which occur with a minimum injury based on the developed osteoporosis and reduced geriatric reaction to the changes of the position of the body. In the traffic accidents, there were 9.7 patients, occupational injury 5.6%, 76 patients, 86.4% of all the patients have the direct mechanism of trauma. Distribution of the patients according to ASIF, 34 patients had 47.2%, the second ranking 29 cases, 40.3%, and A3 fractures in 9 patients, 12.5% of patients. Distribution of patients depending on the used constructions and structures according to this table for the osteosynthesis of the upper fractures of trochanteric femur fractures. Those who had mathematical justification, the control group patients had the proximal femoral nail, PFN. Results of the surgery treatment were assessment based on the Matisse scheme. This scheme is universal and may be used to study outcomes of the fracture treatment. The outcomes of treatment of the patients with the trochanteric femur fractures, we had good results, better in the normal group, main group compared to the reference group, 82.2% against 68.6%, almost 1.25 times more. Satisfactory results were more observed in the reference group, which exceeded the main group 1.3 times, 20% against 14.3%. 5.4% more. The number of patients with unsatisfactory results in the reference group made up 11.4%, which is 3.5 times more than in the reference group, being 3.5%, and it is 7.9% more. Outcomes of using the new device for osteosynthesis of the trochanteric femur fractures had 82.2% of good results of treatment, 96.5 positive results. Good and satisfactory. In the reference group, good results of treatment made up 68.6% and positive 88.6%. Unsatisfactory results of treatment in the main group were 3.2 times less compared to the reference group, 3.5% against 11.4%. Here, one of the clinical cases, patient 65 years old, came in 2017 as a result of traffic accident. After the pre-operational preparation, the surgery was made. Osteosynthesis was done on the left femoral bone. In 10 months after the osteosynthesis with the new device, it was removed. Conclusions. For the stable functional osteosynthesis of the trochanteric femur fracture, a new device was developed which allows to have stable fixation of the bone fractions before the fracture is united and to make early functional treatment of the patients. The mathematical calculations of osteosynthesis with the new device of the trochanteric femur fracture showed high fixation properties of osteosynthesis with the developed device. Clinical absorption of the new device in patients with trochanteric femur fractures has increased the frequency of good results of treatment 1.2 times, which reduced the frequency of satisfactory results 1.3 times and unsatisfactory results 3.5 times compared to the traditional treatment. Thank you very much. Thank you for your presentation. And now we would like to give the floor to Professor Christos Garvanos with a presentation, the use of blocking screws for the closed reduction of difficult proximal and distal femoral fractures.
Hello, good afternoon. Actually, it's a good morning for me in Athens. It's a great pleasure to participate in this excellent scientific event, and thank you very much for the invitation. So I'm going to tell you about the use of the blocking screws for the close reduction of difficult femoral fractures. And nothing to disclose. We are all of us probably aware that some fractures, femoral fractures, are difficult to reduce by closed means. And by saying that, I must admit that the most popular alternative, if traction alone fails, is the clamp-assisted reduction and circular wiring, which has produced several papers in the past. However, if we see a picture like this that I'm just showing you now, then it's almost not absolutely almost certain, but it may be that the clinical situation is something like that. This is something that we certainly do not like. And if we see these post-operative pictures with a circular wiring in these subtrochanteric areas of these femoral fractures, we probably can expect that we will have increased rate of some complications like failure of the implants or non-unions or infections, because we have actually violated a lot the biology, and biology is revenging if we violate it. The blocking screws have been introduced about 20 years ago for the treatment of the distal tibia fractures, as we can see here in the beginning, because we saw and we actually admitted that the blocking screw keeps the nail in the desired position, reduces and stabilizes the osteosynthesis. And that's why surgeons tried to use the blocking screws in other areas of the fractures of the lower of the leg. So for the femoral fractures in difficult problems, so we need to find some solutions that probably will give us some better results. One question that actually faced, and most times when I do these lectures, is where would be the point of insertion? Is there a rule? Well, there have been many rules, but the rule that I actually follow is that the blocking screw should be perpendicular to the direction of the fracture displacement in contact with a guide wire at its side that indicates the direction that the bony segment that carries the blocking screw should move in order to meet the other bony segment and reduce the fracture. So we see in this example here, the blocking screw has been perpendicular to the displacement, which is a mediolateral insertion of the blocking screw while the displacement is the antero-posterior level. It is in contact with a guide wire, and actually on the side of the guide wire that indicates the direction that this bony segment that carries the blocking screw should move in order to meet the other bony segment and reduce the fracture. And another example here in the fracture that happened above a total knee arthroplasty is that the blocking screw was decided to be positioned in the distal bony segment. So from which direction? In the direction and in the position anterior to the guide wire, as the bony segment that will carry the blocking screw needs to move in order to meet the other bony segment and reduce the fracture. So here we go to our examples. In order to be understood, what's the offer and the service that the blocking screw offers. A segmental femoral fracture in a 31-year-old male after a road traffic accident. It's a significant displacement, especially at the distal bony, at the distal fracture site, which actually is intracondylar as well. So we see here the displacement on the lateral level. It's quite a lot. Here is the positioning of the distal fracture in the operating table and under traction. We see that it is not absolutely acceptable, but my assistants insisted that if we introduce the nail, just the nail, this will reduce the fracture and will give us the solution. So I do that because I always want to prove that this is not always the case. And this is the situation after the introduction of a 12-millimeter nail. We see that the situation is not acceptable. So the nail was withdrawn and the blocking screw was inserted in the middle bony segment, the free one, at its distal part. It's an antero-posterior blocking screw. On the lateral side of the guide wire, it is the side where the direction indicates the direction that this bony segment should move in order to meet the distal bony segment and reduce the fracture. Then another blocking screw was inserted at the distal bony segment in order to deal with the displacement on the lateral level. And here, the blocking screw was inserted anterior to the guide wire, as this is the direction where the bony segment should move in order to meet the most proximal bony segment. So after the introduction of the nail with these two blocking screws in situ, the situation is much better. And 4 months later, the patient is actually fully weight-bearing and back to his activities. Another example here is another segmental fracture, but here the proximal fracture is intertrochanteric. So now we are talking about an antegrade nailing, not a retrograde one. And you can see the displacement on the lateral view, which is very impressive. So in the operating theaters, the situation after retraction is quite acceptable proximally, but it's not acceptable distally. So provisionally, I ignored the distal fracture and I introduced the guide wire as usual for intertrochanteric fractures up to the distal fracture. So I rimmed the femur up to that level, and with the use of the joystick that most companies that produce intramedullary nails offer, I used this joystick as a lever, reduced the distal fracture, and passed the guide wire down to the intercondylar region. And that seems to actually offer a good solution, an option. We thought the operation almost finished as we rimmed, and everything looked all right. But as the nail was going down, it was noticed that it was going towards the medial side of the knee, the medial femoral condyle. And this was actually a problem because, bearing in mind the proximal fracture, the intertrochanteric fracture, where that indicated and actually needed the nail to be in an absolute perfect position, not deeper, not in superficially. We thought that if the nail will remain in the middle line after the removal of the guide wire, or if the nail will remain in situ while inserting the distal locking screws or not. So in this case, I thought that the blocking screw should be introduced In this position at the distal bony fragment, you see the nail in situ just proximally, not to reduce the fracture, but to divert and the nail to its optimal position. So here is the anteroposterior blocking screw diverting the nail in the middle of the femoral condyles, and then the nail was introduced up to the optimal level to accept the lug screw proximally in AP and lateral use in a good place, and the locking distally just with the two locking screws, and the blocking screw is just in between them, offered a good option and solution and the resolution of the fracture, as you can see in the postoperative films. Now let's move to the proximal femur. Here we have also some situations which are not quite easily reduced and easily handled, and we need to do something in order to keep the close reduction as possible. Here we have an 82-year-old lady. You see the long spiral subtrochanteric fracture and the great displacement on the lateral view. Intraoperatively, we have a very good position on the AP view, but in these cases, most of the traumatologists know that the lateral can be completely unacceptable with great displacement. Here, we have an 82-year-old fragile anemic patient. So, a blocking screw at this level, at the proximal fragment, mediolaterally, can actually be introduced. Here, the screw was introduced without the K-wire. By experience, we knew about the level that we should introduce the blocking screw. The guide wires go above the blocking screw, as you can see here, and with the joystick that was used as a lever and the blocking screw as a fulcrum, the fracture is reducing, and the guide wire goes straight down to the distal femur without opening the fracture site, as you can see here. Then the nail is introduced above the blocking screw. The question here is if the nail will have, if there will be enough room, enough space for the nail to be introduced between the blocking screw and the anterior cortex. But it seems that the calculations were correct, and the nail is introducing, as you see, going down, the fracture is reducing. And when it goes to its final position, the fracture is completely reduced. It's an anatomical reduction just with this blocking screw. Post-operatively, it's a very good position situation. The old lady was able to stand up without any problems on the next day, and very minimal blood loss and the minimal disturbing of the biology. Now, this is the last case I'm going to show you, actually one from the last. It's a case that we have again a subtrochanteric fracture, but here the displacement is lateral. It's not so much anterior, but lateral. And we can see that here, the medial cortex, just below the lesser trochanter, is missing. So here, the blocking screw comes to actually substitute the medial cortex. And you see as the nail goes down, actually the screw is on the medial side of the guide wire and the nail, because this is the direction that the proximal segment should move in order to meet the other one and reduce the fracture. Here is the end of the operation, and at 4 months, we have an excellent healing without disturbing the biology. Sometimes the proximal fragment is very short, as you can see here, the displacement is great. And here again, the situation after the traction is not acceptable, but the blocking screw at the middle of the at the lateral side of the nail should reduce the fracture and offer in a good resolution. Now, systematic review of the outcomes of the polar screw augmentation is a review that has been done a year ago. And in this review, the authors recognized only 4 papers that were dealing with the use of the blocking screw in the proximal femur. In this paper, the authors they reported some disadvantages related to the use of the blocking screws, and we need to report these disadvantages and present them here. So fluoroscopy and operative times are longer than fracture reduction by clamp and circular wiring. But of course, saving the biology and protecting the biology is a greater advantage. Also, the authors think that the propagation or creation of a fracture line while introducing the nail after placement of the blocking screw can happen, but this is an anecdotal complication. The complications reported in this review are few and are actually comparable to the complications that happen during the operations where the blocking screws are not used. For conclusions, well, although the successful insertion of a blocking screw requires more operating time and more fluoroscopy, can be considered rewarding as the alignment of the limb is restored without exposing the fracture site. The soft tissues around the fractures are protected, the fracture hematoma is maintained, and the enhanced biomechanical strength of the fixation allows early rehabilitation and weight bearing. However, it should be stressed that the use of the blocking screws requires good experience with intermedullary nailing techniques. Well, thank you very much for your attention.
Спасибо большое, профессор Гаранов.
Thank you so much, Professor Gaivanas, and you will have your next presentation. The use of new novel minimally invasive technique for the management of complex bicondylar fractures of the tibia plateau, suprapatellar nailing, compression bolts, and grafting with freeze-dried allograft combined with autologous concentrated bone marrow. The floor is yours, Professor.
Okay. Okay, well, thank you very much. And now I'm going to present my actually research over the last 10 years about what you have already described. I'm not going to repeat it. Nothing to disclose, of course. And we are talking about fractures that are complex. They include both tibial condyles and are classified with the well-known classification of Satke as Satke type 5 and Satke type 6. The management option for these fractures universally, globally, is actually that these fractures are managed with screws, with plating and screws, and with external fixation techniques. However, open reduction internal fixation although is a very widespread method, it doesn't doesn't appear attractive to me. And the main reason is that we have this situation here. And as you have understood from my previous lecture, I don't really like exposing the fracture sites and violating the soft tissues if I can manage the problem without doing that. So the MIPO plates, minimal invasive plating osteosynthesis, have been during the last year popular, but sometimes the situation is not as expected because sometimes the situation is not so less invasive. As we can see in this picture here, which has been published in JBJS as an example of a minimally invasive technique, if we add all these small incisions, I don't think that this will be such a less minimally invasive situation. And also, if we see this X-ray here with this fracture that has been treated with this minimally invasive plating, then we see how this plate was inserted in theaters. It's not infrequent that we have this situation here. Also, complications of blocking plates have been reported a lot, and there are many more than we expect. I am not in a situation due to the time limits to go through each one of them, but the reported complications of the locking plates have been many. External fixation techniques are popular, as I have already said, but the drawbacks include the pin trap infections, and especially if we have problems with the pins inserted close or through the knee joint, and we must think about the possibility of a total knee arthroplasty in the future. We also know that there is problematic control in osteoporotic intra-articular fractures, as we have seen in many cases in older patients. And of course, we can only accept that the external fixation, the fixators, are too bulky to manage, and patients do not like them. So what I really thought is, how can I escape from this situation and offer a good solution to my patients? Is if we implement the tibia nail, a simple tibia nail, and especially over the last 5 years, but with the use of the suprapatellar technique, Also, if I take the bolts from the supracondylar nailing system, the compression bolts, I also, if I use the strong guide wires and the measuring tools that are available in the ASNI's set of tools, then if I use the bone marrow that I aspirate from the iliac wing just before the operation starts in theaters, with the combination of the freeze-dried allograft. And I'm going to show you how I use all these in a specific case that you can accept. It's not a simple one. It is a complicated, it's a complex fracture of the tibial plateau with a significant impaction of the lateral tibial condyle and comminution. As you can see here from the slices of the CT scan, the situation is really complex and quite difficult. So, just before the operation starts in theaters, I aspirate about 60 to 80 or 100 ml of bone marrow from the iliac wing. I centrifuge this sample of marrow, and then I collect the concentrated marrow into a sterile pot. Then I introduce into this pot this freeze-dried allograft until it will become like a sponge soaked within the marrow. I left it on the side. I leave it on the side. Then I turn to the patient, which has been positioned in this position for the suprapatellar nailing with his knee in the semi-extended position. And these are my first intraoperative views, AP and lateral. You see we have a good reduction to the metaphyseal area. Of course, the impaction is there. And the comminution of the articular surface has not been affected. Then a small incision is performed on the lateral side of the knee, about 3 to 4 centimeters, possibly less is feasible. And through the small incision with a lever, I try to reduce and elevate the impacted articular surface. You see here the AP and lateral views just at the beginning of this action. And there is at the end when the articular surface has been elevated to the desired level just with this lever. Then the bone graft is introduced. You see how nicely it's soaked with the bone marrow to the cavity that has been created with my elevation and impacted there. You see the X-ray at the end of the impaction. Then the two compression bolts are inserted in the proximal tibia in the posterior and middle part of the tibia to support the elevated articular surface. And now nailing starts, as you can see here, but there is a small problem with the reduction in the metaphyseal area. But it's a small problem because, as you saw in my previous lecture, a blocking screw can actually do the job and help us reduce this displacement without opening the fracture site. And here are the final X-ray AP and lateral views. At the end of the operation, 2 additional screws have been inserted at either sides of the nail proximally to reduce and fix the elevated tibial tubercle to its position and secure it there in order not to prohibit the mobilization of the joint. You see the appearance of the knee just after the operation, the following day. A post-operative CT scan confirms that the reduction of the articular surface is good and the fixation of the fracture appears acceptable. 10 weeks post-op, we see that the fracture is almost healed because the violation of the biology has not been performed. The soft tissues are undisturbed and the healing is fast. And you see that the patient is able to move his knee almost into a full range of motion post-operatively. The question that most of my colleagues, almost all of my colleagues are asking when I present this technique is this fixation strong enough? So we had this question as well. So we tried to sort the problem with an experiment. We used saw bones of the latest great quality, and we fixed 6 of them with the dual blocking plates, the ordinary plates that we used in the past, 6 of them with a lateral locking plate, and 6 of them with the new the nail and the bolts with the new technique. Actually, the fractures of the saw bones have been created to be exactly the same as such a type of 6. We tested these samples until failure, and the result was published in Injury. And the conclusion is that the proposed new technique demonstrated flexural behavior similar to single lateral locking plating, while maintained a rigid intra-articular stability similar to dual traditional plating. So actually, it seemed that we were in the correct path. I'm going to show you this case of a very extended, very comminuted, very impacted, and quite nasty fracture of the tibial plateau, extended, but the patient appearance is really even worse. 150 kilograms, diabetic, with a bad vascular disease down to his both legs, especially on the injured side. Immediately post-op, this is the appearance of the leg. And what happened in theaters is that 5 months post-surgery, the fractures are almost healed, good alignment, quite good appearance of the articular surface. The patient is moving his knee towards almost full range of motion, and he started walking while he had actually lost some weight and started walking in the clinic, and he's a bit afraid, but situation has been really very good. This experience has been reported in the JBJS 3 years ago with 17 cases having at least 2 years follow-up. The main results is the operation time of the technique was less than 2 hours. Partially weight bearing averagely was almost at 2 months. Fully weight bearing at 3 months. A knee range of motion 0 to 100 degrees, and the scoring to the KOOS system was 95.77 averagely. The complications, well, in one case of secondary displacement, removal of the bolt in 2 cases, 1 and 2 years after the fixation due to the irritation at the medial side of the knee, and 1 case of patellar tendon tendinitis that resolved over time. Finally, there was 1 case of unsatisfactory reduction, as you can see here. Of course, it's unsatisfactory reduction. This was a redo case, and after the case was redone, the articular surface was good and the reduction was good. Advantage of the technique is that certainly allows axial loading, early rehabilitation, return to activities, as you can imagine. That there is shortened time from injury to operation, especially in cases where there is a lot of soft tissue problem, because the operation does not involve the main tibia, is actually around the patellar tendon, where the soft tissue problems are usually less or non-existing, as you can see here. The surgery is minimally invasive, and for that reason, there has never been used of a tourniquet, and there has never been a use of blood transfusion. In no cases there was a continuous passive motion required, and all patients regained full range of motion without physiotherapy within 2 to 6 weeks from surgery. The combination of freeze-dried allograft with a concentrated marrow seemed working quite well. You see a case here that was grafted on the lateral side, that you see in this post-op X-ray that the graft is quite obvious. It's denser than the other side, but 2 years later, you see the incorporation of the graft is great, and it's almost, there is no difference to the appearance of the other condyle. In extended and segmental fractures, this method can offer great serving, as actually can deal with both fractures, proximal and distal, as well, as you can see here. And in open fractures, after some days of external fixation, just to deal with the great soft tissue injury, as you can see in cases like the one I present here, then the new technique can actually allow the plastic surgeons to perform their reconstructive techniques without prohibitions and without plates or external devices just over the area. Well, in 2015, Cochrane Library reported a review about the surgical fixation methods for tibia plateau fractures, and they reported that the evidence does not contradict approaches aiming to limit soft tissue dissection and damage or to avoid autograft donor site complications through using bone substitutes. So it seems that in this Cochrane review, library review, actually proposed what described in this technique. Some or many, all of you may think that what is done is beyond the limits. Well, what I respond, actually my response is that extreme ideas today could be researched tomorrow and routine practice in the future. And thank you ever so much for your attention. Thank you.
Следующий доклад. Открытая репозиция.
Next speech is an open reposition with the internal fixation when it comes to the fractures of the tibial plateau, planning and strategy. Stefan Frenzel from Austria, please.
Не видим, не слышим.
Can you hear me now? I hope so.
For sure, we hear you.
That's good. So please interrupt me if you have any problems with the translation or if you have problems seeing the slides. Welcome from Vienna again, as this morning already. I don't have to declare any conflict of interests, and I'll go right into the topic of open reduction and internal fixation of tibial plateau fractures, with an incidence of 1% of all fractures, but it's getting more and more common, especially in elderly patients. Isolated fractures of the lateral tibial plateau are the most common ones, but you also have isolated fractures of the medial plateau or combinations bicondylar fractures. Associated injuries that you have to look for are open fractures in up to 3%, meniscal tears, very, very common, ligamentous disruption, also common. Look and try to prevent compartmental syndrome whenever possible, because that's something that you have to face quite often as well. Perineal nerve lesions or popliteal vascular lesions are also associated injuries that you have to keep in mind. Treatment goals: restoration of articular congruity, correct axial alignment, joint stability, also very, very important. Functional motion, as you have seen in the presentation of Professor Gavanos before, is an aim that you have to go for as soon as possible. And very important, the prevention of post-traumatic osteoarthritis. Talking about post-traumatic osteoarthritis, that's something that might be caused by the bone quality, by residual instability, or by malalignment, but not by the degree of initial articular depression. So aim for the best possible articular recreation after the fracture. Diagnostic tools: conventional X-ray, at least in 2 planes, CT scans for diagnostic, but also for classification. That's important, and for preoperative planning, and if possible, also go for 3D scans for optimal planning of your operation, and MRI for soft tissue imaging. Classification: AO, the standard classification. The Moore classification is one of the most traditional ones, and the Schatzker classification, very well established and also mentioned by Professor Gavanos in the talk beforehand. And the Schatzker classification was revisited in 2018 to keep the plateau plane also in mind when planning for the operation. So that's, I think, a very useful and very elegant addition to the already well-established Schatzker classification, as indicated in those slides, where it helps to plan your operative treatment correctly, and especially to look for dorsal aspects of malposition after the fracture. And if you see something like that, keep it in mind, and as indicated with the plate here with the C, don't be afraid to go for an additional approach for the best optimal repositioning of the fracture. Krause already established this approach, and the enormous importance of especially those dorsal aspects of possible fractures where you have to go for the best possible repositioning. Indications for operative treatment, of course, they're quite flexible, but at least at my department in Vienna, articular displacement of more than 2 millimeters is something that should guide you towards operation. Articular fracture in the weight-bearing area, a valgus or varus instability of more than 10 degrees in less than 20 degrees of flexion, open fractures, and compartment syndrome also is a classic indication for operative treatment. That's a case treated at our department with the fracture of the lateral tibial plateau. Here you see the CT scan according to this fracture site and the operative treatment with a lateral plate and also bone material that was a bony cylinder that was brought into the fracture before bringing in the plate. In principle, 4 steps that you have to follow. Articular fractures have to be reduced and stabilized, fixated as one articular bone block. Then an additional fracture, if there is one, has to be bridged, and fixation to the shaft, where you can see here, that's a quite old school picture. Now we do bicortical screws, so don't be misguided that we might only use monocortical screws in these cases. Another case with a varus collapse, medial plateau involvement, osteoporotic bone, and a quite short proximal segment that was treated by an additional lateral and medial plate. And as an option, you could also use a medial external fixator. The implants that we use, angle stable implants, LCP or LIS plates, T or L-shaped plates, and maybe in addition or only the use of screws, which have the advantage of being less invasive. Intraoperative arthroscopy, a quick word about it. If feasible, yes, it can help you to deal with intra-articular concomitant injuries, and it's a very useful tool also to evaluate your repositioning of the articular surface. Complications that you have to deal with: infection, as mentioned by Professor Garnavos already, loosening of implants in up to 12%, development of pseudarthrosis postoperatively, post-traumatic osteoarthritis, secondary displacement or sintering that can also occur, especially if it's in the weight-bearing area of your tibial plateau, instability, especially if it's left after the operation due to insufficient addressing of concomitant injuries, movement restrictions or joint stiffness, and local soft tissue irritations. Reasons for secondary displacement: inadequate technique or the usage of the wrong implant. A very common reason for secondary displacement. Implant failure, less common. Wrong screw position to support the articular surface. Once again, especially if you're dealing with fractures in the weight-bearing area. Bone defects or resorption of the bone due to poor vascularity or due to occurring infection. Avoiding secondary displacement by cancellous grafting, by bone graft or autograft substitutes, and where, as was suggested in the talk beforehand, and maybe consider inflation osteoplasty if this is feasible for you at your department. So to conclude this short overview of open reduction and internal fixation of tibial plateau fractures, sufficient diagnostic investigations are enormously important. Then, based on this information, choose your correct indication, plan your procedure accordingly, and be aware of the possible complications that you might face afterwards. Thank you very much for your attention, and greetings from Vienna.
Следующий доклад. Спасибо огромное за интересный доклад. Я с удовольствием.
Thank you so much for your presentation. Now I'm happy to present Dr. Ibraev from Kazakhstan using blocking synthesis during distal fractures. Is it Ibraev or is it Dr. Klaus? It's Dr. Klaus Schanz. because our program has changed. So it's Dr. Klaus Schatz. From the 1st of October. Sorry for technical hiccups. Dr. Klaus Schatz, arthroplasty using key element without the pod from Austria. The floor is yours, Professor Schatz. Yes, we can hear you.
Can you hear me?
Yes, we can hear you. Yes, we hear you.
Warm greetings from Vienna. Can you hear me? Can you see me?
Осталось две только. А кто должен сказать?
Yes, we can see you. We can hear you.
Dear professor, can you hear me?
Dear professor, please share your screen. Like yesterday. Yes, you should tap share screen and tap desktop and open your presentation, please. Thank you. Dear Professor Schatz.
Yeah, one moment, please.
Yes, please. Please share your screen and open your presentation. That's your turn.
One moment.
Да, цифровое будущее как-то еще не это.
Good morning, everybody. Can you hear me?
Yes, we can hear you, but please, Professor, share your screen. Thank you.
Yeah, we already tried to.
Just like yesterday.
Yes.
Yes, that's great. Thank you. You may start.
Okay, so we can start?
Yes, you may
please start.
So thank you, first of all together for inviting me to this meeting. My topic today is to talk about joint replacement of the shoulder. And I would like to give a short overview of the systems we are using right now in 2021. When we are talking about joint replacement, we are talking about a reconstruction of a joint in order to perform and achieve a reduction of pain and optimal biomechanical function. We would like to reconstruct the anatomic situation and a stable center of rotation. That's what we want to achieve. How can we do this? Back in the 90s, starting in the 70s already with the near endoprosthetic device, We have endoprosthetic devices to do that, first generation up to the fourth generation. In the 70s, everything started with a monoblock prosthesis designed by NIR. It's a classic device still used today in cases because, of course, it's a very cheap endoprosthesis and it still works quite well. The problems, of course, were the radius of the glenoid and the humerus head were the same, which resulted in a very stiff congruency and a slight tendency towards overstuffing. So the further development of second generation and third generation addressed these problems, and the radii were changed, and also the inclination, the eccentricity of the systems were changed. We went and changed to more modular systems, which gave more possibilities to individualize the system and reconstruct the anatomic situation like the normal one. The last big step was the fourth generation, also back in the late 90s, with the aim of complete modularity and movement of system around all three axes, with the possibility of infinitely variable head and shaft stem situations. The total arthroplasty of the shoulder works well if the indication is right. We use it very extensively in osteoarthritis, more than 80%, but also in fractures, of course. Also comminuted fractures work well. Even the results are a little bit worse in the traumatic cases. The results very much depend on the healing of the tuberculum, the major, which also leads to different designs of prosthesis. Indications which are not cleared for total arthroplasty are cases with rotator cuff defects, with big bony defects, infection cases, of course, and these situations in many cases lead to overstuffing, incorrect soft tissue balancing, resulting in instability and loosening. The biggest problem always was, and still today, is the malpositioning of the components, which lead to an eccentric stress, especially on the glenoid side, with loosening and polyethylene disease at the end. You can see this here described by Madsen, 1998, the rocking horse phenomenon, when we are ending up in a situation that's not adequately soft tissue balanced, we will have an unsuccessful outcome, as you can see also here in the clinical cases, case with aseptic loosening, with instability, and at the end a dislocation of this elderly lady. These are the pictures, and as you can see here, the problem from the beginning was an inadequate soft tissue balancing, overstuffing, of course, and over the years, polyethylene disease, loosening, and at the end also infection of the system. Shall we implant the glenoid? The glenoid is always the weak part of the system, with a high potential of loosening. We are very thankful to the classification of the osteoarthritis of the shoulder given by Sheil Walsh, who described very clearly the morphologic aspects of the glenoid side and gave us this classification. Everybody who is dealing with osteoarthritis of the shoulder knows. Type A with a centered head, type B with an eccentric head, with posterior subluxation, and the type C when we are talking about dysplasia of the glenoid with a retroversion of more than 25 degrees. This old classification coming from 99 still is valid and still is used in order to find the right indication. Should we use a glenoid or shouldn't we? And if yes, which kind of glenoid is adequate? In type A, according to the Walsh classification, we can decide whether we would use hemiprosthesis or total arthroplasty. In the type B, it's only total arthroplasty that can be used. And of course, a contraindication for glenoid prosthesis, or in the distance between the humerus and the acromion, the shaft, the neck head angle, and the lateral offset. Of course, all these things are planned in our department by using of CT scan, preoperative planning, and trauma cut or autocut. What about overstaffing? That always has been a main reason for loosening. We this could be shown by many studies. We have a limit of around 3 millimeter of lateralization or medialization. If we medialize the center of rotation 3 millimeters or more, the result will be significantly worse in comparison to other situations where we lateralize the center of rotation. That means overstaffing, of course, has been shown to be one of the major reasons to lose an implant. Here you can see a medialization of the center of rotation more than 6 millimeters with a clear overstaffing of the system, leading to a very bad result. This device has been understaffed intraoperatively. It was not planned, but happened. But we could see that an understaffing provides a much better result than an overstaffing. And this patient, for example, is doing very well. However, it is understaffed. Other cases like this one here, I just go through this very shortly. As you can see, the head is a little bit big here. The center of rotation is lateralized a little bit, but the lateral offset was less than normal, and this provided, in this case, a very good result. Again, I want to come back to this 3 millimeter medialization thing. It is important that you do the planning preoperatively with the CT scan using any kind of trauma cut, autocut, or whatever to plan your angles, your sizes, and in order to avoid the overstaffing. Reverse total shoulders, stemless, are available, but we do not use them extensively at the moment. We are a little bit holding this back because it has not been shown adequately that these systems are reliable also, but it seems to be like this. So we expect also good results in the reverse TA on the long term. You can see here an example, the first reverse total arthroplasty back in 2004 from Biomed. It was stemless reverse arthroplasty, which works very well. But again, we have not enough studies for that. The results, again, between stemless and stemmed prosthesis are comparable. We have no problems with loosening or polyethylene wear. Also, on the long term, the results are comparable in any kind. And the situation now in 2021 is like this. We can use stemless prosthesis in order to simplify the surgery, in order to have a better and easier situation in case of revision surgery, and to achieve a very fast rehabilitation and good results. All these things basically have been mentioned before. Another point I want to focus on, the operation itself, the surgery is way easier, way faster, with 70% less steps intraoperatively and 50% less changes of instruments. So all these things have been mentioned before. We are using these devices and are very happy. Of course, you have to follow the rules, accept the right indications, and do a proper pre-operative planning. Thank you very much.
I'm happy to present next presenter, soft tissue reconstruction after trauma and resection and tumors. This lady is like a fairy for the Cinderella, and she can easily remove defects on the soft tissues. The floor is yours.
Hello.
Professor Schulz, now it's the next speaker. Professor Chance. The next speaker will be speaking now. Please unmute yourself.
Hello, can you hear me?
I can hear you, so I think I'm next.
Okay.
But I think we lost our moderator, so just to let you know that we can hear you, but our moderator seems to be gone.
I hand it over to you. Thank you very much, and have a nice day.
Thank you.
Can you share your presentation, please?
So good afternoon. May I ask if our moderator is present or how we proceed?
Hello, I don't know if you can hear me. I believe I'm one of the two moderators for the sessions, but I believe that the session is moderated centrally by the base of the Congress. So if it is up to me, of course you can proceed.
Okay, so thank you very much, very kind. Thanks for your help. So I will proceed, and yeah, good afternoon. My name is Professor Radke. I'm the third one from Vienna. So hello from Vienna again. I would like to share my screen. Can you see my slides? Okay.
Yes, of course we can. Yes.
Thank you. So I'm a plastic and reconstructive surgeon, and I like very much our cooperation in trauma surgery and plastic surgery, where we work together very successfully, obviously, is in soft tissue reconstruction after trauma and after tumor resection. These are clinical pictures I think we all know from our daily work. Here you can see an open fracture with soft tissue defect, functional structures are injured. And if you look at the classification of open fractures after Gustiju, when do we cooperate? When does a plastic surgeon get into your game? We need flap coverage in Gustiju 3B and 3C, and where we can offer to do local flaps and free flaps. So what are our goals? We want to have stable coverage for bone, for implants, for example, in the talk before from Professor Schatz, for nerves and for vessels. We want to restore function. Obviously, we want to have some kind of aesthetic outcome, and we need soft, stable tissue coverage for rehabilitation. We have the reconstructive ladder, which you walk up the more severe the injury is. So mostly we start here in Gustiju fractures in local and free tissue transfer. So you can see it again, the kind of soft tissue reconstruction we need is dependent on the localization, on the size, and on the cause of the defect. It's dependent on the quality of the surrounding tissue, obviously if the patient has infections, dependent on previous surgery, the age of patient and comorbidities, and as I said before, we have a little bit of aesthetic, we want to have a little bit of aesthetic outcome. How should the soft tissue be prepared in open fractures? Obviously, mostly there are multiple debridements before. We need a no infectious situation. And said with that, wound coverage should be done as early as possible. And we need for our free flap, mostly what's free flap, sufficient vascularization, and an angiography is necessary for that. Here you can see an angiography. Often we have surprises, like you can see here, stenosis on multiple layers. And in cases like that, we have to see where we can add our free flap and how we guarantee the vascularization. We have several donor areas of flaps. You can see here we have a vast majority, we have a vast instrumentarium where we can harvest flaps, where we can use local flaps. And it's always a question, what flap can we use for which defect? Very challenging are flap reconstructions in the lower leg. In the proximal third, we can use the gastrocnemius, either the lateral or the medial or both. In the 2/3 of the distal part, it's quite more difficult to use local flaps. It's very challenging over there, and we need free flaps, for example, the free latissimus flap. Would like to show you the gastrocnemius flap. Here you can see the drawing, and here step-by-step cadaver dissection. Here for medial gastrocnemius flap, you make the skin incision. As the next step, you prepare the gastrocnemius. You loosen it from the distal part, from the Achilles tendon. You prepare it from distally to proximally. When you reach the vascular situation over there and the nerve, here you can see the vessels. And as a tip, what you read rarely in books, you should denervate the gastrocnemius. And then you can rotate it in the arc of rotation to the needed defect. To go now one step further, we can use microvascular flaps. So it's the next step on the reconstructive ladder. For that, you need an experienced microsurgeon. You need the possibility to harvest field flaps. You need microscope and the instrumentarium. You need the forceps and the scissors and the needle holder for microsurgery. The latissimus dorsi flap is a very versatile flap we can use very often because you can use it as an fasciocutaneous, musculocutaneous, or musculocutaneous flap. So there are a lot of varieties. And here I would like to show you the step-by-step preparation as well in a cadaver dissection. So you make the incision in the medial axillary line. From there, you can prepare easily around the latissimus dorsi flap. You lift the flap from distally to proximally. You can see you can leave a skin island on the flap. The more proximally you get, you can dissect the vessels. Here you can see the vessels very nicely. You have the latissimus dorsi flap over here. You have here the vessels which are being cut over here. And then you can use it in situations like here. You can see the external fixation with a large defect. From the wound situation, you can see that it's a wound which has been open for a long time. You see that we don't have an infection. And this is a situation at the end of the operation. You needed a little bit of skin graft in addition to the skin island on the latissimus dorsi flap. Here you can see another defect. It was an accident at the arm. The muscles are open, the skin is missing, the vessels and the nerves can be seen. Here we performed as well a latissimus dorsi flap. You can see we wrapped it around and we added as well some skin transplantation over here. What's possible as well, and it's a very nice flap because it's a thin flap in contrast to the latissimus dorsi flap, is a ILT flap, the anterior lateral thigh flap. We have very low donor morbidity here. The disadvantage is that we have short vessels and it's limited in size. We can't have that size which we can read here with a latissimus dorsi. Here's an example, again in the distal third of the lower leg. We have a deep defect. You can see the screws over here, and the defect is 6 × 15 centimeters, as you can read here. This is the drawing for the harvest of the ILT flap. Here we could Doppler the vessel. This is a harvested ILT flap, and in contrast to a latissimus dorsi flap, you can see that we have a very short vessel. We only have 6 centimeters. And this is the situation at the end of the surgery with the transplantation of the ILT flap. Contrast to the latissimus dorsi, you can see it's very nice in the niveau of the tissue, but obviously we are limited in the size of the defect we can cover. In addition, we can not only use musculocutaneous or fasciocutaneous flap, we can use osteomyocutaneous flap if you need as well some some bone in addition to the flap. So, and very often we use a free fibular flap in addition with a fasciocutaneous flap. Or what's very nice, you can use as well latissimus dorsi flap, for example, and use parts of the scapula to transplant with the latissimus dorsi. You can see we take the skin, we take the bone, and this is an example of a patient. He had a fracture in his foot and with pseudarthrosis. You can see the pictures here, you can see the clinical photographs, and we performed here a fascio-osteocutaneous flap from the media femur. You can see here, this is our flap. This is a medial femur condyle, and this is the vessel. And this is after harvesting. And this is then after connection to our vessels and to add the bone in our pseudarthrosis. And I showed you a variety of flaps. The question is obviously which flap for what defect, what's the best, what can be good. And it's always dependent on the defect size and available vessels for the microvascular anastomosis. Often we have very difficult circumstances. You need a plastic surgeon, and the patient can be difficult as well, not only the plastic surgeon. Here, our patients have comorbidities. It's age dependent. It's dependent on the defect size, additional injuries, on infection, and as I said, on the vessels. So, but there are more questions, not only what flap is the best for what situation. We have to answer the question, do we do an acute versus delayed wound coverage? What is the indication? Do we do damage control, or do we have alternative therapies? And the major question when to flap is, I think you know the different studies, for example, the very famous Godina study, when we have the best free flap closure. And it's common sense that the immediate to surgery up to 7 days leads to flap survival, leads to an increased flap survival, but we have a reduced incidence of infections. That we have better fracture healing. We have less soft tissue fibrosis, reduced hospitalization, and earlier rehabilitation of the patient. So our studies are confirming that our post-traumatic osteomyelitis is reduced from 30 to 11% if we do a very early interdisciplinary treatment with free flap coverage. We have a reduction of pseudarthrosis from 16% to 6%. We can lower the amputation rate, and in general, the success rate of free flap is 96%. What about the microsurgical emergency flap? That means fix and flap. We do the same time the bones are fixed, we do our emergency flap. To do that, we need obviously the logistics. We need a stable team and a good surgical team. One problem is that obviously with additional injuries, the surgical time will significantly increase. One other question is obviously when to call the plastic surgeon for wound coverage or when to get into contact for our disciplinary work. The best is obviously as soon as possible. This means best situation would be if the patient is admitted to the hospital, call your colleague, call your plastic surgeon, and start the planning immediately together when to do what in what sequence. What is my take-home message? So early soft tissue coverage with free flaps is best under 7 days. For that, obviously, we need a stable patient, non-infectious situation, and an angiography. The incidence for infections and amputations are then reduced. Optimal is the interdisciplinary treatment, and that emergency flap, fix and flap at the same time is always, should be seen with a question mark. Thank you very much.
The next speaker is Mr. Akiljanov, the experience of intravessel balloon occlusion in hemodynamically unstable pelvic fractures.
Hello, dear colleagues. Hello, dear colleagues. Let me introduce you my report, the experience of application of the intravascular balloon occlusion, the hemodynamic unstable pelvic fractures. The pelvic injuries represent one of the most complex problems in the surgery of injuries. Its incidence is about 3%. The pelvic fracture is most common in the young patients. Mortality is quite high, especially with the patient with unstable hemodynamics. That is why multidisciplinary approach is the key aspect in the intensive therapy, in the blockage of bleeding and treatment of the bone fractures, which is most important in the first hours. According to the classification of the Global Society of Emergency Surgery, there are 3 classes of pelvic ring injuries: light, including hemodynamic and mechanically stable damages; medium, which including hemodynamically stable and mechanically unstable injuries; and severe hemodynamically unstable injuries irrespective of the mechanical stability. And in the algorithm of treatment, hemodynamically unstable injuries require, as you all know, pelvic packing, temporary fixation, then application of FBO and angioembolization. Endovascular balloon occlusion of the aorta has become as an alternative to the acute resuscitation thoracotomy, laparotomy, EVBOA, and other endovascular and hybrid methods of treatment are used in different cases of care. In our clinic, we have made we had actually 2 cases of treatment of the patient with hemodynamic unstable pelvic injuries. The first case, I would like to tell you about it. This is patient L, born in 1986. He was received after the traffic accident and injury. During the repair of the car, there was a movement of the car uncontrolled. He was received in the emergency unit. Hemodynamic was 70/40. We made the support for him on 3 vasoconstrictors. We made hemotransfusion. Hemoglobin was going down all the time, and then we decided that he should be taken to the angiography OR. Here you can see the X-ray image of the patient with the injury of the pelvic bones. Then we took him to the OR in the resuscitation unit. The external fixation apparatus was applied. Catheterization was made. All the manipulations were made to embolization. For the embolization, he was taken to the OR. In the position of his back, we inserted the introducer, crossover type. On some images we saw, please switch on the video. Cannot upload the video. So we detected injury of the posterior branch of the upper gluteal artery. Then after that, we made catheterization of the iliac arteries, right and left side internal iliac arteries. We inserted the balloons in both arteries, 2 balloons, and they were inflated to 10 atmosphere. After that, the bleeding was stopped. There were no signs of bleeding. In the emergency care unit, these signs were eliminated in 6 hours. Hemodynamic was stabilized. The pressure was increased to 130. In the morning, without vasoconstrictors, he could maintain the stable condition. We can say it was stabilized. And the second example, this is a picture of our patient in 1 year after the trauma. Unfortunately, he had a rupture of the urethra, and with this problem, he had several surgeries. And during one of the visits, he came to our place and we made a picture to him. He's doing well now, he's healthy and wealthy. The next patient, there was a traffic jam. There was a traffic accident, some logistical problems we had. First, he was delivered to the regional hospital. Then from the regional hospital, he was moved to the traumatological department. In the region, they made massive hemotransfusion there. They applied the apparatuses, stabilized his condition, but still they could see stable reduction of hemoglobin in 3-4 days. Thereafter, he was transferred to the polytrauma department of the first city hospital. This was the injury. After the pre-operative preparation in the first city hospital, hemotransfusion was continued. About 110 hemoglobin. We took him for the operative treatment. For the surgery, we made approach using cochlear logging back. After the incision of the skin, we have identified a defect of the fascia. When we cut the fascia, there was a stress hematoma and the bleeding started. The bleeding started and we invited the vascular surgeons from the vascular surgery. The revision, we have identified that the gluteal artery was bleeding and we decided to make embolization. That was not angio OR, but ordinary traumatological OR. That is why we didn't have time to transfer him to the angio OR. Also, we inserted the catheter and installed the balloon, inflated it to 7 atmosphere pressure. And then in the revision, we have found out that for the final insertion, we need to approach through the laparotomy. At that point of time, the bleeding was about 3 liters. If we would start approaching by laparotomy, we would lose 500 to 700 millimeters. That is why we decided to approach through the bone defect, through the fracture. We insert the clips, we separated the bone fractions, mobilized the ruptured artery, then fixed it and brought together the fractures and made osteosynthesis. Also, the condition was stabilized, the hemodynamics also stabilized. Then we made blood transfusion and brought all the indicators into normal condition. As we said here, we made visualization using this C-band of Phillips after osteosynthesis. The same patient in 1 year after the trauma, he still has some problems, neurological troubles, some vascular lymphostasis, but in general, he is more or less okay. And in conclusion, what we can say is EVBOA of vessels in patients with the pelvic injuries accompanied by the bleeding and expressed hypotony results in increase of the arterial pressure by 40 millimeters, approximately stabilization of hemodynamics, which allows to make diagnosis and treatment care. Then traumatic treatment, the pelvic injuries should be treated by the multidisciplinary team, by the traumatologists, surgeons, urologists, anesthesiologists, emergency doctors, and increase the efficiency in case of polytrauma. We need to arrange the assistance in the hybrid ORs in the multidisciplinary inpatient clinics. Thank you for your attention. Dear ladies and gentlemen, we have finished this session devoted to the acute problems in traumatology and orthopedy. If you have any short questions, we can get short answers for you. So if all the reports have been clear enough and if you have no questions, thank you once again for your attention and for being patient, listening to our speakers, and thank you so much to all our participants and speakers.
Thank you very much for inviting us. Have a nice day.
Hello. Dr. Dural, merhaba. Where are you? Mr. Dural, Dr. Dural. Mahmoud Bey. Dear ladies and gentlemen, I'd like to congratulate you all with the start of our section in this scientific practical conference dedicated to 20 years of our Center of Traumatology and Orthopedics, named after Batpenov. We'd like to start our section today with the first presentation. Will be a scientist from Kazakhstan, Nuрлана Батпенова. 11 years of experience in using PRP tropo cells in Kazakhstan. Good evening, dear moderators and participants of the conference. I'd like to thank the organizers of the conference of the 20th anniversary of academician Batpenov Nurlan Jumagulovich. And we also would like to talk about the 11 years of experience in using PRP tropo cells in Kazakhstan. Microphone. Microphone. The regenerative medicine objective is to create the standardization of clinical application of reliable individualized bioengineering. Microphone. The platelets are the first cells that arrive on spot and play an important role in tissue restoration by emitting growth factors. And in all tissue damage stages and inflammation, cell proliferation, and matrix remodeling, the platelets are key, and activation of their growth factors. The advantage of the plasma-rich platelets compared to other natural and artificial regenerates could be summarized in this way. First of all, PRP is autologous product. It does not have potential immunogenicity and is not transferring infections. It doesn't influence the hyperplasia, cancerogenesis, or tumor growth. Autologous factors stimulate cell migration and damaged tissue regeneration. However, clinical results differ. This is related to different methods of PRP preparation and different growth factors concentration. If we are to talk about PRP, several years ago we said that PRP is a plasma where platelet concentration is 1 million or more. So the more platelets, the better. Now the definition of PRP has changed, and platelet-rich plasma is a fraction of autologous blood with extra physiological concentration of platelets and associated growth factors without an admixture of red blood cells and an acceptable minimum number of leukocytes. There are factors which influence the final number of platelets while preparing PRP. platelet-rich plasma. The supraphysiological moderate level of platelets is more ideal than a higher level. The high concentration of platelets may lead to their death, and 4 times increase is ideal. Also, different types of generating platelets determine their efficacy. Platelet-poor plasma should be depleted, should be removed, and it also depends on the clinicist experience. Also, ideal PRP is not just platelets, but it's the PRP which has no pollution by erythrocytes or leukocytes. The large number of red blood cells lead to their death, and it also increases pain syndrome and causes inflammation. The system of gel separation is ideal to select clean platelets. There are two parts here shown on this picture, and this may lead to pollution by erythrocytes and red blood cells and leukocytes. The leukocytar film procedure and separation by gel leads to platelets based on the gel, and young platelets are usually on the surface of the gel near to centrifugal motion. What kind of system should be selected? The system which ideally matches the definition of platelet-rich plasma. It's a fraction with the extraphysiological fraction of platelets without admixture of red blood cells and leukocytes in normal amount. So that's why 11 years ago we have selected PRP tropocells system, which ideally matches this definition. Tropocells according to tropocell systems, all the clinical trials have been in abundance. There is a abundant evidence-based. The Kashida made research on all 6 systems, comparing them to tropocells, and we can see on these slides that platelet-rich plasma in PRP system ideally match this definition, because tropocells, they make high concentration of platelets reaching the gold efficacy standard, and erythrocytes and leukocytes concentration is much higher than in other systems. So all inflammation and aging factors are removed, but growth factors concentration is mostly the same in all PRP factors. But clean PRP and growth factors release, they make the tropocells system the best option. The quality and confirmation of this research is shown here. PRP applications are shown on this slide. I'm not going to mention them. We are proud to be partners with eStar Technologies since 2010. You can see our picture where we are being trained in Israel in 2010. This is the Mr. Aaron Esteron, the founder of this company. We have researched this company for 2 years, and in 2012 we registered this as a medical device, and now the system looks like this. The package has changed. The number of blood taken has changed. You can take 11, 22 milliliters. There are open and closed PRP systems. And naturally, if we talk about the glass, then it's not just sterile glass, but operogenic glass. So there is a difference of sterile to operogenic test tubes, and they are replaced every 5 years. In Kazakhstan, we used PRP tropocell systems in derma state clinics in treating hyperpigmentation in cosmetology, such as anti-age therapy and aging, augmentating laser procedures, also in traumatology, preventing skin flap necrosis, speeding regeneration of soft tissues and bone tissues, as well as we're using this in dermatology because the research have shown the positive results of PRP while healing post soft and bone tissues. Somehow the slides do not move in my presentation. Shall we wait for the slides to move in my presentation?
Микрофон выключите пока, да?
Our computer seems to be experiencing some technical problems, so we would have to reboot in a moment. Dear colleagues, we are experiencing some technical problems, and we are working on them to solve them. Please don't disconnect, stay online, stay with us.
Так, тут немножко.
So we are back. Some of the slides have moved, so let me go back. I stopped at this slide, and now we move on. In traumatology and orthopedics indications, I'm not going to dwell on them because technical difficulties have eaten some part of my presentation. But you know these indications. We have started using PRP in orthopedics with osteoarthrosis. That was the first indication in Kazakhstan, and this problem still remains pressing. And the first joint injector in Kazakhstan is Eric Kanatovich Remagambetov. In the 1990s, he studied in London with famous traumatologists for patients with osteoarthritis of the second and third degree. PRP therapy for all these years have been given to many patients. The materials are presented on the slide. They received 1 to 3 injections. The conclusions are that after 1.5 months after infection, there was a positive outcome, reducing the pain syndrome, and that led to active regeneration. In the third stage of osteoarthritis, there were better conditions for arthroplasty, and that helped to reduce the risks of progressing the disease. And PRP also increased the success for reconstruction. This shows the celebrities that have used PRP. In 90% cases, the patients with arthrosis received positive outcomes depending on the degree of severity, with better results for elbow and other results. And with the traumas and the effect aided better return to the loads. So when we've seen the presentation of the second and third PRP, they would dance at the festivals with no pain, and athletes after first procedure returning into their training. It's the right usage of PRP tropocells in traumatology. Kazakh Association of Dermatologists and Venerologists, headed by Nurlana Batpенова, are the pioneers of PRP therapy in Kazakhstan, and this technology is used in the regenerative therapy. So let's share our success. This is the monotherapy for this patient. You see a very good clinical effect to increase the hair surface. It's a monotherapy. No minoxidil was given. And also would like to share this slide, which shows clinical effect of PRP tropocells procedure carried once per month, 4 in total. So we see that there are no wrinkles, and we see here the lifting effect. We also provide training and training PRP tropocells traumatology in orthopedics and sport medicine. It is done by Alexey Solot, the chief traumatologist of the Nur-Sultan healthcare department. My presentation has gone off. Also, head of traumatology department #1 of the hospital #1. All the results are covered in the scientific and practical journals and during congresses. Talking about the future, we will talk about Tropokin system, which is also manufactured by E-Star Technologies, such as Tropokin G and Tropokin P, target therapy of pain, target therapy of inflammation, and the results already available. But there are animal tests and trials. E-Star Technologies does carry out serious clinical studies based on evidence medicine, so that's why we love E-Star Technology products, including PRP tropocells. And I know that Ansar Mahmoud from UK will also share his results of treatment, and he also is using the system of PRP tropocells. Thank you for your attention. Thank you, Gulnaz Batpenova. If there are any questions, please ask them to the speaker. If there are no questions, let me continue our section. Next presenter is the use of biologics, PRP, BMAC, and scaffolds for the knee cartilage injuries. My perspectives of combination of evidence with experience. Mahmoud Nedim Dural, the floor is yours.
Wait a minute, please. I have to share my presentation. Do you see my presentation?
No.
No? Okay. I can show my presentation. Okay. Do you see now? Is it okay now?
Yes.
Thank you.
Mahmut Bey, nasılsınız? Buyurun.
Teşekkür ediyorum, teşekkür ediyorum. I tried to speak in English, but Turkish is better now, but I will continue by using English. Okay, sizler nasılsınız? First, I want to thank to all of you for this invitation and my best regards to one of my best friends in the world, Professor Batpenova Nurlan, is a good friend of me about the years and years and years. And I want to give my big respect to him again. And this is the Turkish-speaking countries formation. Nurlan was one of the pioneers of our group. Now we already created Turkish-speaking countries society, and in the next very near future, we will be in connection with Kazakhstan, Azerbaijan, Kyrgyzstan, in the Balkan countries. In every country speaks Turkish orthopedic surgeons. We try to collaborate with all guys, and we try to collect the Turkish orthopedic speakers, and one day we will organize under the main language of Turkish, but with Russian, of course, Kazakh language, of course, and the others. Once again, thank you so much. I tried to give some important remarks about the articular cartilage. I have any disclosure. Articular cartilage is part of the biological system, and as you see that in 66%, we can see under the control of arthroscopy. And there are focal, partial, and traumatic lesions can be seen under arthroscopic control. Sometimes in MRI, we can't see the focal lesion. Under cartilage, under control part, we can see, but the surface can't see. If we make double contrast MRI, you can see it maybe by CT too. If untreated osteoarthritis can be done, but my question is always the same.
Dear Professor, we hear you not so well. Could you please speak a little bit louder, please?
There is very high my sound. I don't understand.
Yes, a little bit louder. We hear you not so well.
Okay, now do you hear me? Okay. Is it good now?
No, your sound is bad.
You're breaking up, Professor, unfortunately. We can only hear every second word that you're saying.
Okay. Do you hear me now? Do you hear me now?
Maybe no. Maybe you choose and use your.
I don't hear you now.
And
It's very
headphones.
difficult. I don't hear you now. Do you hear me now? I think
Hear
this
you
is,
very bad. Your sound is bad.
now do you hear me? Now do you hear me? I will try it from my phone. Could you wait 2 minutes? There is no link. Do you hear me now? Do you hear me now?
No. You should tap sound on your phone. Yes, you should tap it. You should choose.
Do you hear me now?
No, you should choose in the
Okay,
left.
do you hear me now?
Yes, yes. Now it's okay.
I tried to speak from my phone and I will share from my laptop. Okay, cartilage is not alone. There is a big osteochondral unit between the articular cartilage and subchondral bone. There is continuous complex interactions. And the in vivo chondrogenetic properties, there is a big bridge between the cartilage and synovium. We already published this in PISTA, and at the end we can say that cartilage synovium tropism, there is a big connection, and this is a bioreactor. And also we have a connection between omentum and cartilage and the other synovial cell complex with cartilage too. And peritoneum and omentum also, they are bioreactors published in Turkish. 1 minute, please. Okay. Yes. Yes, Abdullah.
Dear Professor, we hear not so well.
But you can hear me now. I try to speak from my phone.
Please, we cannot hear you so well. You should choose your speakerphone on your phone, but you are using it from your laptop, from where it is very bad. It's going very bad.
1 minute, please. I will stop my phone speaker. Do you hear me now?
No, you should choose it from. You should choose microphone from your iPhone. You haven't done it. On your iPhone, when you go to the Zoom, it's in the left bottom angle. That's called audio or something like that.
1 minute,
and
please.
You should choose Wi-Fi. You see the button.
1 minute, please. In my laptop, you say, or in
on your iPhone. Yes, and Wi-Fi. It should be Wi-Fi.
Okay. Okay. 1 minute, please. No, it's very difficult. Okay. When we try to treat the osteoarthritis, we should go for the positive side, quality of the life. We should give to the patient the function. The pain should be down, and we try to delay total joint arthroplasty and prevention and exercises. As I said, there is no real treatment of osteoarthrosis, but we try the life without pain, with function, and with increasing the quality of life. We have three very important points: chondro protection, chondro facilitation, and chondro restoration. Maybe at the end, limited surface arthroplasty or biological resurfacing, or at the end, we can do total knee arthroplasty. One of the kind of approaches is microfracture and microfracture plus, meaning giving some, putting some matrix, scaffolds, alginate gel, chitosan, etc. There is a good result, but irregular fibrocartilage, short-term relief. Look at, this is one of my paper published in KSTA2, osteochondral lesion of talar dome microfracture, and after 3 weeks, approximately after 2 or 3 weeks, I use hyaluronate injection, sometimes as soon as possible after the microfracture, after the arthroscopic approach, I use this. And this is, you can see in patella or in femoral condyle. This is nanofractures, about more than the depth of the microfractures is about 9 millimeter, maybe more than, to get the bone marrow. This is a good depth. Seems promising, but we need the long-term results. Look at this publication, enhanced microfracture using acellular scaffolds, improve results. After treatment of symptomatic focal grade number 3, 4 knee cartilage lesions, but current clinical evidence does not allow unequivocal recommendation. There are 10 studies, 331 patients, other breach grade number 3 and 4, enhanced microfracture, improved patient-reported outcome measures in constant imaging results, but current evidence does not allow clear recommendation. NPRP in this publication, in this study, 59 studies, level of evidence is number 4, overall support toward PRP use in preclinical studies, many biological variability, variation in preparation, and we need the real dosage. This is a systemic review, level number 1 and 3 clinical trial. Mesenchymal says is better than PRP, said this publication. And this is the concentrated bone marrow aspirate. The message is anabolic and anti-inflammatory effects, safe procedure with varying degrees of reported good clinical results, minority of high quality study. And look at this, acellular dermal matrix and versus the acellular cartilage matrix, more suitable for cartilage regeneration. At the end, they said ADM better than ACM, published in 2021, this year. And evaluation of hydrogels for cartilage tissues, engineering of the knee. This is a systematic review, improvement in pain and functional scores, efficiency of hydrogel-based reconstruction published in 2021. And that one, the third generation ACI, cell-based on type 1, type 3 collagen membrane. And they said that a good result to use when we use the third generation of ACI. And this is one of my case for Dalard-Dome osteochondral lesions, debridement, microfracture, or nanofracture, and using hyalofast esterified hyaluronic acid and the motion function as soon as possible, good results. And in this publication, this is cost efficacy of knee cartilage defect treatment in US. Currently used treatments are cost effective, they said, except microfracture in lesion more than 3 centimeters square and osteochondral allograft transplantation of patella or bipolar lesions. And we use also a hemicap in several different joints like shoulder, hip, knee, patella, and Dalard-Dome. This is my experience with my friend Onur, and finally we can get a good result. Not a big operation, a short time, and we have a good result in 15 years, approximately 10 or 15 years. In this study, articular cartilage restoration requires cells and scaffolds, biological stimulation, growth factors, and mechanical stimulation, meaning rehabilitation, CPM, etc., need a larger number of studies in this message of this publication. To use 3D printing to restore anatomical articular geometry, routine clinical use in the future maybe, but not nowadays. As a conclusion, patient and lesion-specific reconstruction, very important. Alignment of distal extremity, ligament stability of the knee, meniscus integrity, etc., are very important. We should be very careful. The other point that we should be careful is biological resurfacing. Do not forget this chondro facilitation and chondro restoration by biological input. Histologic healing, biomechanics clinics, we need to follow the patients. The best reconstruction still controversial, and there is no fixed approach in biological resurfacing or biological approaches. The philosophy and experience of the surgeon is very important, because we have a good relation with the patient. We have to explain all the point, all the steps to the patients, and we have to follow with the patient. Maybe we can say that the patient should be our one-of assistant. Quality of the implants and technology, we need to progress on this too. Cells, scaffolds, biological and mechanical stimulation need new research, new investigation. Regeneration, 3D printing, gene therapies, updated algorithms need also new dilemmas, and the algorithm and the following the new approaches at the same time. And do not forget also oral supplements, but there are a lot of questions on this topic too. Again, my question is, can we treat really our cartilage lesions? We know that we should increase the pain, decrease the function at the beginning, I said this, and the relation with the patient are very, very important. And do not forget COVID-19, because we published as a introduction in orthopedic surgery, Journal of Orthopedic Surgery last year, 2020. And with hope, at the end, we said, with hope, respect to the science, respect and thanks to all our colleagues in the world and all global healthcare workers and scientists as true heroes of this moment to save the future of our planet. We have a big mission as orthopedic surgeons in COVID-19, because this year is COVID-19 2021 and next year COVID-22, and I think this pandemic will continue in the next 5 years with different level, different niveau of the coronavirus virus. And this is my my publications as a book. The last one will be done in 2023 with under my editorial with my editorial staff, Professor Carlson, Professor Nyland, my friend Honor, my friend Senorsky, and Professor Freddy Fu. As you know, we lost our friend Freddy Fu last week, but he accepted to be with us, and we will publish this for the memoriam, for the respect to Professor Freddy Fu. And this is my first edition, translation to Chinese. Last year I was in China for this ceremony, and thank you again to all of you for inviting me, and my best regards again to my very close friend Nurlan. Thank you.
Спасибо.
Thank you very much. Thank you, dear professor. With that, let us continue. Keeping in mind the technical issues that we've had, we don't have much time, unfortunately, so we will move on to the next speech. I give the floor to Ansar Mahmoud from Great Britain with this speech, PRP in osteoarthritis and future directions. Please, the floor is yours.
Dear professor, could you please share your screen? Yes, thank you.
Can you see and hear that okay?
Yes, thank you.
Great, okay.
Все отлично.
Thank you. Great talk from Dr. Nadim from Turkey. So I apologize, I missed the previous talk before that, which it looks like there's been a masterclass in biologics for orthopedics, and I'm going to add my little bit to that board of experts. So I'm just trying to move the slides. There we go. So I have an interest in the UK. I'm an orthopedic trauma surgeon, but I have an interest in biologics, and I set up a PRP lab. And we do. I work at the Institute of Translational Medicine at one of the universities, and we're looking at translating a lot of the in vitro and basic science work into our orthopedic practice. So my interest is MSCs and PRP for a number of years. And I teach and train in biologics across Europe. I think some of this will already been covered. You know, why are we interested in biologics? It's quite simple. There's an unmet need. There are patients who are not ready for surgery. We have a better aging population, very active patients in their 70s or 80s. You know, my typical patient tends to be somebody perhaps in their 50s, 40s or 50s who has established osteoarthritis. Probably is a little bit young and too functional for arthroplasty, and doesn't really want to take that amount of time off work. And we know that the outcomes of
in the younger population tend to be significantly worse from a patient-reported outcome perspective than in the elderly lower demand population. So there's a treatment gap, and that treatment gap is what we're interested in. There's lots of options out there on the table. We're going to talk today specifically about PRP and what it can provide, particularly in the osteoarthritis population, because we don't have too much time. I know we're a little bit behind time, so I'll try and make it up. And I was given a 15-minute window, and I normally teach this in a 2-day course. So we'll try and squeeze as much as we can into the short time that we have. We all like high quality level 1 evidence, you know, the peak of the pyramid of evidence. And so do we have any evidence for what we want to propose? And most orthopedic surgeons will realize that actually most of the operations or surgery we provide doesn't meet level 1 evidence, if almost ever. Yet in biologics, there's a constant demand that we need level 1 evidence. It's a more simple intervention than surgery. And do we have the evidence? And the simple answer is I think so. In the sense that we have now 21 randomized controlled trials, meta-analysis of which was done only in 2021. I think Dr. Nadeem mentioned it, and it definitively shows that there is a improvement in outcomes for patients. The issue is the heterogeneity of the studies and the non-standardization of how it's used. So some people are doing 1 injection, some are doing 3. The number of studies that actually record the specific protocol, document the dose, and document you know, what was given to the patient, as well as the patient's baseline whole blood, for instance, is very small. I was at the British Orthopaedic Association meeting recently, and it was presented there that apparently only about 16%, so 1/6 studies tend to report a detailed protocol, so that somebody could then reliably repeat that study. So that means over 80% of them are not reporting what they're giving, and this is where the regulators then start to struggle with providing guidance and saying definitively that yes, this is good or this is bad, because actually they don't really know what we're comparing. And that's an issue for the clinicians to some extent. You know, if we're producing studies with poor protocols and poor information, then we're going to get ourselves into a position where we make it difficult for people to recommend the treatments that we advocate. My journey into PRP was from seeing all the problems with cortisone, and I also believe in all guided injections and targeting being very important, particularly for biologics. I won't labor too much about cortisone. I think you've probably already covered it. We know it's deleterious over time and can produce negative tissue effects in the short, medium, and long term. What is PRP? Again, I won't go into too much detail because I think we've already had 2 speakers discuss it, so I'll save a bit of time and move on. What we're interested in is the PRP it generates growth factors and cytokines, and works effectively as the granules, alpha granule is what we're interested in, where the growth factors are stored, and it sort of works as a signaling molecule and sends out lots of healing signals both into the local environment and into the systemic environment, asking for support for healing. And you can see there it's mentioned there are over 300 different growth factors now independently identified. What's also important to remember with PRP is there's lots of protein in the plasma and other amino acids which are actually beneficial and anti-inflammatory. So it's not just about growth factors. You do get a response from the plasma proteins and other cells within the environment of the plasma. So we don't want to just isolate growth factors, which is where some of the research is starting to head. And I think we will lose some of the effect potentially by doing that. So your platelets acts as a bit of a conductor for orchestra and signals that it needs support to improve and restore tissue integrity, fundamentally restoring tissue integrity being its primary goal. Lots of areas that it's being used in. We're interested in osteoarthritis here today, but I use it in bone fractures. Our unit does lots of research in burns and nerve injury, and we've shown positive effects in those tissues as well. The question is, what types of PRP? Different ones out there. Broadly, there's the Buffy code systems, which have been around for over 40 years. The more modern systems, so plasma PRPs, where they generated an improved separation, both due to centrifugation technology, the development of the R&D behind the tubes, as well as the gel-based systems, which were developed to provide one-step concentration and an improved purity in the PRP systems. Again, I think you've had electron troper cells. I am a fan of troper cells. I do use that as well, and it is a very pure, high-quality, tunable PRP. What I like about it is you can adjust the dose within the tube. The next question I ask is, is all PRP equal? And there's a very simple answer to that, really. No, it's not all equal. And we know that leukocyte-rich generates a pro-inflammatory catabolic environment for a period of time. That period of time is extended if you're leukocyte-rich. The growth factors are still present and evident. And so a lot of the literature actually says that you get a pro-inflammatory response initially, but actually with 3 months, 6 months, 12 months, in the patients. So you still get the anabolic and positive effects further down the line, but you get a pro-inflammatory response early on. So certainly for orthopedics and joint injections, we probably prefer not to have leukocyte-rich, particularly granulocyte-rich, like neutrophils, etc., PRP. But in other indications, there's growing evidence that you may actually want an increased and perhaps a slightly more prolonged response, for instance, in tendons, especially chronic tendinopathies. So that research is still ongoing, but there does seem to be a swing back towards wanting some leukocyte-rich PRP for certain indications. And one of the things we found and established now really over the last 10, 20 years is that osteoarthritis is really a biological disease. It has a mechanical driver, but fundamentally it's a biological disease. And Prof. Nadeem just mentioned COVID. And what COVID has taught us is that the immunity and immunological response and innate immunity within patients and between patients is hugely variable. And that's something that we know. One patient may get a scuff or an injury on the knee and have very little problems with it in the future, and another one will get a biological start, often with interleukin-1 and 6 and TNF-alpha degradation, and this sets up a loop and an arc, and you generate ongoing inflammation, catabolic environment, which generates pain usually in the synovium, and that pro-inflammation continues. And some of these 18-year-olds or 20-year-olds that injure their knee at that age are the ones that go on to develop osteoarthritis in their 40s or 50s. And so the question really is, what is our biological target, and can we do anything to modify this inflammatory response once it's started? The simple answer is yes, we can modify it. What we do not know is in each individual patient how much we need to modify it and with which signals and with which cells. So that's the work that needs to be done and is being done, hopefully, with across the world with all those interested in orthobiologics and the level of literature work that is going on in this space is significant. Most people will know, and orthopedic surgeons love new things. We like new things and new techniques and promising ideas. And this is Scott's parabola, which shows the journey of a lot of what comes into medicine as a new idea, and it often falls into disuse. Why will that not happen with PRP this time around? You'll see that the exponential research and output in this environment is huge now. So I think we've reached a point where critical mass of understanding the available science, the biologic ability to isolate genomics and metabolomics has caught up to such a level that we can now see individual cell responses to substances and work out individual signaling mechanisms, etc. And so I think the amount of work, and not fundamentally it's about money, the amount of money that's gone into this system now to produce the research that we need has reached a critical mass, and I don't think we will lose that. So I think that PRP and particularly orthobiologics and more advanced systems are here to stay. So where are we heading? I mean, it's difficult. There's a philosophy of marginal gains theory, where you make a small improvement, but each 1 or 2% improvement over time, you end up with a 10 or a 20% improvement, which makes a big difference to a larger part of your population or to an individual. So we need to, as clinicians, learn which patients this works for, how it works in that individual patient. Is there an immunological target? Is there a biological response that one patient may mount and another one will not mount? And this, as I said, is work that is ongoing. We know that PRP, for instance, in grade 1 to 3 osteoarthritis, most of the RCTs show a positive response in around 80 to up to 90% of the patients. Most of the studies stop at 12 months, but we know that's not absolutely the case. And what the golden answer is, who are the non-responders? Who are the patients that it does not work for? As well as knowing your patients, it's important that we choose, the patients choose their doctors well. You have to be honest to your patients. I always start my consultations with patients about what is your problem. And then once they tell me that they want cell therapy or PRP, I then explain to them very simply what we know and what we do not know. Those are the two things that we start the consultation with. And so I'm very honest with what we think we know, what we think we don't know, and where future directions are probably going to head. And I'd be surprised, I say this to patients openly, that I'd be surprised if I'm doing the same thing in a few years' time. We seem to be changing our methods probably every couple of years, really, at the moment, if you're in the biologic space. It's an exciting area to be doing research and interventions in. So I think, in summary, the potential is enormous. PRP is the start of the biologics journey. We're stepping up into a cell therapy. Stem cells is a very controversial word to some extent in the orthopedic and orthobiologics world, because we know that the mesenchymal stem cells that we use, that everybody has traditionally called stem cells, in vivo in the patient do not behave as stem cells. They do not have multilineage ability, and they cannot differentiate into different cells and produce, for instance, our mesenchymal cells cannot change from fat or bone marrow into cells that produce cartilage in the joint. So what they predominantly work as is signaling cells that generate a paracrine signal response, but they can generate an immune modulatory response that provides some long-term benefit. So the future directions, custom PRPs and growth factors are already being prepared and are available to some systems. There's some eminent scientists who suggested the customized PRP, because you can imagine it doesn't make any sense for PRP to be the same when you need it in skin, for cartilage, for bone, for the endometrium, for the epithelium of the eye. They're completely different environments, different tissue environments, different tissue lineage, and different oxygen tension environments. So we will need different balances for different tissues. There are advanced systems appearing now, advanced plasma systems, which are, I often describe them as advanced PRP, but they have specific ways of being prepared, like N-stride, like monocytes, rich products. And a new one that I've seen in the last few years, there's actually been around for about 20 years in Germany, Goldic, which is gold-induced cytokines. And all of these promise an advanced longer-term outcome. There is data from all of these products now in excess of 3 years in osteoarthritis providing positive outcomes. So it's an interesting space to be in. I thank the committee and the organisers for inviting me to speak. And I'm happy to take any questions if there are any, or if we're taking them later, that's fine. I hope I've caught some time up for you.
Спасибо, господин профессор.
Thank you, Mr. Professor. If anybody has any questions, you are free to ask them right now.
Если нет вопросов, пожалуйста,
If you have no questions, the next report is progress and prospects of cell technologies in the treatment of rheumatoid arthritis. The speaker is head of the Laboratory of Stem Cells of the National Center of Biotechnology for Nur-Sultan, Огай Вячеслав Борисович. The floor is yours.
Так, презентация видна, да?
Мы пока видим.
Can you see my presentation? Yes, we can see you and your presentation. Dear participants of the conference, today my presentation is on the progress and prospects of cell technologies in the therapy of rheumatoid arthritis. As you know, rheumatoid arthritis is the most common type of autoimmune arthritis of unknown etiology. It affects joints, first of all. It causes swelling of the membrane with the so-called pannus. And that, of course, deteriorates quality of life of the patients, decreasing the life expectancy and leading to disability ultimately. We will look at the pathogenesis of rheumatoid arthritis. While developing rheumatoid arthritis, the synovial membrane is attacked, causing inflammation and destruction of the bone and cartilage tissue, as well as heart and brain failure, because there is a high level of cytokines. Rheumatoid arthritis is related to regulatory function of the immune system. The disbalance between the immune response of pro-inflammatory and anti-inflammatory cells, such as T helpers, Th17, and the immune cells which are anti-inflammatory. The patients with rheumatoid arthritis, they have increase of Th17 and Th1, T helpers of first type, which have a high level of inflammatory cytokines such as TNF alpha, interleukin 6, interleukin 1, and 17A, which are dominating in the pathogenesis of rheumatoid arthritis. At the same time, the non-functional activities number is decreased for those patients. This is briefly about the pathology of this disease, which is related to the chronic inflammation. Looking to WHO data, rheumatoid arthritis in the world, it takes number 42, with diseases with high disability by decreasing the life expectancy and quality of life. 80% of patients are between the ages of 35 to 50 years old. And women are 3 times more likely to develop rheumatoid arthritis than men. Of course, the reasons could be multi-factor disease, as well as related to heredity, aging, lifestyle, and pollution, such as external environmental factors, excessive cooling. There are a number of treatment methods, such as drugs and joint replacement at the ultimate phase. Also, physical load exercise is recommended for the patients to reduce symptoms of this disease. As to the total incidence of rheumatoid arthritis throughout the world, it's 50 patients per 1,000 people population with a prevalence from 0.5 to 1%. According to the statistical data from 2012 to 2016, this ratio is 52 per 100,000, raising to 77 per 100,000, and it's growing throughout the world, not only in Kazakhstan. So what kind of methods, what kind of therapy is administered? Of course, it's mostly painkillers, non-steroid drugs, which reduce pain systems, glucocorticoid, biological response modifiers, biologics, alpha antagonists, DMARDs, such as methotrexate. Although there were some success received during the rheumatoid arthritis, for 40% of rheumatoid arthritis patients develop resistance to these drugs and experience an increase in the incidence of side effects. So that's why there is a need to find new methods of treatment or new drugs which cause less toxicity and would provide for the good balance between the immune restoration and immune system. There is a one-month therapy. And on this picture, we can see the mesenchymal stem cells, which can be taken from different tissues such as skin, the placenta. So there are different sources. Mesenchymal stem cells do not only have regeneratory functions, but also anti-inflammatory functions. This shows how they generate to different immune system cells. The paracrine function of the and using cell-to-cell contact directly. So thus they provide immune modeling effect on the immune system cells. One of the articles which was published in Cell, the data was given that monthly old sorbents could be treated as inflammatory sensors. So here we can see the scheme. Depending on the micro just interferon gamma, interferon alpha, if their concentration is high, then mesochemical cells could be polarized and they would turn on and again to the anti-inflammatory cells. So thus there is a high level of anti-inflammatory cytokines or the factors that influence inflammation suppression, such as beta-1. But if the concentration of interferon gamma is very low, then they may get pro-inflammatory phenotype, and then they will produce low levels of such molecules and producing chemokines that are different, that are influencing the T helpers and others. In the same type, the monocytes we also have anti-inflammatory. You could using anti-inflammatory macrophages which can suppress the inflammation. And the same for pro-inflammatory MSK profile, MSC profile, where they can modulate macrophages with the inflammatory macrophages with interleukin alpha. So if we look at the entire literature, there were 48 experiments using collagen to a certain line. So after injecting collagen 2 and immunization, you would receive the swelling of mice feet, and this is the summary table of mouse and human cells. I've mentioned there are a few. The mesenchymal cells were used from the bone marrow, using concentration from 1 to 5 million. It was cranial or intravenous application, so in all cases there is a lack of reducing inflammation and cartilage tissue destruction on animals. So if we are to summarize schematically, then introducing mesenchymal cells inside the joint or intravenously, it provides favorable effect. And that's why they used I'm going to dwell on that because we're limited in time. Here I am showing the results of our collaborators from South Korea, headed by Professor Kaf and Yuga, her boyfriend. The mesenchymal cells applied in different dosage to umbilical cord, 1 million, 3 million, and 5 million. This line shows us the positive control. And after introducing different dosage of mesenchymal the PAMUS is also decreasing according to histology data. And the dosage is best after 5 million cells. CPCR was conducted as well as ELISA monofermentic analysis to detect anti-inflammatory cytokines. In most cases, there is a dose-specific effect. So it's a production of inflammatory cytokines and interleukin 10. Using the flow cytometry, regulated cells, which are immune suppressing regulating cells, are increasing. This model, which we have made for the journal that we're going to publish. There are 18 clinical trials carried out right now, clinical studies. 9 of them are completed and being published. And this shows the data which was published in the journals. And I have used them as autological or allergenic. So the number of patients was different. It was depending on the study design, whether this was pilot or first phase 1 or phase 1 and 2 combined. We're using different dosages, so we don't have a standardized protocol. But all this data shows that there is an improvement of the card treatment, reducing inflammation. And according to international scale, we can see that there is normalization after using mesenchymal cells. Based on the above data, of course, we have a question. Mesenchymal cells may provide favorable therapeutic effect for the development of traumatologist arthritis. So the perspective is how to improve the effect using different methods. So perhaps we need to use 3D sphere culture, which would be more physiological, or to hypoxia conditions, or using pro-inflammatory cytokines, or do genetic modification. And all that leads to increasing anti-inflammatory immune regulating effects. Vyacheslav Borisovich, time is up. Let me wrap up there. Currently, we are doing research starting from this year in order to assess the efficacy of using cytokine preconditioned so we can send you MSA blood and to carry out the ultimate he will receive some steroids. It has a high inflammatory properties. We're using here 3 cytokines to increase those properties: anti-immunomodularity, anti-inflammatory, and regenerative. I can give you some data, and in the next year we'll starting to use this scheme of our protocol using 3 injections in 3 weeks' time, and to understand the difference between the non-treated and treated. That if you are using cytokines, in this case, their properties should be increased and improved. Thank you for your attention. Thank you, Vyacheslav Borisovich, for a very informative lecture. Don't have questions for Q&A, so allow me to start the next speaker. Next speaker is Professor Reinhard Schnettler from Germany. The floor is yours.
Hello, greetings from Germany to Nur-Sultan. hope you will hear me, and hopefully you will see me, my lecture. The title changed a little bit.
Dear Professor, please share your screen. You haven't shared your screen.
Time in screen time.
Yes, you should tap green arrow, share screen in the Zoom.
One moment, please.
You should go back to the Zoom.
Yeah, we have
tap
it.
green arrow, share screen. Yes, great, great. Thank you.
Okay, thank you
and,
so much.
make it full screen, please. Thank you.
Wo geht das? Nein, wo geht es, dass das startet?
So, hopefully you have it. Again, hello from Germany to Nur-Sultan. As you see, I am going to talk about today about methicillin-resistant microbes in infected non-unions and periprothetic knee infections. This is a Damocles Schwert which will hang over us. And I think very deeply that the development of worldwide antibiotic resistance towards first-line therapies, such as against vancomycin, we saw it, against teicoplanin and daptomycin, which will continue to restrict the successful treatment of these methicillin-resistant microbes. So I want to, in the next minutes, share with you some facts, some ideas, and some thoughts I have about this subject. And I will discuss with you my own results in laboratory about this, and 2 clinical cases. Something about the background. Infections with methicillin-resistant microbes have become a serious problem worldwide in bone infection and in total joint arthroplasty. The frequent resistance against gentamicin, we used gentamicin during the last 40, 50 years, which is commonly used in antibiotic beads and in antibiotic-loaded bone cement, makes a new approach necessary. And as my title is, on the one hand side, infected non-union, and the other hand side, periprothetic infections, I will start with infected non-union, as you see it on this screen. It's a very devastating result of fracture treatment if this might happen to the patient and to the orthopedic surgeon. This is a challenge situation. And an infected non-union raised significant challenges for complete solution and for sure for functional restoration. And so we have to think about the management, which is often associated with repeated and unsuccessful operations in these cases, and for sure prolonged hospital stays, social and economic consequences, social burdens in very many countries all over the world, and economic consequences to the patient and to our healthcare system. Billions of euros we spend every year in Europe for the treatment of these diseases. We know 3 interrelated orthopedic problems in infected non-unions that power each other. We see on the one hand side the mechanical instability. We see a very deep bone infection, as you see it here. And we see a failure of fracture healing. So the guiding principles are, for the first, and this is the main reason for treatment, and the main to do is radical debridement and removal of all necrotic bone and soft tissue and of all hardware. You see in the background of this slide, blade and screws, and deep tissue sampling for our lab in order to look which kind of germs, which kind of microbes we have in these cases. There are current worldwide controversies in the treatment, in choice of fixation to achieve bone stability, in methods to restore bone, how should we do this? And I will address it later on, and in delivery of local antibiotics. Very, very big controversies in these themes. And the question is, what is proven and what is evidence-based. And I want to try to answer it, at least in a small part. Antimicrobial resistance and biofilm formation in part leads to treatment failures, as you see it on the right side of this slide. Open treatment with local antibiotic beads is absolutely nonsense, and it provokes the infection. You are not allowed to do this, but sometimes we see this treatment. So in patients with poorly vascularized infected tissues and osteonecrosis, systemic antibiotic treatment is ineffective because the antibiotic you give intravenously never will reach your dead bone or dead tissue because there is no vascularization. Moreover, microbes may produce a protective hydrated matrix of polysaccharide and protein, which we call the slimy, a slimy layer. So in patients with poorly vascularized infected tissues and osteonecrosis, we often see this biofilm. And I'm deeply convinced that the key of treatment today is an increased understanding of the fundamental biology of these biofilms, also for orthopedic surgeons. So the bacterial biofilm play a major role in infected non-unions, in chronic osteomyelitis, and in periprosthetic infections. And all the slides you see are done in my lab in University of Gießen. Biofilm leads to antibiotic resistance against most antibiotics. We know this. And hundreds of researchers published this in the last 10, 15 years. The thickness of biofilms can differ depending on the species of bacteria. Biofilms, and this is very important, are built of planktonic individual bacterial cells glued together with self-released extrapolymeric substances, so-called EPS. And you see it on the right-hand side. This role of extrapolymer substances is to promote adhesion and aggregation of bacteria to the surfaces and provide stability to the biofilm structure to the methicillin-resistant microbes. These biofilms consist of lipopolysaccharides, proteins, lipids, glycolipids, and nucleic acids. And once this biofilm is established, DNA acts as a biofilm defense mechanism. They are protecting themselves in this biofilm against every given antibiotics. So bacteria within the community communicate with each other. We know this between osteoblast, osteoclast, and pre-osteoblast in bone healing. They make a crosstalk, and these bacteria can also start a crosstalk, which means chemical signs that modulate cellular functions. Cells are capable of forming a new biofilm colony at another location. This is very, very important. And on the left-hand side of this slide, you see a nice publication out of 2018 from Kararuzuman and co-workers. And on the contrary side, these are works we have done with my co-workers in my hospital and in my lab in University Gießen, and we published this in 2016. So to start, the first is that the bacteria attach to the surface, and you see it on the right side of the bacteria here. These are the bacteria attached to the surface, and then these adhesion between bacteria and the surface, they produce these EPS, these extra cellular polymeric substances, and they glue together and form a wall, a protection wall. And you see it here. Here, this is the wall. And in the middle of this wall, there is the microcolony of these methicillin-resistant germs. And then the formation of the microcolony, as I told before, started, and you see it here. This is the wall, and this is the microcolony. And then, due to these talk inside the microcolony. A detachment of bacteria from the microcolony may happen, as you see it here. And here you see this. Out of this break, germs can go out and form a new microcolony. So there's a failure of antibiotics to penetrate the full depth of the biofilm due to the presence of extrapolymeric substances. And these substances you see here in this part of the slide, the antibiotics cannot penetrate this. And here on this preparation, the same. There's no chance to penetrate for the antibiotics this wall, this so-called wall. So we made a lot of experimental research on this infected situation in the last 15 to 18 years in horses, in rats, in rabbits, in mini pigs, and sheep and goats. And due to the time, only 2 or 3 implant-related infected non-unions we did in 36 rats, as you see it here. We gave 10 to 7 colony forming Staphylococcus aureus inside, stabilize it with this device. And you see here on the X-ray a non-union, and here you see the pus and the infected situation, which you see in this preparation, non-union, infected non-union, and here in the confocal laser scan, you see this microcolony reproduced here, and here in our scan, you see the biofilm formation. And in another experiment, we put in these tibia 10 to 7 colony forming units MRSA, and we tested implant rabbits with a coated rod coated with phosphomycin and rifampicin. And what did we see? We see 0 infections with these antibiotic coatings, rifampicin and phosphomycin, and 100 infection rate in the other animals without this coating. So in an other culture experiment, we could show that these MRSA, these Staphylococcus, went inside an osteoblast. This is the nucleus, this is the cytoplasma, you see it here. And we have done it with osteoblast, and we did it also with osteoclast. And what we see, there is a proliferation of these microbes, methicillin-resistant microbes inside the osteoblast. This is very risky because we have to see that normal antibiotics doesn't penetrate either in the microfilm nor in these biofilms. And so we know that rifampicin penetrates in the cells and in the biofilm. But to administer only rifampicin, this is very risky because within 8 days you will have a high resistance. So you are forced and you are obliged always to, if you give rifampicin in these situations, always in combination with a glycopeptide antibiotic in order to exclude a resistance of rifampicin. Then it will work. So mechanical reduction of bacterial load and local delivery of antibiotics appear, at least for our group, to be a key component of successful management of infected non-unions and so far of periprotetic infections. There is an absolute nice algorithm published in 2017 from Mr. Simpson from UK. I modified this algorithm a little bit. And first we have to address the patient factors. And I go very quick through it. Is reconstruction possible, reasonable, acceptable for the patient? If not, make immediately an amputation. If yes, look for the bacteria, determine the bacteria, look for the antibiotic sensitivity and the healing reaction close to the non-union, the same in periprotetic situations, and start to make a radical debridement. Radical means radical, like in tumor therapy. Remove all implants, all orbital tissue. So you have to make in cooperation with plastic surgeons in order to make a very good flap after you make your radical debridement in several cases. Take biopsies, different biopsies, send it to the lab, make in pulse lavage, stage revisions after 1 or 2 days. This is mandatory. Not only one revision, 2 or 3 revisions, and apply local antibiotics plus systemic antibiotics after radical debridement. And apply the local antibiotics due to the determined bacteria and the sensitivity of the antibiotics. And then if the bone defect is minus 4 centimeter, you have different options: autogenous, allogenous bone grafting, growth factors. We have heard, for example, PRP. I work with this in bone healing. It works very well as growth factors. BMP2, BMP7, BMP3 works also very, very good. Resorbable bone matrix and modified muscular technique you can use. And one of my personal cases, a young lady in the proximal tibia below the knee joint. You see it on this. There was open fracture with a bone defect minus 4 centimeter, less than 4 centimeter. And so we make a stabilization and made a plating of the femur fracture, and this open fracture and fixed X, and then infection developed. Then we took probes for the lab, and then gentamicin have been at this time sensible, and so we took in an bring in a septopal chain, and you see what happened with this proximal part of the tibia with the skin. Necrosis of the skin. So you have to do, as I told it before, in this case, an absolutely radical debridement tumor-like. Take all infected and necrotic soft tissue and bone away. And then we have a huge defect up to 4 centimeter. Our plastic surgeons put on a parascapular flap very early, and we rebuilt this part of lost bone with autogenous and allogenous bone. And after 1 year, you see the situation in this 17-year-old girl. And the next is, if you have a bone defect more than 4 centimeter, you know, this monosegmental bone, bisegmental bone transport, compression, distraction, and other methods, free fibular flap, and fibula pro tibia is a very, very old method, and in some cases it works still very, very good. And again, a case of I've performed some years ago. There's a bone defect after radical debridement, removal of this plate. And again, to show it to you, this is a big thought to make an open antibiotic treatment with this mini septopal chain. This must be forbidden because you will provoke the infection. Then we put a Regazzoni fixator and make a bone shifting, as you see it here and here. And after this bone shifting in the docking zone, this is known very well by our Russian and Kazakh colleagues. They are very firm with the Ilisarov technique, which is the Ilisarov technique. I show that they are on the zone where the bone ends kiss. There is a non-union, and so we put in autogenous bone from the posterior iliac crest, and it heals very well. We stabilized it in a clean situation without any signs of infection, clinical and lab, and plate osteosynthesis, and it worked very well. And at the end, our plastic surgeon put on a latissimus dorsi flap. So, infected non-union, biofilm, methicillin resistant microbes. What to do? We are going, as I showed to you, below and above 4 centimeter, but there are situations we have to make an amputation. It is not a nice option, neither to the patient or to the surgeon, but very often, it might be wise choice in such situations to go for amputation. And the earlier, the better. At the end of my talk, I want to touch something about local therapy with another substance, microsilver. The same you can reach with copper. Microsilver has a very broad range against gram-positive and gram-negative strains and fungi. And in the last 15 years, we made a lot of preclinical lab work and published a lot about this. And you see one of our co-workers, we started 2000, published an article about the efficacy of nano and microsilver in nature medicine. And he compared this with gentamicin, and it was extremely good results and extremely high efficacy against methicillin-resistant Staph aureus and Staph epidermidis. We have proven this in animal models, and we have seen in our different animal trials an excellent biocompatibility, and I want to share my results, some of my results with you. We made subcutaneous implantation in rats, and we have seen that nearly 100% of the bacteria, these were methicillin-resistant Staph epidermidis, were killed for the group. And we have seen that, and we showed that silver-coated implants has a strong resistance to contamination, and we published this in Acta Biomateria, for example. Then we made in more than 30 sheep and testing of the silver coating technology, and we have seen a high biocompatibility in the tibia after 6 months. You see this on the left-hand side, and in the femur of these sheep after 6 months too. So we started to go into the clinic and to treat patients with methicillin-resistant infections, bone infections, and periprothetic fractures. Only I want at the end present to you 2 cases. Recently in April, I did this operation in a 12-year-old boy with a podiabscess, open growth plate, as you see it here, and a fistula. And here you see my approach. I made a radical debridement, took out all these poos and the necrotic bone. And here we developed with a small company in Germany, resorbable beads with magnesium and nanosilver. And as we have had in advance the type of microbes, it has been normal gentamicin sensible Staph aureus. We put gentamicin and put silver and magnesium in it. Resorbable beads, as you see it here, intraoperatively. I performed this operation this year in April. And after the operation, you see the beads here. And I took away these part of the soft tissue, necrotic part of the soft tissue. And after 10 days, I go again in and make a radical resection again. And then I rebuild it with allogenic bone. And you see here on the lower part, the X-ray on the right-hand side after 4 months. And the 12 years boy is playing football and this is okay. And here is an infected situation in this knee joint, as you see it here. Radical debridement of the soft tissue and of the prothesis, as you see it here. And the jet lavage we did in this case. And then we made a reaming of the femur and the tibia again, a jet lavage, and here we mixed in PMMA cement this microsilver, and we covered the rods. Did it by my friend Rimaszewski intraoperatively here, and then we put 1 rod into the root and pulse lavage femur canal, and the second in the tibia channel, as you see it here. And then we completed it with PMMR cement and silver coated. And this is the situation after gastrocnemius flap we did, and I put on it a mesh graft. And then this is the X-ray after this operation with these rods, with the silver rods. And this is after 4 months, the lady, full extension and bending up to 60% degree. And so after 4 months, we removed the silver spacer and put in a normal artificial joint. And my conclusion of this is we didn't see any adverse events. This is in line with in vitro and animal tests, and the urine pathway doesn't play a role for excretion of silver. And we have seen the highest levels of microsilver in the drainage fluid. Might be that the antimicrobial coatings of implants, either with silver or with copper, might be a step in the future. I want to thank my co-workers, Dr. Rimaszewski, Dr. Klenske, Professor Wenisch, Professor Doman, and my friend and former co-worker, Professor Dr. Alt. Thank you so much.
Спасибо вам большое.
Thank you very much. Now we move to the next speech.
No discussion.
Akizhanova.
Good afternoon. Good day, everyone. Day to everyone, to all participants of today's meeting. On the one hand, I would like to express my gratitude. Please, thank you, presentation. I would like to say thank you for the possibility to speak today. And of course, I would like to say that to talk about the pain does not stop because of the loss of Nurlan college. And it's incredible that he could implement any idea, and now in the year 2017 or 2018 we talked that it would be so good that within the framework of the traumatological meetings and conferences there was a separate section about regeneration medicine. And this is the second conference which is held with a separate section. Please switch on the whole screen. Can you see my presentation? And today I have a report devoted to the combination. Our assistant helps me to demonstrate my screen. Please wait a second. Please start the presentation. I have started the presentation and demonstrate the slides. Show the slides. I think we have done this properly. Let us try it once again. And today's report presentation is devoted to application of PRP for the first time in pediatric cases. Our center, our method is working for more than 6 years with PRP therapy. And before we start doing pediatrics, we have made a lot of big studies in adults. And now for 5 years, we have been working with children in pediatrics. Please here. Press here, please. I have some strange technical disorders. I guess I can start. No, wait, you cannot do it without launching the presentation. Just stop demonstrating the screen. Trying to solve the technical issues.
Да. 2 раза кликните. Ага. Теперь открывайте вашу презентацию. Это ваша презентация?
Да, зеленая, да.
Ага, все, слайд-шоу и сначала. Слайд-шоу сначала.
Итак, внедрение инновационных технологий.
Introduction of the innovative technologies. I will try to speak quickly. Sorry for the technical problems. Introduction of the innovative conservative technologies in Kazakhstan for protection of the hip joints in children. Relevance. It is commonly known that the congenital and acquired pathology of hip joints is a dominating specific weight among all orthopedic pathologies in children, and the bone growth plates and articulating in the hip joints, they are formed from the birth, have internal and external unfavorable factors affecting them. This is dysplasia, hypoplasia, regime of static loads, ischemia, plasticity. From the prognostic point of view, pathology of the hip joint is always a threatening condition, and the outcome of the disease of hip joints with a delayed diagnosis and inadequate treatment becomes the coxarthrosis, hip displacement. Today and yesterday we had a lot of reports devoted to an arthropathy of the dysplastic arthrosis, and this emphasizes the relevance of search of the protection methods for the hip joints, not to allow them to go to the endoprothesis stage in the adults. So the methods of diagnosis of dysplasia of hip joints, clinical symptoms, X-ray graphy, rentgenography, Reimer's migration index sonatometria of hip joints from the neonatality period, which was offered by Rehan Graft for more than 20 years ago. He proved radiological and histological methods that during the first year of life, with the growth of the child, the speed of metathetical division of cells of articular cells is reducing. The speed of division of the cells and speed of the growth of articulum is reducing. So in the age above 1 year has reduced the problem of the identified congenital hip dislocations. Unfortunately, operations for hip dislocation are routine and common in the condition of the National Center for Orthopedic for Maternity and Children. 38 children were operated in 2019. This is a big number. This is not the only clinic in Kazakhstan operating like the 3-4 cases of surgical treatment with intervention to treat the hip dislocation is done in the orthopedic inpatient clinics, which have the right to deal with this technology, and this evidences defects of organization and early diagnosis of pathology of hip joints. We talked about the congenital conditions, and Freeman Miller, who has written a Bible for the orthopedists about acquired failures in formation of the hip joints, he has introduced such a concept as evolution of statical disorders and scenario of development of statical hip dislocation, because each growth in children with a cerebral palsy promotes decentration. 30 to 60% of children with ICP have spastic compound with spastic DLG with the absence of adequate orthopedic support results in lateralization of the femoral head up to development of the displacements, and the children who could walk, they lose this ability to move on their own by the age of 5 to 7 years. According to many literature sources, it is critical when there is a leisure in the bone growth plate in the first 5 years when the bone matrix of the bone is formed, the congruence is formed for the whole life. From diagnosis to treatment, we have discussed the main methods for diagnosis now. Treatment methods, conservative and operative treatment. Conservative is immobilization, physio treatment, drug treatment, vascular disease. What else can we do? How we can protect the hip joints in our little children? Operative treatment. If we see any risks for development of osteonecrosis, disintegration, this will be tonalization of the femur bones, osteotomy, correcting osteotomy, bone-plasty, but this is in any case invalidization of our patients. And until now, we do not have any general rhythm of the events for protection of the hip joint, depending on the total pathological factors of being congenital and acquired. And we believe this situation needs to be reviewed, reconsidered. In addition to the disorders in the supporting and movement apparatus, the patients with static component, now the complicated factor which does not allow the orthopedist to make operation well in time when there is an absolutely all indications. This is trophic disorders of lower extremities, including patients with post-traumatic syndrome, lumbar sacral region. What should these children do? How long will be the delay in the surgery? These problems have not been solved yet. When we can put on legs our children, verticalization, technical means of rehabilitation, these are open discussion questions because the widely used verticalization by orthopedists, which is prescribed for prevention of the necrosis, according to many sources, results in valgization of the femoral bone, disorder in formation of the acetabulum, disorders in the postural autocontrol. And look, in 1966, one of the first studies was made on the influence of verticalization, mineralization of the bone tissues on the bone density. So the goal of our study was analysis of the existing methods for diagnosis and treatment of pathology of hip joints at early stage in children in Kazakhstan, and increase of efficiency of hip joints protection due to application of the innovative conservative technologies of diagnosis and treatment. In our study, there are 3 groups. The first group is newborn children up to 1.5 years, 1,500 kilograms of hip joints were analyzed. Second group, children with neuromuscular pathology who have applied for rehabilitation, 300 patients in the age from 1.5 years to 10 years, and 20 children with the congenital forms of myopathies. The third group is patients with the pertussis disease aged from 3 to 12 years. I will be very fast and very short because I am short of time, but I would like you to understand that this seems to have to be different groups, but the methods of treatment will be interconnected. The third group, 3A groups with septic necrosis diagnosed, which we included for the third time for the PRP intra-articular application, and group 3B who receive standard methods of treatment. Ultrasound of the hip joints in frontal section. Will not stop here. We'll just tell that from the analysis of 105,000 sonograms, the unmatured children have had visualization of all elements of the hip joint was possible up to 1.5 years old in 80% of children. That is a very important thing, and our pole position study, which has been supported by the patent, you can see here distribution of sonograms of hip joints on sonographic types, which allowed us to make this, to obtain the outcomes. The ultrasound window is opened until 14 months in 80%, in 82% of children. During all this time, we can avoid examination using X-ray methods and use ultrasound only. Please look at this picture. This is the study of the hip joint in the children above 1 year old, nosological indications, rheumatoid arthritis, ultrasound investigation has allowed us to see this echo-negative signal, which reflects availability of the pathological exudate. The author of this report has shown all the details and complex of the ultrasound diagnosis in patients with rheumatoid disease. We used the same in children, and now in the second group, please see here, we have used the known scheme of Rainer. For the first time in Kazakhstan, we applied Rainer's index, which is a fundamental index in CPUP program. This is neuro-orthopedic consensus, which is working for more than 10 years in Sweden. We have made analysis of MRI of our children with CP getting rehabilitation in the 2018-2020. I will not go into details of the statistical data. You can see the blue circle on the right-hand side. This is the critical level of neck shaft angle, more than 150 degrees. And here you can see the outcomes in the second group. This analysis has shown that the X-ray of hip joints in children with heavy situations, dysplasia, is done unsystematically, very rarely. For the first time, critical unilateral and bilateral decentrations of hip are found in 22%. Every fourth patient who applied to us, no one knew that there were hip disorders or displacements. It is critical. There is no clear monitoring of decentration of the femoral bone in children with a neuromuscle pathology. It explains the catastrophically high level of undiagnosed congenital hip displacements. So congenital hip displacements now are diagnosed in a better way. They are reducing statistically, and acquired, they are growing in children older than 5 years. The older the child, as Miller said, the growth is higher in our children, the sooner they have progressing disorder in the supporting and movement apparatus, and children who were born without dysplasia, who had healthy hip joints, together with the neuromuscle diseases and other indications, they have acquired these congenital hip displacements. You can see pictures here on the top and down. Yes, please hurry up because we have a lot of reporters. This ultrasound method, it is visualizing the defects of subchondral layer of the bone head. Now we go to the third group of the Perthes disease treatment. You all know what it is. I have not found any study in the world which would reflect the length of the foot with the Perthes disease, and here is the standard development of Perthes disease in our children. And for the first time in our children, we used, in addition, PRP therapy, MKF method to have complex assessment of function of the patients. We use the diagnostic algorithm to take into account the congenital and acquired conditions and additional studies which should be done. You can make a picture. If you have the questions, I will be able to explain them, give your answers on email. And Elizarov said his main principle of work was guiding the power of nature. We have studied biological factors of preparations who affect metabolism of the bone tissue in Russia. 2009, there is a permission to use PRP therapy, and we applied in our children PRP therapy in case of osteonecrosis. This is the patent, the results. I am very fast right now to tell that we do it under the navigation, ultrasound, clinical example. Here you can see in dynamics what is happening to the femur head, how epiphysis is rising and growing based on PRP therapy. Please look at the longitudinal and lateral section of the bone head with osteonecrosis. You can see comparison in 2019 and 2020. What happened to the head? Osteonecrosis is replaced by the matured natural tissue. You can see here, this is the next patient with the Perthes disease. You can see the sections here, and you can see the complete healing treatment of the patient. This is the way he is walking now. Please pay your attention. 2017 and the last year, how well the length has restored completely. This is the next patient who had completely blocked necrosis, which was replaced with a healthy tissue. These are the patients who receive functional treatment and PRP. Please look at them. Of course, this all is accompanied with application of TSR with the correct verticalization in correct TCRs, and the experience of treatment of such patients of MSM syndrome patients for 2-3 years. They were not be able to take for the operation for the bones because the patients had an ulcer. And here you can see traffic ulcer. This is the girl who for 2.5 years was in a chair, wheelchair, and on therapy. She has restored her ability to walk. So this is just to be very fast on the parameters. I have to omit them. The parameters we use to evaluate the efficiency of our method, but we have developed the algorithm. If a child, there is a plastic component, spastic component, apart from PCR, we need to add antispastic therapy. If we have any traffic disorders, we need to add PRP therapy. But finally, we need to do this all for the timely verticalization with the functional apparatus, with the proportions. I'm sorry that I'm so short of time. So the conclusions is early diagnosis. The methods I have told you about them: X rehabilitation, use TCR, antispastic program. If these are children with neuromuscular pathology, and now 100% of newborn, each 4th child of unmature children is born with this spastic component. This is a huge problem now. The orthopedists unfortunately omit this problem, these patients, and the red fish, you can see this is regenerative medicine, PRP therapy, plasma lifting, and this therapy has allowed us to select efficient and conservative protection of TBC depending on the clinical and radial results. So this way you can see these are our children with aseptic necrosis, which had PRP therapy with plasma lifting therapy. We have received the patent for Kazakhstan. Now our work is considered at the Eurasian level to get the Eurasian patent, and we are expecting a grant to save the hip joints. Thank you for your attention. Thank you so much. It is very interesting indeed. I have finished. Thank you so much. I think at the end there will be some questions to you. If there are questions, you can answer them. The next report is from Dr. Nurahmetov Aset Askarovich. This is the doctor of the Center for Traumatology and Orthopedy. The floor is yours.
Dear Presidium and participants of the conference, the topic of my presentation is the use of mesenchymal cells and fibrin hydrogel in the treatment of patients with impaired bone regeneration of non-tubular bones. The false joints of limb-long bones are one of the most common and severe pathologies requiring a detailed study of the effectiveness of surgical treatment. The number of patients with pseudoarthrosis formed after fractures of long bones continues to grow every year and reaches 4.5–16% of cases. A variety of methods of surgical treatment of false joints and defects of long bones of the lower limbs has not yet solved the problem of increasing the regenerative ability of bone structures. So the development and use of effective sparing methods of reparative regeneration, especially at the initial stages of its violation, should be recognized as justified and promising. Methods of treatment of traumatic defects and false joints of non-tubular bones are as follows: formation of bone regenerate by compression and destruction, bone grafting with autograft, transplantation of a free cancellous graft from the crest of iliac vein, plasty with a free vascularized bone graft. The purpose of the study is to study the effectiveness of fibrin hydrogel containing mesenchymal periosteal stem cells and osteoinductive factor BMR2 in the treatment of patients with disorders of reparative regeneration of long tubular bones. Cellular technologies, we managed to implement composite biomaterials, including the stem cells. And in pursuit of new technologies, and within the NTP, in 2015-2016, with the colleagues from the National Biotech Center in Nur-Sultan, we managed to start work in 2015. The bone defect, according to experiments, we used the Velikan rabbits, or giant breed. Animals were kept under vivarium conditions. All experiments with animals were performed with the local ethics committee approval. Creation of the defect was performed on the long tubular bone under general calypsal anesthesia using a surgical oscillator. So the defect was made on the diaphyseal part of the radius for 1 centimeter. After complete bone resection, a broad spectrum antibiotic was administered for 3 days in order to prevent purulent septic complications. The dynamic of bone defect regeneration, the animals were checked every 3, 6, 9 weeks with a radiographic control. Hydrogel was implanted in the bone defect area among animals. we managed to separate 5 groups of animals. First group after the bone defect, they had hydrogel with BMP2 and BMP7. The heparin plus mesenchymal bone marrow, stem cells, and then BMP2 plus BMP7. Next group is heparin gel plus BMP7. The other fourth group is heparin fibrin gel plus BMP2. And next was the control group, for which we've managed the radial bone defect without any allograft. Also, I'd like to note that during observation on the 9th week, we see very good effect of forming bone structure using heparin combined heparin gel and using BMP2 and BMP7. So this picture you can see on the next slide. It's a morphological analysis of the bone defect on the 84th day after GCFH implantation containing BMP2 and BMP7. We see there is a full recovery of the bone structure. The result in this preclinical study, we were able to evaluate the therapeutic efficacy of GCFH containing periosteal MSCs and osteoinductive factor BMP2, which when combined more actively stimulate osteogenesis and accelerate the rate of degeneration of massive bone defects. Don't see my slides. Materials and methods. In 2020, we managed to apply this method and to implement in the clinic by operating our patients. Patients with impaired bone tissue reparative regeneration were divided in 2 groups. First group, patients who were operated on using mesenchymal periosteal stem cells in combination with fibrin hydrogel, 14 patients. The other second group was control, patients who were operated on using traditional method, decortication with bone autoplasty, 14 patients. All patients had impaired bone reparative regeneration of the long tubular bones with an average age of 49 years. According to the segments that were operated on tubular bones, they were distributed as follows: false joint of the femur, forearm bone, false joint, and tibia false joint. Surgical treatment of patients who were operated with traditional method was performed as follows: skin and soft tissues incision, skeletonization along the false joint of the affected segment, refreshing of fragment ends, decortication of the spruce cone type, bone autoplasty, previously taken from the crest of the iliac bone. You can observe this on this image. The bone is in a lateral position. Applying mesenchymal cells and fibrin hydrogel on patients. This method of treatment is basic, where we select patients that have reparative regeneration function impaired First, we take the transplantant. We make this under local anesthesia. It's 2 centimeters from the middle third of the fibia. Then we transport this to the lab, and we work here together with the Biotechnology Center. We make delivery to the Biotechnology Center for further cells growth. Second stage is the operation procedure, where a patient is being hospitalized in the department, and there is a mini incision of the skin and the soft tissue, and the false joint area is decorticated. Fibrosis tissue are removed, and fibrin hydrogel plus growth factor are introduced into the defect area, and then this wound is stitched, sutured. So we do X-ray every 2 months to assess the therapeutic efficacy. We are short for time, so I'd like to show you a clinical case after cell transplantation. Patient 28 years old, false joint of the lower third of the femur, metal reconstruction. Surgery was performed autologous bone transplantation with osteosynthesis. However, the autologous bone leased after some time without giving a positive outcome, and the patient was repeatedly operated using biocomposite material with periosteal MSCs and VMP2. Dynamic observation. After implantation of the biocomposite material, there were no side effects. Acceleration of bone regeneration was noticeable by the 5th month, as you can see this on this image. Next clinical case, patient 28 years old, mixed contracture of the left knee joint, condition after osteosynthesis. Surgery was performed, decortication of the false joint of the lower third of the left femur, supplementation with a static screw, transplantation of periosteal stem cells, and fibrin hydrogel. In dynamic, we notice remodeling and satisfactory bone regeneration. In dynamic, 6 months post-operation, there is integration of biocomposite material into the area of bone tissue regeneration. And a patient a month ago, we managed to remove the metallic structure. Third patient, pseudoarthrosis of the middle third of the left ulna, a condition after osteosynthesis with a bone plate. First image prior to stem cells transplantation, second after 2 months post-operative, and third image within 6 months post-operative. There is full recovery. Thus, in this study, we were able to evaluate the therapeutic efficacy of fibrin hydrogel containing periosteal MSCs and osteoinductive factor BMP2, which in combined application more effectively stimulate osteogenesis and accelerate the rate of regeneration of massive bone defects. We believe that the results obtained in this work are of fundamental and applied importance for regenerative medicine, in particular for the repair of complex and non-healing fractures. Thank you for your attention. Thank you, Asset Askarovich. Next is Dr. Saikpaeva Evgenia from the imaging department. The floor is yours.
Good evening, dear colleagues.
Она видит, но она повторяется.
Нет, в смысле, лайв. Все, давайте. 3, 2, 1.
Добрый вечер, уважаемые
Good
коллеги.
evening, dear colleagues. My speech is about ultrasound diagnosis of median nerve compression syndrome in the carpal canal. Carpal tunnel syndrome is a neurological disease manifested by prolonged pain and numbness in the fingers of the hand. It is related to the tunnel neuropathy. The cause of the disease is compression of the median nerve between the bones, the transverse carpal ligament, and the tendons of the muscle of the wrist. Speaking about frequency and prevalence, we need to mention that compression neuropathies make up a significant part of diseases of the peripheral nervous system. According to various sources, their frequency is 48 to 52%. But speaking about the structure, carpal tunnel syndrome accounts for up to 9% of all the neuropathies. About 45% of the working age population, age 40 to 60, suffers from the carpal tunnel syndrome. The peculiarity of compression neuropathies is that they have a progressive course, resistant to treatment and tendency to relapse. Etiological factors, heredity such as transverse ligament thickness, complexion, activities, trauma and its consequences, formation from the cavity of joints, systematic and endocrine diseases, pregnancy. Pathogenesis includes impaired blood supply and ischemia. Symptoms of the median nerve damage are numerous, but we can talk about the main ones: pain, impaired flexion, and numbness. In order to diagnose this disease, there are different types of diagnosis, and I would like to draw attention to the ultrasound diagnostic, which is a gold standard of the peripheral nerve system. According to foreign and domestic authors, ultrasound scanning can be considered the main methods for studying a nerve. More precisely, the study is considered the gold standards of visualization for studying peripheral nerves, while clinical and electrophysiological studies do not provide morphological information about the state of the damaged nerve. The specificity of the method, according to the literature, is 80 to 100%. The sensitivity is 89 to 97%. Previous slide showed you that MRI specificity is 30 to 38% only, or up to 38%. So of course, we see that the ultrasound has a greater advantage. In our country, unfortunately, the diagnosis of the carpal tunnel syndrome is not well developed, especially at the outpatient stage, which is due to the low awareness of specialists about the methods of diagnosis of this disease. Most experts assign too great of a role to degenerative changes in the cervical spine and the formation of damage to the peripheral nervous system due to the lack of timely diagnosis and adequate pathogenetic treatment. Now, speaking about the devices, of course, there are certain requirements. Since the nerve is quite small and they're located in a particular way, we need to use a longitudinal device. In our clinical ultrasound examination of peripheral nerve trunks has been carried out since 2012. And we can talk about the research methodology. Scanning is carried out in the longitudinal and transverse axis. The cross-sectional area is measured up to the entrance to the canal tunnel. Next, we carry out the assessment of the nerve following the criteria that you see on the slide. In order to understand the ultrasound image, I suggest we are reminded of a normal anatomy of the peripheral nerves. So we are interested at the epineuron, perineuron, and the bundles themselves. We can also see the longitudinal and transverse axis. Again, you can see the normal heterogeneous structure. And all of that is put together in the bundle and covered by the epinegram. This slide gives us a better picture of the normal ultrasound imaging of the nervous stem. Now we're showing you the structure that is similar to the electric cable. Now you see also the transverse axis. These are bundles again. And they also look like the honeypot. Again, a normal image of a median nerve. In our clinical ultrasound examination of peripheral nerve trunks has been carried out since 2012. We have a lot of patients with this pathology. Between January and May 2021, we had 42 patients that were examined. And in all patients that were examined, the mean ultrasound science identified the presence of the carpal tunnel syndromes. The syndromes include uneven nerve thickness before entering the carpal tunnel in the canal and the exit from the tunnel, impaired differentiation of normal nerve fiber, disappearance or smoothing of the fascicular structure, decreased nerve echogeneity. This slide demonstrates quite well all the compression syndrome, which again includes uneven. One second, let me switch on the slide. Well, anyways, I want to show you uneven nerve thickness, decreased nerve echogenicity, and also impaired differentiation of these bundles or trunks. We no longer see them. And of course, we see enhanced perineural vascularization. Next, we see compression syndrome in the carpal tunnel. We see longitudinal and transversal scans where you see that the surface is extended of the carpal channel. Carpal tunnel ultrasound gives us the following information. When conducting ultrasound, it is also possible to accurately diagnose or exclude the developments of secondary tunnel syndromes that have developed as a result of flexor tendinogenitis. This can fundamentally change the tactics of patient management, and on the basis of the ultrasound data, either conservative or surgical treatment can be provided. The value of the ultrasound examination is to establish the exact location of the nerve compression site, which is important for planning surgical treatment. And let me go over the main advantages of the ultrasound and remind you that in comparison to other visualization methods, it has a rather high level of visualization of differentiation of the neural trunk as well as the anatomical and morphological structure. When we carry out CMG, we only see anatomical structure, but here we see both anatomical and morphological structure. Ultrasound is rather easy to carry out and it's easy to interpret data. It has a low cost and it's possible to have repeated studies, and there are no limits to the people with different metallic structures or the pacemakers, etc. And there is no irradiation, which is also an important factor. Besides that, there are some limits to the ultrasound diagnosis. First of all, we cannot receive the image of the nerval trunks in the places where it's going under the bone structures. A difficult visualization in case of adhesions and in case of scars, they can maybe distort the image, and lower quality in patients with higher BMI. In this case, we use a different type of device. And of course, ultrasound hugely depends on the technician. That's all I have. Thank you for your attention. Thank you very much, Evgenia Nikolaevna. The next speaker is Doctrine of Treatment of Patients with Large Joint Osteoarthritis. doctor, professor, Department of Orthopedics and Traumatology, Mr. Minasov. Please, the floor is yours. We can't hear you yet.
Can you hear me now? Okay, dear friends, dear colleagues, I am pleased to meet you and to discuss with you the level of scientific community has grown significantly. It's amazing. I heard the reports and I'm admiring that the reports correspond to the sixth technological level. Ansar Mahmoud and other colleagues talked about the modern biotechnology. Nur Mahmetov, Aset Atskerovich talked about the treatment technology. We live in the conditions of evolution, transition of the medicine. The last year I am speaking at the sixth forum, Eurasian Federal International, and we talk about the sixth technological level of the quantum revolution, because the medicine has revolutionary changes and we cannot stay back from these tendencies of the society. And it is impossible. We are trying to catch the last wagon car of the train. These are the trends from which the world global community is evaluating. 10 years ago, we didn't know what is the cell mode. This is the future. This is epoch of the cognitive technologies, inclusion into the production of the human consciousness. Author of Joris, inventor of the semiconductor, all the modern gadgets, telephones, and electronics is working with the semiconductors. He received the Nobel Prize for development of these semiconductors, but the era of semiconductors is outdating now. We have some conditions in our medical activity. We are using the international list of death, which is developing. We do not quite often think about imperfectness of this instrument. What about the people who are not sick? After the Second World War, in the orthopedic, there was a cardiac revolution, change in the doctrines of treatment, and three great scientists, Müller, Elizarov, and Kitcher, these are the people who suggested to solve the problem of broken bones. Each of them in their own way have solved the problem. They are geniuses of the orthopedy. And what about the function with the joints? So the global community for 20 years, starting from 1980, for 20 years, they have been discussing how to classify the person with disorder of the functions with a problem in joints. And in 2003, the Russian version was published, which is called International Classification of Functioning. It is describing different types of movement of the human body, all of them. And thanks to this classification, we started to understand the health. The global community has started to understand in a different way how to treat the patients in order to integrate the initial social communities. Sometimes we joke. The famous Russian Professor Sergei Vasilyevich Sergeyev, he is a classic of orthopedic. He is called the great science, known clinicist, virtuous orthopedic surgeon, innovator, pedagogic teacher, methodist, doctrinal. He was asking if medical rehabilitation is a goal or it is a means of reaching the goal, and not many doctors will be able to answer this question. The norm of orthopedy is the external immobilization of the joints. Sinister said the reason for immobilization of the joint was never determined before. This is the dramatic history of joint injury treatment. Salter believed, for example, that the joints are fixed because it is accessible and it's possible. It was in 2007 when I was reviewing the literature. The only person who has written the resting state of the joint is the creator, and it can never damage or harm. That was Salter, the great British orthopedic surgeon. He is guilty in deformation of the joints. The joints should never be fixed. We have understood this after the First World War, when the joints were fixed. All these patients died because of generalization of the infection of sepsis. In 1989, an article was published, Clinical Orthopedy. This is a biological concept of continuous passive motion, 18 years experience of using the apparatus for passive motions. And it turned out that it is a more favorable condition. Then Williams appeared in 1975, and they made healing of the wound, gun wound, immobilization, active regime, and permanent passive movement. In 4 weeks, in 80% cases, the cracks were healed. The authors believe that the first week post-operative is the most important. The shown with the co-authors in the experiment on 40 joints has proven the importance of the synovial membrane. You can see here the cracks in the rats. This is opening of the lacunas under the membrane over the plate after the normal traditional arthrotomy. Any intervention in the synovial joint results in the destruction of the synovial medium. Normal trophism of the elements of the synovial medium is possible in the motion condition. Look, this reminds these feathers structure. The tissue is a crystal, and this is the basis and understanding of the health of the human beings. I must show you example of Bauer, the founder of theoretical biology in the USSR in 1835. He has established the theoretical biology, science of the laws of motions of the organized living matter. Arseny Vasilievich Rusakov, head of the Cathedra of the Forensic Medicine of the first Moscow Institute named after Sechin, he has devoted his activity to the disease of the bone system. He described osteospasm and other diseases and pathologies. Every surgeon who is doing arthrotomy of the knee joint, they remember about Rusakov because they talk about loosening of the tube pipe bone. Mechanostats, mechanocytes, chondrocytes, they are also mechanostats. That is why we should consider any patient in terms of postnatal ontogenesis, and based on their positioning on the scale on kinematic balance with the precision of 90%, the diagnosis can be determined for this patient. Tomorrow, the medicine is based on 4P: predictive, preventive, personalized, and participatory. Without participation of the patient, he cannot be treated. So there is total and micro research in the modern medicine. We have thermography, DEX, radioisotope studies, even low dose X-ray examination. You can examine the whole body. So the modern sonograms, they are bone sonography, they become outdated. biometric allows us to determine the motion balance. That is why in Bashkortostan we develop a project of the health passport of the human being to position and get parameters of functioning of the person who has not come to visit the doctor and he is not healthy at all. He is examined on the vasotones plantotoman, and we get parameters, main parameters of his health, which is a phase portrait. Microscopy allows us to determine the microstructure, efficiency of the adductors, component of kinematic balance, all the scales of functioning, level of pain, efficiency, functional efficiency, they are included into this concept of the health parameters. So we have created an integrative program for the health indicators on the total coordination of all indicators. We have created that for the rehabilitation record for each patient in the digitalized manner to record digitally all our surgical activities, functional activities to show efficiency of our influence on the health of the people. So rehabilitation events are well known, well done operation on the, but the patient complains about the pains preserved. So we have identified here the cracks. You can see that the pelvic component is not stable. After 1 year after the operation, we understand the implantation of the huge mass with instability causes alteration of the inflammation. We started to guess that there is an inflation. We put in place the spacer in 4 months and made revision arthroplasty. In 4 months, this is the functional condition. Nowadays, any orthopedist who is making any minor arthroplastic interventions in our patients, they have their own list of patients with complications. This patient, you can see here, she's 62 years old. She had 8 revisions. The first surgery was made in 1981 by the main traumatologist, Mr. Kuzmenko, Professor Kuzmenko, osteotomy, surgery without solder and so on. And finally, this patient, having passed the whole range of arthroplasty, has reached us. We have made intervention. We use modern methods, osteography, made revision arthroplasty, another one. So the patient who had the replacement of hip for the artificial one, he is ready for the next operation for its replacement every time, or improving the artificial joint. When we started to learn the reasons for bad efficiency of these implants, the thing is that there is a spectrum of the concomitant disease which predetermine development of the early and later complications. That is why the passport of health allows us to see the person in more details with the rehabilitation prognosis. So this sixth rhinological mode is characterized by the atomic modular construction. What we have heard from the reports of our esteemed professors when the special construction is offered, these are the modern realities of the preventive reconstructive orthopedy and medicine as a whole. The great Elizarov, who was mentioned today, I was happy to hear his name again and again. We have celebrated 100 years from the birth and 70 years from the method. So he is great not only because he has offered treatment of bone, he has offered functional treatment. He says, and construction for the joints, the load, as mentioned, has a piezo effect. All the modern doctrines of treatment, they provide for a function. The special apparatus which has a special structure, they are developed everywhere, designed everywhere. They use special mechanism which allow using these technologies in a safe mode, and kinematics is used as a factor for treatment. Low invasive intervention into joints is very modern nowadays. Globally, they have low invasive effect. Michael Strobel, volume 1, page 52. The reserve of fluid should correspond to the quantity of the arthroscopic operations made. In average, for the normal arthroscopic resection of meniscus, 2 to 5 liters of fluid is enough. For arthroscopic reconstruction, you will need 10 to 15 liters. It is always very sensible and hyaluron, which will ensure realization of genealogical demands. This is a thin, fine structure. When we washed out with the normal saline, it is washed out improperly. We have done a study. We took as a hyaluronic acid of the Russian production, Salofarm, and we used 1.5% of hyaluronic acid. You know that the basis for this implant, liquid implant, there is a molecular weight 3 to 3.5 microdaltons, maximum approximate to the meanings of the medium molecular mass of the polymer, identical to the solid pH, with the therapeutic action up to 1 year. And when we made the subsequent studies, we understood that indeed on our orthopedic canons, we have improvements on first injections. Periarthritis is going down, motions is increasing, improving, and pain scale is reducing. The liquid implants are intra-articular injection. They are more efficient in terms of all parameters of quality of life. We have received better results. Each of you, when you have a patient with periarthritis and distal swelling, there is no doctrine for treatment there for them. But when we inject liquid fluid into the knee, we block the distal swelling, the lymphatic drainage is launched, and the quality of life is better. And when we started assessing the hyaluronic acids, we have 10 of them in the market. In terms of market and efficiency, what is the best one? Philomatron, who took 40% of the market, is going down. Why? Because it is not satisfactory to the patients and to the doctors. Armaviscon is going up and takes almost 40% in the market, and there are about 10 preparations like this. There are different theories for promotion and application, but if the company is developing a preparation without participation of the practicing doctors, so the method as a medical technology will fail. And we are oriented at the Russian market. We can add magnet or hydromethyl sulfate not only to ensure restoration of the hydrophil polarizing indicators, but to improve the regeneration. To use the preparation to be introduced periarticular, intra-articular way. So there are special surgeons with special needles. We can ensure precise injection of this substance into the ligaments and the muscles. This is the most promising direction in the outpatient orthopedy, and the competition is high. This is good because we have a good choice. When we made study in our university and checked how these substances behave inside of the cartilage, in the joint, they have different behaviors. The needle which comes into the joint, washing out, and this is the armaviscon introduction injection. It is disseminating in an equal way. We took another preparation, and when we started injecting it, based on the descriptive model, we were surprised that at the time of injection, there were crystals which did not dissolve, some elements which do not dissolve. They look like dirty because 40% of price of any drug formula is its cleaning, its purification. That is why, dear orthopedists, when we inject something, we need to understand what kind of material we are dealing with and an equal distribution of this substance. They are working based on different mechanisms. There is no smooth distribution of this substance in the synovial fluid. I can show you tens of these, dozens of these films, but when we compare 10 different preparations, believe we do have an idea of the range of efficiency of every of the systems. Please be careful because these preparations have different degrees of purity, because if the manufacturer is saving money on purifying, this is a trouble. In fact, clinical examples, when a patient comes with a complaint on the knee joint, he has some problems with this symmetricity, and when we make arthroplastics, we have a risk that the patient may have decompensation. And at the end of my presentation, I would like to repeat the joke from Mr. Sergey. Medical rehabilitation is the means. No, the medical rehabilitation is the goal. It allows us to provide adequate social, professional, household, and even sexual reintegration. Thank you for your attention. Thank you, Vladimir Ilyich. The next report is from Professor, Head of the Department of Traumatology in Istanbul, Turkey, Hayati Durmaz. The floor is yours.
Merhaba. My chairman and audience. My topic, treatment strategies of distal biceps tendon ruptures. Firstly, we should talk about demographic data. Incidence 1.2 per 100,000 patients. 56% dominant extremity, smokers, males, anabolic steroid use. Anatomy, the aponeuros attached to the ulna, while the biceps tendon attached to the tuberculous radii. Therefore, tuberous radii variation are associated with ruptures. Etiology, if it necessary to mention the etiology. Bony prominence, irregularity of the distal tuberosity of bursitis, mechanical impingement, the presence of a watershed area of the tendon are related to the ruptures. Presentation, patients apply to the emergency room after the trauma, and their main complaint is pain, in addition to a painful pop as the elbow is eccentrically loaded from flexion to extension. Pain and weakness, medial ecchymosis, loss of more supination than flexion strength. Hook test is positive. Radiologic imaging. Generally MRI, in addition to ultrasonography, can recently. We classify the ruptures. Distal biceps tendon ruptures classify acute, partial and complete, chronic, intact, and torn aponeurosis. Treatment options depend on whether the tear is complete or partial. Partial, non-operative management be attempt with focus on stretching and strengthening. Complete, surgical, anatomical repair to restore supination and flexion. Surgical repair options, one incision technique, high incidence of the radial nerve injury, less chance to heterotic ossification and synostosis, most common injury, lateral antebrachial cubital nerve damage. One incision technique. Fixation options, endobutton, strangler in radial tuberosity, interference screw. The purpose of strangler is to provide tenodesis on the decorated area. Two stranglers are often used. Interference screw, tenodesis the stump tendon to the bone tunnel is aimed with the directed of a screw. In the endobutton method, a stable fixation and maximum tenodesis effect are aimed with the button passed through the bone tunnel. Surgical repair options, dual incision technique. The stump tendon is fixed in the bone tunnel using two different incisions. Less radial nerve injury, more heterotic ossification and synostosis, less lateral antebrachial cutaneous nerve damage. In the biomedical study, where 4 different detection methods were encountered. 63 fresh frozen cadaver elbow, randomized treatment option, cyclic loading was planning. Cyclic loading was then performed from 0 to 90 degrees at 0.5 hertz for 3,600 cycles with a 50 N load. Also, the highest load to failure ways demonstrated with the endobutton technique. Chronic ruptures, more than 4 weeks history. Treatment options, reattachment to brachialis, non-anatomical. Anatomical reattachment, interposition graft, flexor carpi radialis, Achilles tendon, semitendinosus. Case 51 years old male, acute trauma, right side. you can see the clinical presentation of the patient. His hook test was positive. Also, you can see the clinical presentation of the patients. His hook test. Also, you can see the MRI images. We prefer the endometrium method with one incision, this case. Final X-rays, you can see tunnel and endobottom. Second case, 45 years old male, 5 months history. With a diagnosis of chronic ruptures, you can see the reverse Popeye sign on the right arm. Preoperative photo and perioperative photo. We performed the reconstruction using a semitendinosus autograft with a double incision. The graft was passed through a bone tunnel in the radius. Reconstruction of semitendinosus tendon. Thank you for your attention.
Thank you very much, distinguished professor, for a very interesting presentation. I wish you all the best and please come to Kazakhstan. And the next speech from Novosibirsk, from the National Research Institute of Traumatology and Epidemiology. We have a group of authors. The speaker is Anastasieva Evgenia Andreevna. Please, the floor is yours.
Hello, dear colleagues. The topic is in vitro assessment of cell viability of the stromal and vascular fraction of adipose tissue on the allogenic bone matrix. As to orthobiology procedures, in recent decades, with the development of regenerative medicine, the method were introduced using stem and progenitor cells, growth factors. Their use was being substituted by many authors and many countries, such as South Korea and Japan. They are quite popular methodologies. Talking about stromal vascular fraction, prior to processing, this fraction has a lot of lipocytes and fat and oil, and then after main fraction processing, there are a little bit pericytes, adipocytes, stromal cells of fat tissue, pre-adipocytes, endothelial and progenitor cells, hematopoietic cells, monocytes, macrophages, as well as extracellular matrix are preserved. The goal of our research is to assess the viability of the stromal and vascular adipose tissues fraction in an in vitro experiment on various types of bone matrices, such as compact and spongy and deproteinized and bony matrix. The materials were the mesenchymal stem cells, fat tissue derived, which were isolated by obtaining a stromal vascular fraction using standard methodology. 24 samples of native and deproteinized compact and spongy bone tissue were used as carrier matrices, which were subjected to medical processing and according to the preparation procedure to assess the mesenchymal viability. We used citation 5 fluorescent imager and fluorochrome and calcine. As to the results, the experiment revealed that colonization of bone matrices goes uniform both for compact and spongy deproteinized and native bone matrices. And the cell adhesion density indicators and cell distribution show similar results. At the first view on the obtained results, to assess which matrix is preferred was quite difficult. So you see on the top compact native and at the bottom spongy and deproteinized bone matrix. And comparing two matrices visually, it's quite difficult to distinguish what we are getting. But with a more detailed calculation, a deeper degree of purification of bone matrix from organic components, deproteinized bony matrix leads to proliferation of cellular elements and more pronounced adhesion, as indirectly evidenced by the increased size of cell nuclei. Also, at deproteinized bone matrix, the spongy structure, 25–30% indices were better. The cells adhere not only on the surface, but also in the deep structures of the samples of bony, spongy bone material. So studying the indices of the spread on the surface, the spongy matrix on the left, deproteinized, the cell nuclei are bigger because they are using the space from which the organic elements have emerged, and the viability of such cells was higher. On the native bone matrix, the cells were on the surface and did not penetrate deeply. For us, it was interesting whether those cells are live, and we assessed viability using fluorochrome. By painting those cells, we found out that those cells are alive, and so we identified that the deep processing level determines the absence of cytotoxicity, the deep degree of purification. And the results showed that this is possible on any bone tissue. They are more preferred on deproteinized, spongy bone matrices. Thank you for your attention. Thank you, Evgenia Andreevna. Next is the final presentation, also from Novosibirsk. The Institute of Traumatology and Orthopedics. Medvedchikov Artyom is the presenter.
Dear colleagues, I have a report on the surgical treatment of patients with rupture of distal biceps brachii tendon, a comparative assessment of the effectiveness and safety of fixation methods, aspects of sportsman rehabilitation, and experience of 32 patients. Traumatism of this localization is a quite rare event or incident. This is 1.2 for 100,000 people. Rupture of distal biceps brachii tendon is observed mostly in the male population, 30 to 50 years old. There are two bundles segregated of short and long head of biceps. Injury of any head is partial. Injury of both bundle is avulsion. Injury, the function of the biceps is supination and flexion at the same time. According to the literature, injury of the biceps in most cases is represented by the rupture of the proximal tendon. In 3%, we have a distal tendon ligature, and short head is 1%. Short head rupture. So distal tendon of biceps brachii is affixed to one of the tuberosity of the proximal 1/3 of diaphysis of the radial bone. Etiology and pathogenesis of the damage are still not clear. The number of the general accepted theories describe two commonly accepted depolarization, hypopolarization of this zone and mechanic traumatism. About the first theory, it is proved by the computer tomography in the scoping mode, the narrowing of the distance of the proximal radial space by 48%, then in supination position, in addition in the position of the maximum pronation of the forearm, distal bicep brachii tendon rupture occurs in 85% without injury of the surrounding muscles. Thus, tropic disorders as a result of hypervascularization and hypergeneration, oxygenation of the tendon tissues can cause subsequent degenerative fracture. The factors of risks are smoking, taking anabolic steroids, corticosteroids, physical labor, some types of sports, fracture of the proximal 1/3 of diaphysis of the radial and elbow bone. The mechanical injury, the mechanism of damage is represented by the ascending action of the tensile force with the elbow joint bent of 90 degrees, experiencing an action effect. At the same time, if the damage of the long head occurs mainly as a result of the action of indirect injury, then the ruptures of the distal tendon are quite common with the direct impact of the traumatic factor. On this slide, you can see the algorithm of diagnostic events in the patient with the distal tendon injury, starting from analysis, collection, specific tests, O'Driscoll Rowland test, diagnosis, routine type of diagnosis like ultrasound diagnosis, MRI. Then there are special methods of diagnosis like electroneuromegraphy if there are signs of sensomotoric injuries of peripheral neural system, MRI, multi-layer CT, MRI of the elbow joint with 3D reconstruction. The diagnosis of injuries is divided into two types, two tests. They are very indicative and none will have difficulties in fulfillment thereof. About the radiologization, we should keep in mind the radiation X-ray of the elbow joint of the both extremities and two projections, ultrasound of soft tissues of the elbow joint, comparative radiography of the injured and contralateral elbow joints in two standard projections show the expansion of the diastasis between the radius and ulna in the area of biceps tuberosity and signs of hyperoscillation in case of chronic damage of the soft tissue in this area, marginal avulsion of this tuberosity contact in the case of hemorrhagic trauma. On this slide, you can see the same anatomic area in 3 different studies, MRI, ultrasound, X-ray, and you can see the difference, significant difference in the visualization. Talking of them, selecting the methods for treatment, the group of specialists representing this report, they provide the algorithm for selecting the method of treatment. The patients may be divided into 3 groups: patients with the acute trauma, with also trauma, where we suggest conservative treatment, and evasive injury, where surgical treatment with the low invasive approach is suggested. If there is a patient with a delayed trauma more than 6 weeks, the low invasive surgery is offered. There is the 3rd group of patient criteria group, the patients with the injured and pre-operated elbow joint with a low invasive method. We suggest the method surgical treatment in a low invasive augmentation way with fixation of the cortical button, which has a patent from our side. So conservative treatment compared to the operative treatment, conservative treatment methods such as orthopedic regimen, restriction of rotation, flexion, extension, strength test, 6 weeks, immobilization, and inflammatory drugs. The surgical treatment has more and more attention in connection with development of the low invasive treatment and fixation aspects. So the indications for surgery, these are ruptures of the bicep tendons. There's a positive or scroll test, round test, MRI picture of the bicep brachii avulsion, restriction of supination flexion, the presence of persistent pain syndrome, unsatisfactory results of conservative treatment. There is a classical and open access. This is the choice of the surgeons, but the observations are made since 1962. Each of the approaches has its benefits and disadvantages. It may result to the heteroscopic defects, and there can be the risk of contact with the macromassive structures. So methods of fixation of the tendon may be divided into 2: anatomic, non-anatomic fixation, anatomic transversal sutures, anchor fixation, and intracanal fixation with cortical bottom. Non-anatomical options of reconstruction are not frequently used for fixation of the biceps to the shoulder, to the brachii. If we talk about the reliability of any fixation, the studies dated 2014 in the US have shown the materials about the soundness of intercanal fixation as related with the button compared to the other methods, internal methods. So the specialists representing this report believe the reference technique of a low invasive Boyd-Anderson in combination with the Bain fixation method, when different diametral canals are formed in the radial bone, 3 millimeters, with suture of the distal tendon and putting the loops through the cortical button as an option. And this can be used for the intercanal fixation. On this slide, you can see the sequence of the method fulfillment with the laying down the patient with the approach and control. Analysis in 2014-2020 has shown preferences of the specialists in terms of cortical fixation. More rarely, they use transarterial suture methods, as we see. Ulnar neuropathy was received contracture, came across, the patients and the surgeons came across. The gender modality needs to be emphasized, actually absence thereof, because all the patients were male. The patients applied not in the acute period, but after more than 6 weeks, 5 patients, we had open approach, and 24 patients had low invasive technique, Boyd-Anderson. by the type of implant and technology. The cortical button was used and interferent screw was used. 10% of the patients applied from contralateral extremity, writing with the right hand. Hospitalization took about 3 days. The short-term result in 29 patients were assessed within 1 year. Long-term results were assessed within 3 years. Unsatisfactory result was identified in 2 patients, one of whom had preserved contracture and pain syndrome. In one case, in patient, there was the neurography, which detected radiolopathy, which required intervention, and 27 patients had no pain syndromes, and they could come back to their everyday normal way of living and work. Results of treatment: none of the patients had any inflammatory processes on the surface or deep inside. The length of incapacity and an inability to work made up 33. For physically active and sportsmen, 45 days. After 3 years, we made diagnostic methods for determination of reinsertion and degenerative component of distal biceps brachii tendon using the scale of ASIS, dash, vision analog scale, ultrasound diagnosis, if there is a metal implant, and MRI. Together with our rehabilitation protocol, you can see it in the recently published article. Briefly to say, it provides for wearing sling bandage for 2 weeks, fixation first class for the first week. The volume of motion was dosed during the first 2 weeks, 45 to 100 degrees, 30 to 35 degrees on the 3rd week. And 15 to 130 degrees for flexion of the 6th week. You can see different types of fixation for kinesiotherapy, starting from the 2nd week, plus mechanotherapy starting from the 3rd week. The group of the started patients with the cortical and combined method of reinsection, 6 patients had good results in 6 weeks, 2 patients in 8 weeks. Patients with the anchor fixations had good results in 12 to 16 weeks. In the group of sports rehabilitation required 24 to 26 weeks. What the results of this report? This is the use of modified method of pain, reduction of the swelling and pain syndrome is reduced, early mobilization of anatomic zone due to the tough fixation of the tendon was received. The rehabilitation has forced 2 times. The outcome of the surgical treatment using the Boyd-Anderson axis was more efficient, 2.5 times. If compared to Dobby axis, the connection, the relation between the period of complete restoration and age of the patient and temporary time distance between the trauma and operative iteration were not significant. So the complete restoration and time and age was not significant, as well as relation between time period and specialized assistance provision. There is also the surgical treatment of avulsion. Thank you to the speaker. Dear ladies and gentlemen, today we have finished this session. Although we had some technical problems at the beginning, all the reports were presented. I think we had a very fruitful day. I would like to ask if you have any questions to the reporters or to anyone. If you want to have some comments or say something, the floor is yours. If we have no question, I would like to say thank you to all the participants and to all the speakers today for the wonderful material you have presented, very interesting reports and presentations. Please connect tomorrow. We do not say you goodbye yet. I hope to see you at the other sessions. Have a nice evening. Have a nice day. Bye.